Colleagues, we're ready to start. Has somebody started? Has anybody started? Your microphones are off. Tech support, please. Technical support, so your microphones are on. Please mute your own microphones. We are on air. Let's go. Dear colleagues, dear friends, on behalf of the Mental Health Union and on behalf of myself personally, I would like to congratulate you on the Mental Health Day that's upcoming, and I would like to announce the third Congress on Mental Health Meeting the Needs of the 21st Century open. This Congress will be devoted to matters of mental health of teens and children. I would like to say a huge thank you to all of the members of the Russian Organizational Committee, our International Organization Committee, and our Research Committee as well. I'm particularly grateful to our co-organizers, the International Association on the Perfection of Programs in the field of mental health, and personally its president and head of the International Organization Committee of the Congress, Professor Norman Sartorius. The World Psychiatric Organization and its president, Afzal Shaved, and the General Secretary, Petr Viktorovich Morozov. The World Association of Social Psychiatry and its president, Rashid Benegadi. The International Association of Children's and Teenage Psychiatry and Allied Professions and its ex-president, Bruno Falisari. The International Association of Applied Psychology and its president, Christina Levy. The International Union of Psychotherapy and its president, Alfred Britt. The International College of Personally Directed Medicine and Juan Medici, its president, the Russian Association of Psychiatrists and Nikolai Grigoriev, the president, the Russian Psychological Society, and personally its president, Yuri Zinchenko. The All-Russian Psychotherapeutic League and Makarov Viktor Viktorovich, its president. I'm particularly grateful to the representative of the World Health Organization in Russia. Our Congress is going to be supported by the Ministry of the Health and Well-being of the Russian Federation, the Ministry of Education of the Russian Federation, the Ministry of Education and Science of the Russian Federation, the Ministry of Labor and Social Protection of the Russian Federation, the Ministry of Sport of the Russian Federation, and the Ministry of Culture of the Russian Federation. Our partners in this long-standing journey include the National Medical Research Center of Psychiatry and Neurology, named after Bekhterev, the Faculty of Psychology of the Moscow Lomonosov State University, the National Medical State University of Narcology, named after Serbsky, the Scientific Center of Psychic Health, the Moscow Pedagogical University, the Moscow State Legal University, named after Kudafin, the Scientific Practical Center for Youth and Teens, named after Sukharev of the Department of Health of Moscow, the Federation of Psychologists in Education, the Russian Psychotherapeutic Association, the Fund for the Support of Children that have found themselves in harsh living conditions, the Neuropsychological Applied Society, the Research of Children's Neuropsychology, named after Luria, the Scientific and Practical Practical Center, named after Solovyov, the Research and Practical Center of Children's Psychology, the Pedagogical Academy of Preschool Education. Participants of today's Congress will include over 4,000 participants. I would like to thank you all for the interest in the topic that we're going to be discussing over the next 2 days, and I hope we all have a constructive set of sessions, and it's my great pleasure to pass the floor for a welcome speech to the Honorary President of our International Organizational Committee, Professor Norman Sartorius. Norman, the floor is yours. Norman, unfortunately, we can't hear you because your microphone is off. Go. Thank you so much, Norman Sartorius. And now I'll pass the floor for a welcome remark to the Director of the Department of State Policy in the field of child right protection of the Ministry of Enlightenment and the Russian Federation, Larissa Pavlovna Falkovskaya. Larissa. Good day, good morning, dear colleagues. On behalf of the Ministry of Education of the Russian Federation, I would like to welcome you at the opening of our Congress dedicated to mental health and the future of our children. Matters of mental health of children and teens, the key challenges and the solutions to these challenges, everything that has to do with the development of the psychological and psychiatric support for children is one of the key activities of the Department of the State Policy in the field of protecting the rights of children. The presidents of the Russian Federation, the government of the Russian Federation have passed a number of state decisions, resolutions that have to do with continuing our efforts in developing psychiatric services within the educational system, and we will continue in this endeavor to support psychological support for kids, teens, youth, to develop psychological services. Of course, this can only be done jointly. It has to be a collaboration between the ministries and all of the other stakeholders. We hope that our Congress today, tomorrow, and the day after tomorrow has a constructive exchange, new creative answers to the challenges that we're now faced with, and that reality is testing our professionalism. We hope we're going to be able to pass these challenges, and I wish everybody health and well-being. Thank you very much. Natalia, let me please read out the welcome speech on behalf of the Ministry of Health of the Russian Federation. Dear friends, on behalf of the Ministry of Health of the Russian Federation, I would like to welcome the participants and guests of the Third Congress on Mental Health, meeting the needs of the 21st century youth, mental health, well-being. Mental health is an important component of human health and well-being throughout their entire life. It's hard to overestimate the importance of harmonious mental health developed in childhood and in our adolescence. The complex process of personality development, intellectual and physical overloads, experience of interacting with adults and peers, which are often manifested through abuse, including bullying and cyberbullying. All this has a direct impact on the mental health, often defining childhood and adolescence as periods of risk of developing mental disorders and behavior disorders. So people under the age of 18 account for more than a third of all patients with mental disorders registered for the first time in their lives. So the vast majority, up to 79.5% of them, are disorders that are not psychotic. The importance of early diagnosis cannot be overlooked. The prevention of mental health and behavior disorders is critically important, and this is reflected on the platform of the Congress. I hope that this Congress brings together competent mental health professionals, will be able to facilitate the productive exchange of experiences and research advances and findings. I wish all the participants and guests of the conference constructive work, a lot of new ideas, effective interaction, and professional success. Deputy Ministry of Health of the Russian Federation, Oleg Salagai. Dear participants, this is the end of our welcome remarks, and we're ready to start with our productive and intensive agenda. It is my pleasure to pass the floor for the first presentation to Professor Norman Sartorius. Norman, the floor is yours.
adolescents. Local mental health care system. You cannot change it like that. And if you want to improve your mental health care system, you have to come from what exists. Next slide. So, what is child and adolescent psychiatry? For many people, and in particular for adult psychiatrists, child and adolescent psychiatry is just a psychiatry of little persons. Next slide. But this is not correct. This is not correct. There is a big difference between adult psychiatry and child and adolescent psychiatry. And it is not easy to define what is child and adolescent psychiatry. Here is a proposal of definition. This is a discipline dedicated to the treatment of a community. We face families, and this is quite a big difference with adult psychiatry. And this community calls for help. They come to see us because there is some suffering, and this word is very important. And the suffering, where is the suffering? In mind or behavior. Previous slide, please. Thank you. So there is a treatment. This is a discipline dedicated to the treatment of a community that calls for help for some suffering in the mind or behavior. And this suffering is located in a youth. And this is very important for clinical practice. People bring us a child or an adolescent, but it is the community that calls for help. And obviously, this is not simple to deal with that. And this is even more complex to explain it to societies and to communicate on it. And so there is a big problem, much wider, which is that in fact, child and adolescent psychiatry with this definition is completely different than child and adolescent mental health, as it has been presented in the previous presentation. Mental health, as defined by WHO, is related to well-being, self-actualization, and productivity. And obviously, this is not in line with the definition of psychiatry I propose to you. And even if there is a common border about primary prevention, we have seen it, to deal with mental health is very important to prevent mental disorder. And this is obviously the best way to deal with psychiatry. This is to prevent mental disorder. But anyway, we cannot prevent anything. And unfortunately, we still will have in the next decades many children and adolescents with mental disorder, and we have to deal with these patients. The problem is that for politicians, this is much easier to give money to mental health than to give money to psychiatry, because the word mental health is so pleasant, and because everybody wants to make children happy. And at the opposite, to give money to child and adolescent psychiatry, this is not very popular. And so at the moment, in many countries, nearly most countries on the planet, there is a lack of money in child and adolescent psychiatry because a lot of money go to mental health, which is fine, but there is also a need for money for psychiatry. Next slide. So concerning, as Professor Sartorius presented it, at the moment, there are plenty social mutation about the climate, which is a big problem for everybody, but in particular for young people. The question of gender, of identities, of social media, of school pressure, etc. And so we are very worried for the next generation. But there is also the risk of an overuse of child and adolescent psychiatry. This is not because there is an anxiety about the climate, which is correct, that this anxiety is a mental disorder. And so there is a risk that we use the word psychiatry to deal with all the problems that our society are facing at the moment, and this is not good. And so how to make the selection between all these societal problem and psychiatric problem, the split is the notion of rupture. A psychiatric patient is a patient that suffers in mind or behavior and suffers so much that there is a rupture in his or her existence. And whether it is an adult, an adolescent, or a child. Next slide. Next slide. So now, if psychiatry does exist, what is a child and adolescent psychiatry? And first, it is a physician. And even if psychiatry deals with the mind, and even in all societies on our planet, human beings experience a split between what is called interiority and physicality. And this has been shown by the anthropologist Philippe Descola. Even if we are dealing with the mind, children and adolescents have also a body. And for instance, in anorexia nervosa, obviously, you need to be a physician also to deal with this very severe eating disorder. A child and adolescent psychiatrist is also a person that can conduct highly technical interviews. Surgeons can do very refined things with their hands. We can do very sophisticated interviews with our words. And this is a job, this is a very technical job, and we have to defend it. Psychiatrists, they know also how to manage a team. And as you know, child and adolescent psychiatry, this is the problem of a team, how to deal with a team that can treat a patient. A psychiatrist is also a person that can make a serious decision in a minimum of time because we are trained for that. And this is a big difference with psychologists who can do also, obviously, very highly technical interviews. And psychiatrists in all countries are associated with some form of authority. And this is important in our interview. Our voice is can be very impactful, and we have to be aware of it, and we have to use it. Now, next point, how to think about an inclusive evidence-based medicine. Of course, we need research. Of course, papers are crucial. And now we can read all over the planet paper, a randomized control trial of a high quality that can point which treatment are better for this type of patient. Of course, this is true. But these results have to be interpreted according to local culture, local resource. And I love what Olainka Omegdobun, the past president of Yakapap, said. She comes from Nigeria, and she said, we have in Africa different resource countries. In some countries, you have resources that are not known in rich country, and we have to develop this different resource. And of course, you have to organize the local mental health care system, but it takes time. This is difficult to change the mental health care system, and it involves a lot of people. And so we need a bottom-up and not a top-down evidence-based medicine. And this is the reason why qualitative approach are very important in some kind of inclusive evidence-based medicine to be sure that these treatments are adapted to local culture. And politicians, administration, and sophisticated professors have to acknowledge it. Next slide. And so this is my conclusion. The future of child and adolescent psychiatry, we have to go beyond the common sense perspective, because the common sense perspective is some kind of pseudoscience, and it can be misleading. And so to plan the future, we have to consider very bottom-up question. What is child and adolescent psychiatry? This is not mental health, and we need psychiatry, and we need mental health, and we need that also there is some money in both directions. We need to deal with societal mutation, but all the problems that are related to societal mutation are not necessarily psychiatric problems, and this is important to say it. We have seen what is a child and adolescent psychiatrist. We have seen that an inclusive evidence-based medicine is necessary, and we have to think about the organization of local mental health system. And I will say thank you very much. Spasiba.
Thank you very much, Professor Farisal. In your usual style, you have left us with many questions. And I think that's wonderful for the Congress, where so many people from different fields of world will come, and I hope they will answer some of them. Just one correction. While you were saying that child psychiatry needs more money, it is also true for child mental health. It needs more money. So both of them should be given something. Thank you very much indeed.
We completely agree.
I have now the pleasure to introduce Professor Afzal Javed. Professor Javed is the president of the World Psychiatric Association, and he is a psychiatrist who is also a professor at the University of Birmingham of Applied Health Research. He is an honorary associate and a clinical professor at the Warwick Medical School. And I think it's important at the same time also is the chairman of the Pakistan Psychiatric Research Center at Fountain House, Lahore in Pakistan. Professor Javed will speak to us about the future agenda of the World Psychiatric Association and about action plans for youth mental health. Professor Javed, please.
Thank you very much, Professor Sartorius. Dear panel members, chairs, and respective participants. It is indeed a pleasure to be a part of this activity by Union for Mental Health. That is certainly a very important association working in the field of psychiatry. I have the privilege of attending some of your previous meetings, and this is one of the best models that they are taking, both public and private sector, to highlight the importance of mental health. My talk will be a brief overview about the future agenda and action plans of World Psychiatric Association, specifically in different areas of children, adolescent, and youth mental health. May I have the next slide, please? Can we go to the next one? I will try to very briefly cover why mental health is important and what are the issues regarding the importance of youth mental health and how we are going to address this from the World Psychiatric Association. Next, please. I think there is some problem with this slide, and there is also some time limitation. So may I just suggest to go to the next slide. I'm afraid that these slides are not visible, but these two slides were just giving a brief review about the importance of mental health in general. As the previous speakers have highlighted, that mental illnesses are highly prevalent. And as WHO says, there is a sort of around 25 to 30% of general population who are suffering from one or another type of mental health problem. This is a very important point because this shows the disability and the burden of disease when we are talking about mental illnesses in general. Now, coming to the children, adolescents, and the youth mental health, there are a number of evidences that mental disorders are the single most common cause of disability in young people. And we now know that around 70% of mental disorders begin before the age of 25. So this means that this is the age period when we can have, or at least we can predict about the chances of having any mental or psychological distress coming in the later years. Next slide, please. And as it has been mentioned by the previous speakers, the adolescent years are, just the slide before that, please, are very critical periods because this is what we in our technical terms call the formative years. And formative years are not only in terms of the bodily growth, but also in aspects of a number of other variables like emotional well-being and social development. And there is ample evidence that addressing mental health problems early in the life can decrease emotional and behavior problems and functional impairments in the coming years. So this is very important that we give due attention to the health and the development of children, adolescents, and young people at this particular age. Next slide, please. But there are a number of challenges that the healthcare and the social care professionals are facing when we are dealing with the mental health of children or the youth. The first one is that the failure to address child and adolescent mental health problems, including all the developmental issues that certainly have far-reaching consequences. The second thing is that evidence shows that a substantial proportion of adult mental health problems originate early in the life. And we do find that there are significant gaps what we know about how best to treat mental illness in children and youth. And similarly, when we look at the current trends in research, unfortunately, there is inadequate support for research into developmental neurobiology, the causes of mental illness, and most effective, safest, and best tolerated treatments in these age groups. And in addition to all these challenges, the stigma of mental illness, together with some of the current child and youth mental health care systems, illustrate the negligence of our society. Next slide, please. So I'm just going to very briefly describe about the programs that World Psychiatric Association has developed. As many of you know, that WPA is the umbrella organization of psychiatrists, and we have got 145 member societies in more than 120 countries, and representing the total membership of around 250,000 psychiatrists. Next slide, please. What WPA do, that we prepare action plans during a triennium. And these action plans are focusing on what are the current priorities or the needs for the WPA team and the WPA membership to highlight the importance of any particular areas. Next slide, please. I'm afraid this slide is also not visible, but this slide says that the most important features of the action plan are to highlight the important areas that are neglected or that are underestimated or have got some practice problems in different areas. What we have done is that there are 6 important areas in the action plan. And the youth mental health is one of the very important area that we are targeting in our activities during this triennium. The other areas are public mental health, looking at the comorbidities, capacity building, and developing associations with other organizations. If we look at all these action plan areas, the youth mental health is present or is visible in all these areas of future work, whether this is public mental health, whether this is exploring needs for dealing with comorbidities or developing capacity building and establishing joint collaborative work. Next slide, please. And youth mental health is highlighted by having different areas of work. I'm extremely sorry that we are missing some of the slides. Those slides were just giving the details of the youth mental health programs that we wanted to follow during this triennium. Some of the salient features are preventive education, promoting the health care of children, adolescents, and youth, specifically looking at their needs and targeting those specific groups in these age groups like developmental disorders, early interventions, early identification, and providing support to the parents, specifically looking at the needs from the low and middle income countries. Another important area where we are concentrating, and that has been mentioned by Professor Sartorius as well, is the digital technology. And there has been unprecedented and rapid changes in how adolescents are spending their time connecting to the world and communicating with each other by using these technology. Unfortunately, there has been some concerns that digital technology usage and mental health is focusing on negative effects and being considered as a sort of an area that requires a lot of attention from the professionals. But the fact is that digital technologies are here to stay and are becoming a norm in the lives and the relationships of young people. So what WPA is emphasizing that we should try to use digital technology to improve and to explore what sort of work we can do in this particular age group. Next slide, please. And as it has been evident that adolescents are spending an increasing amount of their time online. So probably we should really try to explore how can we use and how can we actually facilitate this particular technology for improving their mental health needs or providing them some online support if they are searching or if they are trying to find out a similar support. Next, please. I wish you could have seen this slide in full. I have just given you some data that shows that what is the extent of use of digital technology among the adolescents. But all these studies and reports confirm that the use of digital technology in the youth is much more as compared to the older age groups. So this again shows the trend, and we have to really find ways and means to explore the possibilities of using this technology for improving the mental health services. Next slide, please. These are some of the aspects of the use of digital technology when it comes to its use in child and adolescent psychiatry. The most important thing at this moment is that there is an increasing body of evidence that supports the use of computers and the internet in the provision of interventions. But probably a comprehensive need for evaluations of the effectiveness and, more importantly, the cost effectiveness of digital technology is an important area for research and delivery system in coming years. Next, please. Next, please. So in summary, we find that the mental health of children and adolescents is an important area, not only for clinical practice, but also for academic and research dimensions. This is a recent WHO finding. Again, I'm extremely sorry that you can't see the full slide, but that really gives the intensity and the extent of the problem. For example, 1 in 6 people are aged 10 to 19 years suffer from one or another type of mental health problems. So these are the data which show the global burden of disease trends and, more specifically, the needs for our younger generation in terms of providing them support. Suicide is the 4th leading cause of death in 15 to 19 years old. WHO collected this data from a number of countries, and it is one of the recent publications of the WHO. Next one. The next slide. Can I have the next slide? This is, again, the reference was at the end of the slide, which is unfortunately, again, not visible. But this is the latest release of the data from the England, where they have just put the emphasis on mental health of children. And as per their report, 1 in 8 among 5 to 19 years old had at least one mental disorder when they were assessed in 2017. And this data is just a sort of a follow-up of what has happened over the last 2 and 3 years. Again, this data reveals an increase over time in the prevalence of mental disorders in this younger age group. So probably the data are there, and that needs to be highlighted when we approach the policymakers. Can I have the next slide, please? And of course, while using this data, and as I was mentioning the importance of digital technology, I think this is what we have to emphasize and concentrate in future for our future directions. It is encouraging to note that many apps are in development and helpful in mental health promotion, prevention, and increasing mental health literacy among general public. WPA is currently working on developing some mental health apps to be used more specifically in low and middle income countries and with a clear focus on the youth and the young population. We do feel that technology, if used correctly, can be an important weapon in the fight against stigma, which is again one of the major problems when we encounter the mental health difficulties in youth and the younger age group. Next slide, please. So just to sort of summarize that WPA's efforts are currently focusing on improving and highlighting the importance of youth mental health. And we do hope that collaboration with other organizations, especially with our child psychiatrists, with NGOs, and with other international organizations working in the field of mental health, will be highly beneficial for some joint and collaborative works. With these words, I would like to conclude and thank the organizers for highlighting this particular important field. And we do hope that we will get some guidance from the proceedings of this Congress, which will help all of us in formulating our future plans. Thank you very much, and I wish all the conference participants and the organizers a big success. Thank you very much, sir.
Thank you, Professor Javed. It is clear that the many tasks that you have mentioned will probably be also helped by the developments and the discussions which will take place during this Congress. And I hope that the programs of the World Psychiatric Association will all be a great success. Thank you very much indeed. I now have the pleasure of introducing Professor Juan Mesic, who is the Secretary General of the International College of Person-Centered Medicine. He's also a past president of the World Psychiatric Association, and he will speak to us about the human development as a key strategy for person-centered medicine, health, and education. Professor Mesic, please.
Thank you very much, Professor Sartorius. I'm wondering if you are able to listen to me. I presume so.
We can hear you now.
Thank you.
We can see a slide. This is wonderful.
Thank you very much, Professor Sartorius and the other colleagues in this important Congress. I am grateful for the opportunity to participate in it, and I would discuss the perspective of human development as a key strategy for person-centered medicine, health, and education. Next slide, please. As part of that, I will briefly review the historical background on life, health, caring, and the person. Consider the contemporary precedents of the person-centered approach. Consider person and health as totality, rights, responsibility, and community. Then more specifically, in a perspective on person-centered medicine as both principle and strategy. Then we'll touch on an extension of this perspective towards a person-centered education. And finally, focus on human development as a key strategy for becoming a person. Next, please. This is the ankh from pharaonic Egypt, a symbol of life, which I am sharing because, as we know, life is at the center of health, and therefore of all what we devote our lives to as health professionals, as members of the human species. Next, please. Next. These are symbols of ancient civilizations that have, as all civilizations do, have specific views on health, which reflect their general way of conceptualizing important things. On the left, from the Chinese perspective, the complementarity concept, the yin and yang. On the right, the sense of equilibrium from Ayurvedic tradition. Next. In the Western civilizations, at the cradle of this, we have on the left Esculapius, the god of medicine and treatment, and on the right, a higher god, or more specifically a goddess, Hygeia, or the goddess of prevention. Next, please. And from the part of the world where I come from, namely Latin America, and Andean cosmovision, the concept of health as a harmonic equilibrium among an internal world, a social world, and a natural world, a concept that is of high pertinence at the present time. Next, please. So these allegories have confronted us with a historical background, which perhaps could be traced back to Neanderthals who address life and health through care as a shared social responsibility. Again, a very old concept that actually is gaining a lot of relevance in the new way of formulating promising strategies for health caring. And also during the Incas Tawantinsuyo period, it was emphasized that each age had specific social responsibilities. Even young children had the responsibility of caring for even younger children. And at the other end of the cycle, older people had a responsibility of administering justice. and were very respected for this. We can also recognize that all Eastern and Western ancient civilizations engage a broad personalized approach to health, which remains alive in many ancestral communities that currently live in parallel with other traditions and modern perspectives. So these are not pieces of museum exotica, but rather current realities in many parts of the world. Also, it's important to consider the ethical principles in our field, and which were highlighted by Kant and constitute the philosophical basis for human dignity. Nobody can be a means, only ends. All human beings are ends in themselves. And the contribution of the French Revolution concerning the respect for human rights. Next, please. Just touching on some contemporary figures that have delineated the person-centered approach one way or another. First, I'd like to mention Jose Ortega y Gasset, a philosopher from Spain, who, as we know, enunciated the dictum, I am me and my circumstance. And if I don't save her, I do not save myself, recognizing the importance of context and the sense of responsibility concerning that context. Next, please. Next, please. And also, it's valuable to think of Carl Rogers, an American philosopher, educator and psychologist, who wrote crucial books in our field or perspective, and on the basis of which, he's recognized as one of the most prominent psychologists in history. And he wrote, among other many books, one on becoming a person, and another, the person as a center, which clarify this perspective very nicely. Next, please. And finally, I'd like to mention Paul Tournier, family doctor in Geneva, who produced a book on medicine of the person, de la personne, which has been translated to more than 40 languages, and which is a wonderful stimulus to think about a person-centered approach to medicine, particularly from a spiritual perspective. Next, please. And so the concept of person to understand health is valuable on several grounds. One, because it articulates a comprehensive vision of health, biopsycho, social, spiritual, and even now ecological theoretical framework, the consideration of fearless and positive aspects of health, and take into consideration the person in context as a matrix to understand health, an integrative pivot for the coordination of health services. Also, because promotion is a fundamental ethical imperative, as already had a chance to mention, Kant's view of the person's dignity but also respect for persons' autonomy, including both rights and responsibilities, and consideration of the personal growth, value of cultivation of one's life project, which can emphasize the meaning that each life has for the person who lives that. Also, the person is important because it's an active and responsible agent crucial for effective healthcare and education. And so points out the value of extending this concept from health to other areas such as education. And last but not least, that the concept of person highlights the person behind many roles, such as that of the patient, the family member, the health professional, the educator, etc. Next, please. So we can see this recognized in many quarters that the 21st century is being perceived as the century of the person. And it is expressed in many ways, including the high interest on identity, for example, but also on paying attention about centering many crucial activities on persons, including person-centered health, broadly considered as we have done here during this, the early part of this report. Then more specifically, person-centered medicine, but also person-centered education, as we're starting to recognize and see, and even the value, by extension, of the person-centered approach to social organization and governance. Next, please. We can recognize that person-centered medicine is both a strategy and a principle. Person-centered medicine points to a fundamental theory as well as a strategy of medicine, which is characterized by assuming that contextualized person as the center to understand health, and also as the proper goal and protagonist of health actions. And this way, medicine and health can be understood best when they are seen as of the person, for the person, by the person, and with the person. And also to consider that this perspective is marked by the articulation of science, humanism, and social responsibility. And finally, perhaps understood as a holistic and collaborative approach to medicine, informed by evidence, experience, and values. Next, please. Now, extending in my final slides, this perspective to person-centered approach to education, we can remember Frank's proposal that a shared vision on and common strategy for education in medicine, nursing, and public health must be developed, which should overcome the limits of national borders and the silos of individual professions, so that we can work as a team to care for persons more effectively. This comprehensive framework considers the connections between education and health systems. It focuses on persons as co-producers and as drivers of needs and demands in both systems, education and health. Similar recommendations to focus education on the person are emerging with respect to medical education and university education more recently in general. Next, please. And so we can see in one of the aspects of education, which is university education, that a person-centered approach is quite relevant in the various responsibilities of the university, including the creation of knowledge, where we can see that persons are important not only as subjects, but also as participants, even when subjects, in the whole enterprise, which may, in many cases, enhance the quality of research. But most potently, this approach is important in professional training to make such training not only focus on technical competence, but also on the growth of the person. And finally, in terms of the social responsibility of the university, as that responsibility can be most effectively delivered when considering societies as composed by persons, each one of them unique and worthy of respect. Next, please. And as I am approaching my conclusions, what can we say about human development as a key strategy? This enhances the fulfillment of the mission of education in terms of personal growth, general and professional training, scientific cultivation, and social responsibility. The educational concern for human development and quality of life, conceived as eudaimonia in Aristotelic terms, but also in Andean cosmovision as a good living well, is relevant to all levels of the educational community, students, professors, and the administrative staff. Educational human development can be recognized, encompasses technical competence and human and social training, and thus contributes to the promotion of social and human concerns. Human development involves ethical commitment, a holistic framework, and a relational capacities related to the principles of person-centered care. And finally, that human development in education, therefore, must be person-centered. Next, I believe my last slide. Next. This is my last slide, a mural from Diego Rivera, the Mexican muralist who called this a history of medicine, but also gave it a second title, People in the Search of Health. With this evocative view, I'd like to conclude my remarks. Thank you very much to all of you for your attention. Thank you.
Thank you very much, Professor Mesic. Thank you also. You are the only one who had to get up very, very early to join us. It must have been 3 o'clock in the morning when you got up to join us. So thank you very much for your presentation, I think, which complements the previous presentations and which also brings us to the end of the morning session. I would like you please to remember that the WHO session dealing with the integration of child and adolescent mental health into global sustainable development agenda, speaking about the strategies for universal health coverage, will start in 15 minutes from now. Until then, thank you very much and we shall have a brief break. In normal times, you would go and have a cup of coffee together. Now you have to have your cup of coffee on your own. Thank you very much again for your contributions, and I'll see you very soon again in the WHO session. Thank you.
Спасибо большое, профессор Норман Сарториус.
Thank you very much, Professor Sartorius. We have to stick to our agenda, so I'm not sure we can allow a 15 minutes break. Hopefully, the limitations of online communication have a flip side in the fact that we can be flexible in grabbing our coffees and continue straight on with our sessions. With that, let me introduce our next session, as mentioned by Norman. So we are opening a special WHO session on integration of child and adolescent mental health into the Global Sustainable Development Agenda through to 2030. Strategies to achieving universal health coverage. This special session is hosted by the WHO European Office in Geneva. Colleagues, we are ready to hand it over to you.
Thank you. Thank you, Natalia. Good morning, all. You can hear me well?
Yes, that's one.
Thank you. Thank you very much for this. I'm Ledia Lazari, and I'm the Regional Advisor for Mental Health in the WHO Regional Office for Europe, based in Copenhagen. And it is my honor and pleasure to be moderating this session. Before I go on with the session, I'd like to notice also the presence of the esteemed pillars of the psychiatry community in the world, and both the figures that just took the floor now are an inspiration for the generations of psychiatrists, young and old, and I'm one of the old ones that got inspired by Professor Mesic, Sartorius, and many more. So without further ado, I'm going to open this session. It is actually the, as mentioned, on the integration of child adolescent mental health from a global sustainable development perspective. I would like to give the floor to my esteemed colleague, Dr. Melita Vujnovic, who is the WHO Special Representative to the Russian Federation. Melita, the floor is yours.
Thank you, Lydia. And allow me to proceed in Russian, having in mind the large Russian number of Russian-speaking attendance to the Congress. Уважаемая Наталья Валерьевна, уважаемый профессор Sartorius, уважаемые участники.
Esteemed colleagues, Ms. Treushnikova, esteemed speakers, participants, it's a great privilege for me to participate in this special session, and it's been long in the making. As you'll remember, together with Dr. Treushnikova, our original plans had this Congress take place offline and face-to-face. Then COVID hit, and we have to bring it to you online. This Congress marks the Global Mental Health Day, which envisages that we take care of mental health of each and everybody, which is fully aligned with the principle of SDGs, which says no one left behind. And it's especially crucial in mental health because the COVID-19 pandemic has dealt a major hit to mental health well-being of all populations, especially some vulnerable and exposed group. These are healthcare workers, frontline workers, adolescent students, people who live alone, and existing mental health patients. The total burden that COVID-19 has brought about and its increase will be manifest only in the coming months and years. However, there are some grounds for optimism. At the May Global Health Assembly session, this year, 194 governments recognized the need to expand the services for mental health on all levels. Some countries have already developed new mechanisms to deliver psychiatric help to their populations. As a representative of WHO in Russia, let me especially underscore the productive mode of cooperation that has take place between WHO and Russia in the recent years, especially as represented by the Russian Ministry of Health and mental health services in Russian regions. We are also in close cooperation with the Union for Mental Health of Russia. I'm confident that our collaboration will continue to strengthen and increase in the coming years. Let me especially note the joint initiative by WHO, the Ministry of Health of Russia, the Serbsky Center and Free Russian regions. That is the initiative to set up the distributed monitoring center system for suicide and suicide attempts. This project is in its pilot stage, but it has already shown that it's unique and crucial in order to prevent suicide, especially among adolescents. As part of the WHO session, my colleagues will share most current information and approaches on mental health for children and adolescents, and I hope that this is going to be interesting and useful for everybody who's joined. With that, I wish you a most productive discussion. Stay safe, stay healthy, and keep your well-being. Thank you.
Lydia, we don't hear you.
Yes. Спасибо, Милита.
Thank you, Milita. Lydia, we do not hear you.
Your phone.
Thank you.
Yes, thank you.
Yes, thank you very much, Melita. And also, I think we need to acknowledge for the audience the efforts of the WHO country office in the Russian Federation, but also of our partners in the Serbsky Institute to move ahead an agenda for the prevention of suicide. And I think we'll hear a bit more later in this panel from someone who is having hands-on experience of collaborating with the Russian colleagues in this area. Now, in the program, we should have had His Excellency, the Deputy Minister of Health of the Russian Federation, but I understand Dr. Salagai is unable to join us due to concurrent commitments, and therefore my turn is to present you a bit the latest from the WHO Europe office and what is what is happening in Europe in terms of novel mental health policies. If I can share the screen, I think I can. Yeah. Yes. I think I can share the screen, and I hope you can see the screen now.
Yes, that's okay. Thank you.
Thank you. So I'm going directly to the new WHO European Framework for Action on Mental Health that encompasses the period 2021 to 2025. This was developed at the end of the previous framework for action on mental health, and it has very much capitalized on lessons learned from the COVID pandemic response and recovery efforts. This slide represents the three main objectives of this strategy. The first one, those three objectives align with WHO Global Program of Work and WHO European Program of Work, and it builds upon the pillars, namely the pillar one, moving towards universal health coverage, and it consists on mental health service transformation. Here you can see what are the main topics here, but what I would like to say is that mental health service service transformation is not new in WHO. We have been working for a few decades already to support our member states in transforming mental health services and systems, but the fact remains that mental health systems have been chronically underfunded and under-resourced globally in the global public health sphere, so that mental health service transformation is a very much unfinished business, and COVID-19 uncovered those vulnerabilities and fragilities of the system and made it so obvious that no one can afford not to take action to further transform mental health services. The second pillar is based on the protecting people better against health emergencies, which in mental health would translate in through integration of mental health into emergency preparedness, response, and recovery efforts. This means that what you see in the screen is a transformation from a WHO and emergency staff that deliver medicines and supplies into emergency staff that deliver, in addition to medicines and supplies, deliver also mental health and psychosocial support. So what we learned from COVID is that there is no country that can afford to develop emergency preparedness and response plans without a strong and well allineated mental health component. And the third pillar is ensuring healthy lives and well-being for all at all ages, and it consists on mental health promotion and protection over the life course. We have two signature initiatives here: children, adolescents, and young people, so mental health and well-being for this group. And as you very well know, they have been particularly exposed to vulnerabilities during COVID because of school closures, isolation, and so on. It's true, this is true also for older adults who have experienced extreme isolation because of, especially those living in nursing home all across the WHO European region. Suicide prevention, you see, is another priority here under this area, as well as mental health in the workplace. Now, in order to give a response to these needs, the WHO European Office has established the Pan-European Mental Health Coalition that was launched only last week in Brussels. And the coalition can be kind of summarized in the diagram at the right of your screen, and it is an attempt to give a response to all the questions that stem from the awareness of the need. So, what will happen? The three main circles define what needs to happen. What will the coalition focus on? And you see, it's more or less the pillars that I talked about. And then, who will make those things happen? It's around the central circle, WHO, you'll see the number of partners that will need to be involved in order to make those things happen. These start with mental health experts. Many of you are in this room. This starts with government representatives. Again, we have the representatives of the Russian Federation government here in this room. We have international organizations. WHO is one, but not alone. We have UNICEF, we have UNDP, we have World Bank, we have the European Union. So we have many international organizations that are keen and willing to support. And last but not least, we have civil society partners, be those individuals, be those organizations, profit, non-profit, and so on. So when then it comes to how will those actors influence change in the pillars that we mentioned, we want to start by looking into those arrows. You have 4 arrows there. One of them is leadership. We need to have strong leaders, empowered leaders, and those leaders are not only in the ministries of health of our member states. Those leaders are everywhere. A good mental health leader can be a team leader in a community mental health service in some district of a country in the European region. It can be, of course, a policymaker in the Ministry of Health. But so what I want to say is that leadership here does not limit only to policymakers and government representatives, but is a far larger concept. Another instrument of how we will make change possible is data. We suffer chronically from a lack of systematic data collection, analysis, and utilization across the WHO European region. For a very good number of reasons, our data are not aligned. Mental health information systems across our member states are very different from one another, and that makes us in WHO in a precarious position when it comes to use data comparatively and longitudinally. A third instrument is advocacy. Advocacy for anti-stigma, but advocacy also for empowering those who should and can have a voice in how services and systems are designed. Those be mental health service users, mental health carers and families, civil society, as I mentioned, and beyond. And the fourth and as important instrument is mental health literacy. We know that due to many factors, including stigma, the health-seeking behavior among our populations is very low, especially in mental health. So we need a better prepared, better equipped public to not only to take better care of themselves, but also to be able to ask for help when and as needed. So this is a kind of reductionistic diagram because it doesn't include everything that we can and should be doing, but at least it gives a good architecture for how we can organize ourselves around the themes that we need to work on. And last, I would like to quickly mention what are the objectives of the coalition. The Pan-European Mental Health Coalition will serve as an overarching structure for operationalizing the European Framework for Action, working on the three priority initiatives that are the mental health of children, adolescents, young people, older adults, and the development of a mental health data lab in Europe. We also want the coalition will support the development of leadership, mental health leadership, including a peer support structure. And last but not least, research and innovation, including digital technologies. And I know that this Congress has paid very good attention to this aspect of that is emerging increasingly and fiercely in the mental health area. And with this, I close my my presentation. I want to go back to the room. Give me a second to stop sharing, yes, so that I can go back to the program. And unless there is a very burning question, I would like to give the floor to my colleague, Miss Amy Louise Carton, who is a mental health advocate for youth and who has extensive education in political and social sciences, and who has also her own experiences to share in mental health advocacy. Over to you, Amy.
Thank you so much, Lydia. Sorry, I don't think any online talk can begin without a problem with audio. So I apologize there for not being able to turn off my mute. Thank you so much, Lydia, for introducing me, for that wonderful introduction, and for everyone here inviting me today. It is an honor to speak before you as fellow colleagues and as in front of your excellencies. So I'm here today to tell you a story, my story. Just a few years ago, I actually made the very serious decision to end my life. And thankfully, I'm here today. I was able to get the recovery and treatment I needed. I was able to be saved, which is truly incredible because that is not the opportunity for many people out there. But what is part of that story is that for 13 years before I made that attempt, I struggled in silence. I did not seek help from my friends or loved ones. I did not seek help from the resources available. I did not try to talk or open myself to this. I felt that the pain and anxiety and fear that I was feeling every single day was normal. I had normalized it within myself because that's what the stigma told me to do. The stigma in Ireland and in places around the world like Eastern Europe are all struggling with the stigma around mental health and mental illness. We feel scared to talk about it. We feel scared to dig deeper. And as a result, people are silenced. Our pain is silenced. Our feelings and our struggles and our battles with this incredible weight and darkness is silenced. But not anymore. It's incredible to see the work of the World Health Organization's Mental Health Coalition coming together, bringing mental health actors together, because it is only with mental health literacy, as Lydia mentioned, that we can actually start understanding and taking apart the stigma. We can start deconstructing it and building something better in its ruins. It's incredible to stand here today in the aftermath of the pandemic, or while it still continues, because this is something that has opened the eyes for everyone. We have all seen the pain of mental illness over the last 2 years. And as a result, this has enabled us to speak louder. When we look at the younger generations, so many of them are indeed struggling in silence. It's estimated that 13% of European young individuals are struggling in silence. But that's not okay. And it's incredible to see the voices being raised and the potential for change that is around us all the time. It's incredible to see how the young people are standing up and beginning to fight for this. When we look at the service users and the voices being shared on social media, it is incredible to see that change is coming. All of you sitting around this room today, I'm so privileged to be here, but I'm so privileged to see what you are going to do in the coming months and years ahead of us. You know, it is extraordinary, the coalition that Lydia has spoken about, but what is more extraordinary is your potential for change. Whether it's lifting the voices of advocates and service users, or just trying to advocate it in your own personal life. Being a mental health ally is more than just attending events like this. It's creating real change every single day. And for that, I want to thank each and every single person on this call today. You are truly incredible for what you're doing. So thank you.
Thank you, Amy, for this inspiring introduction, and I hope the audience can take stock of your words and also can realize how a lot of the mental health burden is actually unseen, and which has prompted also the theme of the World Mental Health Day for this year, equal access to all, because as you very beautifully described, there is such a silent majority of people with mental health conditions who, for different reasons, do not seek help and therefore are unseen by the professionals and by the society. So I'm now going to the next speaker, and it is my pleasure to introduce my colleague from WHO Department for Mental Health and Substance Use Disorders in Geneva, our headquarters. Dr. Chiara Servilli will talk about strengthening mental health promotion and protection for adolescents. Over to you, Chiara.
Thank you very much, Lydia, and I'm really delighted to be here with you today. I really thank the organizers for giving me the opportunity to share in a few words what is being done and the vision around the work on child and adolescent mental health promotion and protection at WHO. The next slide, please. And before I actually start with yes, this is good. With a brief, overview, I'd like, to acknowledge that it's really, the voice of young people that is leading, the agenda on child and adolescent mental health today. I had the privilege of joining the Global Mental Health Summit hosted by the French government this week, and then again today, hearing Amy Louise share her experience, and it's just astonishing, how the voice of young people is really, leading the way in helping us reframe child and adolescent mental health to better understand how our work around services, around care systems, around equal access to care, can really, meet the needs and make a difference for the lives of young persons that are struggling in silence. And with that, I proceed with my presentation, but it's just, to recognize that, it's really, there is so much work to be done, to make sure that our approaches and our work is really, resulting in benefits, for the lives of young persons. And I welcome, any opportunity to work together with young advocates and young persons with their experience to help us, make sure that, our work is really, going in the right direction. So this first slide is to acknowledge that, we are talking about, as Lydia was mentioning, transforming mental health services. And this is happening, as we talk about child and adolescent mental health particularly, this is happening in the context of transforming the broader child and adolescent health agenda. So we have been seeing, our colleagues that are leading the agenda at the global level on public health for child health and adolescent health, really changing the way they're framing the services and the care, from a focus on, condition-specific work and not really looking at different age groups to a broader approach where we acknowledge that there is a continuum. And as we talk about child and adolescent mental health, this is also true, that there is a continuum in terms of opportunities to improve trajectories for development, for health, for well-being, across the life course. If we talk about the first 2 decades of life, certainly, there is no single time where, we should, missing opportunities to reach every, child, adolescents and their care, and exploit any opportunity of contact we have through the different sectors to deliver messages that can promote mental health, can prevent mental health conditions, and can provide the necessary supports whenever there is distress or symptoms of mental health disorders. This is happening in child health as well. This is the approach. There is the recognition of a life course trajectory, different opportunities across the first 2 decades of life, and the broader framing of the actions. So it's not only, action in terms of biomedical type of approaches and services, but we're talking about a whole society type of approach. There is the recognition that, the well-being and the health of a child is also influenced by the media, and there is a lot of talking about this, this week. There is the recognition that the family, of course, and the care is important, but also broader to that, there is the school, there is, the social protection sector, and much, much more, in terms of policies and laws, that can really frame, the lives of every single child and their carer, including those that are most at risk, those living with disabilities and those living with particular exposure to adversities, including humanitarian settings. The next slide, please. The next slide, please. I'm sorry, I cannot do it myself. And yes, this slide is provides a summary of the key recommended actions that emerged from the workshop on the working group on child and adolescent mental health at the Global Mental Health Summit in Paris earlier this week. A group of experts, young advocates, clinicians, frontline workers, and policymakers join hands to think about the theme of child and adolescent mental health and human rights. And they decided to put forward 6 recommendations that you see in this slide. And I think, it ties very well with, the focus on person-centered care that was mentioned earlier, this morning here. So the first recommendation is about ensuring that mental health care services for children and adolescents integrate the interests and promote their rights. The second is about meaningful engagement of children and adolescents in service provision, in planning, and evaluation. The third is about maintaining equal access to quality mental health care services with recognition that we need to find differentiated and targeted approaches to reach those that are most difficult to reach. Third, the other recommendation is about really the importance of improving health information systems and quality improvement type of mechanism to ensure that we can monitor the quality of mental health care services. Then, there is the recognition that to make this happen, to ensure, quality mental health care services, we need, a good set of skills and competencies for care providers available to meet the needs of children and adolescents with involvement of the different sectors. And lastly, but not least, we need the right level of investment in mental health care services. The next slide, please. So if I can, summarize the streams of work that WHO headquarters is focusing on, for child adolescent mental health, I think, they fit very well with what Lydia, was mentioning in terms of the pillars of the coalition, the strategy at the European level, because the first one is exactly on services. We want to transform child adolescent mental health services. And for this to happen, we are engaging in different sectors. We are building capacities to really, make available collaborative type care strategies with the involvement of different care providers. The second stream of work, I'm sorry, I'm just waiting for the next slide, but I keep going. The second stream of work is specifically about integration of mental health across different platforms. And the third stream of work is about promotion and prevention. So this slide is about transforming mental health services, and really, to recognize that there is that we need to meet adolescents where they are, and we need to rethink the strategies to make sure that we are able to deliver mental health promotion, prevention, and care in a way that is both acceptable, is affordable, and can be accessed by adolescents and young people. And for this to happen, we also need to have a very deep understanding of the cultural, structural, and contextual issues that are determining this poor access to services and to supports, but also to promotion, for children and adolescents. And this may vary. There are some barriers that are recognized across boundaries, across countries and cultures and situations, but there are some barriers that are particular to particular groups of individuals and adolescents, and some barriers that are more related to cultural issues. So this is a prerequisite, to really, better frame and deliver, these supports in different contexts. The next slide, please. The other point that I had here, was, the really, limitation we have, with our understanding about, what are good practices for delivering child adolescent mental health services and supports. We recently commissioned a review to our colleagues in our Washington universities to really look at good practice examples on child adolescent mental health care services, with a particular focus on quality and scale up. And, there has been a challenge, because if we look at the peer review literature, we recognize that there is, more documentation of field testing and effectiveness type of trials of psychosocial interventions also for child adolescent mental health, but there is still very little, being written about the child adolescent mental health services. In the interest of time, I would like to proceed and just talk about the Helping Adolescents Thrive promotion and prevention approach. So I would like to skip to the next slide. Actually, 2 slides, I think, until you reach the Helping Adolescents Thrive slide. The next one, please. The next, yes. Okay, so the focus of today's presentation, I was asked to focus on promotion prevention here, and this is related to the work that we have been conducting jointly with UNICEF on this program that is called Helping Adolescents Thrive. The focus here is really promotion and prevention for adolescents, and when we talk about adolescents in the UN, we refer currently to 10 to 19 years of age. And we recognize that, there was an urgency of, making available up-to-date guidelines on promotion and prevention for adolescents. So there is a WHO guidelines that was published last year. And I will share, the recommendations. And again, here, the approach is looking at what are the psychosocial interventions that can benefit adolescents in terms of promoting their well-being, but also preventing mental health conditions with a focus on behavioral, conduct problems, as well as depression and anxiety, but also, with broader outcomes, related to reduction of self-harm, reduction of other risk behaviors. We also looked at, the benefits of this mental health promotion and prevention type of psychosocial interventions in relation to outcomes outside of health in terms of, education type of outcomes, as well as human capital and substance use. In relation to the guidelines, we develop additional tools with that can really help countries implement the guidelines in the context of a broader approach. So the Helping Adolescents Thrive guidelines are focusing on what are the psychosocial interventions that can be delivered across different sectors and delivery platforms for promotion prevention of mental health in adolescents. But then, we recognize that there is much more that needs to happen. It's not just providing psychosocial interventions. That there needs to be, this whole of society type of approach to improving, the spaces and the environments where children and adolescents live. And this requires a much broader framework of action for governments, to really endorse, to make a difference in the lives of children and adolescents. And this is, the intent of the toolkit, the Helping Adolescents Thrive toolkit, that provides really, this guidance and these approaches towards programming for adolescent mental health. And in relation to that, we have jointly with UNICEF developed a set of tools, very practical ones that are, delivered in a form of a comic book and teacher guides to facilitate social emotional learning in the context of schools. So the next slide. And the next slide, please. This is the summary of the recommendations included in the HAT, the Helping Adolescents Thrive guidelines. There is a strong recommendation for governments to make available a universal type of psychosocial intervention for all adolescents with a focus on social and emotional learning. And then, there are recommendations for making available psychosocial interventions for adolescents affected in humanitarian contexts, as well as for pregnant adolescents and adolescent parents. And if you look at the HAT guidelines, you will see that there is an explicit recognition of what type of psychosocial interventions need to be delivered, including implementation, so what type of psychosocial intervention, including implementation considerations. So for instance, for humanitarian setting, the evidence is about CBT type of psychosocial interventions for adolescents with engaging of caregivers. They will also look at indicated type of psychosocial interventions that should be provided for adolescents with emotional symptoms, as well as oppositional disruptive type of behaviors. And again, providing, very concrete recommendations around, what type of psychosocial interventions, as well as how to implement these interventions in the context of care systems. Next slide, please. So the toolkit, has been used already in the European region. So with the help of, with the initiative led by the European WHO office, alongside, with the regional UNICEF office, the Helping Adolescents Thrive toolkit was used to facilitate the sub-regional type of dialogues and orientation workshops to have governments come together and really, think about gaps in terms of their actions for promotion and prevention of adolescent mental health. And the focus of those dialogues really, reflected, the Helping Adolescent Thrive strategy that looks at 4 different strategic approaches. The first one is implementation and enforcement of laws and policies. The second one is about improving environments for promotion and protection of adolescent mental health. The third one is about caregiver support. And the last one is specifically about adolescent type of psychosocial interventions. There is recognition that it's important across these strategies to adopt a multi-sectorial type of approach and a focus on monitoring and evaluation of all the actions. The next slide, please. In the context of those dialogues at the European level, we looked at what are the good practice examples that have been, compiled in the context of the HAT toolkit to define universal type of promotion, targeted type of promotion and prevention, and indicated type of approaches. And there has been a follow-up type of policy dialogues with some of the countries involved, to really follow up and try and map out what is the current situation in countries and what can be done to strengthen. The next slide, please. The discussion around improving environment is focusing on online spaces, communities, and schools. And the time now is very brief, but if you look at the HAT toolkit, there are specific examples from countries on what are the experiences with implementing these approaches towards improving environment in different contexts. What is aligned with available evidence? What are evidence-based approaches? What are the lessons learned from countries? As well as what are some tools that are currently available in interventions, also outside of the WHO arena, to implement these strategies in different contexts. For instance, parent training approaches, what is the evidence behind this compiled in the HAT toolkit, but also, what has been done and what are available tools that could be used according to the different context needs. Next slide, please. Yes, and this defines, the second strategy about caregiver support. I think, the time is really limited, but I think, it's really, I wanted to have a highlight of the different strategic approaches of the HAT toolkit and how that, can frame conversations and dialogues in countries and regions and define, the different actions at these different 4 levels, environments, policies, caregiver supports, and psychosocial interventions. And of course, we are available, to provide support, with conversations and dialogues, where countries, wants to have a critical appraisal of how their policies, their strategies, as well as their, actions, their action plans, as well as, what interventions and opportunities are currently being exploited in the country to deliver different type of supports to caregiver and to adolescents, and have a critical appraisal about how they align with the best available evidence, and to and how there can be improvements in terms of evaluating those actions and making sure that the adolescents and young persons are not missing any opportunity to be to be in contact with different personnel and providers, and they can benefit from the optimal type of nurturing enabling environments and type of psychosocial support. So with that, I would like to finish my presentation, but I remain available to provide any to clarification, or of course to be in contact in the future to provide support and technical support.
Thank you, Chiara, very much for this thorough and comprehensive presentation. I hope the participants have taken note of the products you proposed here, and that there will be an appetite afterwards to absorb those products in the Russian Federation. And that very much brings us to now the news that His Excellency, the Deputy Minister of Health of the Russian Federation, is online. And I would like to give him the floor to say a few words and to see how the Ministry of Health is looking forward to strengthen mental health services for children and adolescents. Over to you, Dr. Salagai.
Уважаемые коллеги. Если меня слышно,
Hello, colleagues. I am currently in transit. I just landed from a business trip. We can hear you. Thank you, Dr. Buinovich, for confirming that. Dear colleagues, let me first and foremost welcome you at this conference. Let me also congratulate the organizers, including members of the Union for Mental Health, and personally, Dr. Treushnikova, with successfully hosting this event. It is a major step forward, a huge forum that is important, an important contribution. Naturally, this discipline is multifaceted, because for adolescents, this would mean protection of their rights, delivery of proper healthcare, social adjustment, education, freedom of action in labor, culture, as well as countering stigmatization. That's a huge scope of efforts, and for each of these aspects, they have been working actively in order to provide proper protections and support to minors. Mental health issues in children have been changing, and their patterns or manifestations, which drives us towards finding new ways to provide effective treatment. We need to take the approach of reasonable deinstitutionalization of medical treatment. Medicine should still stay in place, services must be accessible and high quality, but our support for children cannot be limited to the confines of psychiatric institutions. I'm sure it has been mentioned and will be mentioned throughout the Congress. So this search for proper community-based humanitarian interventions is a major challenge, and there are a few reasons for that. First, the community itself needs to be ready to take up the task of delivering this help. They need to have the capacity to provide social adjustment, proper level of education and training. Let me note that tomorrow, on Saturday, there's going to be a forum of school teachers and class supervisors. There's going to be a section on the role of educators in promoting healthy lifestyles in adolescents. One of the questions that we are going to be discussing is inclusivity, provision of supportive environments, and otherwise helping with special needs or mental health disorders. We need to understand that full range of medical services of proper quality must be available to everybody. The psychiatric service works really effectively in Russia at this time, both inpatient and outpatient. But still, there is room to grow. We need to upskill workers that deliver help to children. And without doubt, this is going to be a priority for us in the coming future. In closing,
Еще об одном важном моменте – это вопросы
I
защиты
would
прав.
like to mention another important area, and that would be protection of child and adolescent rights.
В случаях рождать определить прав, и в этом смысле мы должны быть особенно
In this respect, we need to pay particular attention to the protection of the rights of people and children in particular with mental disorders. I would like to conclude by thanking the World Health Organization
прежде всего доктора Ганса Клюге за
and
запуск.
Hans Kluge for launching the Mental Health Coalition. We consider it to be a very important step and we will support them as much as we can. I would like to thank Dr. Martilunovic that as part of our country interaction in this area pays a lot of attention to our priorities. And I would like to welcome the appointment of Dr. Ledia Lazari, and I would like to wish her the very best of successes and of course mental health in her new role. Oleg, thank you so much. It was very important for us to hear you today, to get your contribution, and I guess my colleagues will support me in the fact that interaction, collaboration with the Ministry of Health is particularly important. Thank you so much for finding the time, for being so active in supporting our efforts and for always participating in all of our events and undertakings. Thank you so much. Oleg, thank you.
То, что гражданское общество участвует.
We're really appreciating the fact that we're bringing together so many important stakeholders. Thank you so much.
Thank you also on behalf of WHO to Dr. Salagai, and I took notes of his comments, particularly on the role of community, more resilient communities, better mental health for our children and adolescents. I took note also how he very clearly spoke about going beyond psychiatric care when we design support for our youngsters. He talked about data, about quality of services. He talked about upscaling skills of the workers. And he confirmed very clearly that the Ministry of Health has mental health as a priority, and especially mental health of children and adolescents. So it was, and he also gave a strong focus on children and adolescents' rights. So all those points cannot be better aligned with WHO plans, priorities, objectives. So big thanks on behalf of WHO, Dr. Salagai, and looking forward to working together with you. We go now to the next speaker, who many of you in the Russian Federation and beyond in the WHO European region know as a champion in preventing self-harm and suicide in young people, Professor Ella Arensman. She comes from the School of Public Health of University College Cork and National Suicide Foundation in Ireland. Ella, the floor is yours.
Thank you very much, Lydia. And I have been told that my slides would be shared. I just wait a minute to see. In the meantime, so esteemed colleagues, esteemed excellencies, I'm very pleased to address you and all delegates at this very important conference here today. Mental health, meeting the needs of the 21st century. I very much would like to thank Dr. Melita Vunovic and colleagues from the WHO Country Office for Russia for inviting me here to speak today. And I also would like to thank my colleagues from the WHO Office for Europe, particularly Dr. Dan Chisholm, Dr. Elina Shevkin, also for the long-standing collaboration, particularly with some of the innovative and successful projects that we have started a few years ago in Russia. And just one of the examples that was also already highlighted by Melita is a few years ago, with the support of the WHO country office in Moscow and the support of the WHO Euro office, we started to work intensively with 3 large regions in Russia. It's the Stavropol area, it's the Sverdlovsk area, and the Zabaikalsky area in trying to establish a self-harm surveillance system. And we have succeeded, and particularly with the huge effort of the psychiatrists and other mental health professionals involved. So I'm very pleased to refer to that. I'm not going to say too much about that today, but during the conference tomorrow, there will be some speakers who will be referring to this. So, and before I start, I would like to sincerely thank Amy for her openness to share her experiences, but also to share her views on how important the input and the advice, I call it also the advice of people who have gone through suicidal crisis or who experience mental health issues. It's a critical component from my perspective at all levels of our work. So in research, in prevention, in implementation, and also evaluation. And I wasn't aware, obviously, before this session, what Amy was going to say, but a person who has also survived a very, very serious attempt of suicide. I'm going to end with his story at the end of this presentation. Can I have the next slide, please? I will just, so obviously this conference is timely in many ways, and looking at the briefing of the Secretary of the World Federation for Mental Health, I couldn't agree more with this statement, because obviously before COVID-19, we have seen ongoing challenges, particularly in relation to self-harm and suicide amongst young people, but particularly for the target group of young people, the intensifying of health, economic and social inequalities has certainly very clearly impacted on young people. So there are an important number of challenges that I still would like to share with you. However, there's a bit of good news as well in terms of a growing evidence base for some of the very important intervention and prevention programs. So can I have the next slide, please? Yeah, thank you. So in terms of where we are globally, in terms of country rates of suicide amongst young people. So first of all, what is still a major issue of concern is that suicide is the second leading cause of death amongst 15 to 29-year-olds, and this involves both males and females. It's unfortunately still the second leading cause of death amongst 15 to 19-year-old girls globally. Now, if we look at the countries that are listed here, and it's the OECD figures, the latest available figures, and again, we're facing that challenge of delays in reported suicide figures. But based on this, we can first start with a little bit of good news, because if we look at the black and the dots representing 1990 and 2000, then we can say that overall country rates of suicide amongst young people have decreased over the past decades, but we're still facing, first of all, ongoing peaks or high rates in some countries, and here definitely we see New Zealand, Iceland, Lithuania, Russia also still with relatively high peak rates. But another phenomenon which is less well researched is that very unfortunately year on year, based on self-harm surveillance and suicide surveillance, we see that the age of onset of self-harm and suicide is reducing almost year by year. And this is why it's so important that this conference is focused also on multifaceted intervention and prevention approaches, not only for adolescents, but also for children. Can I have the next slide, please? There's something that may have gone wrong here. So unfortunately, you can't see the scientific iceberg, but you do see an iceberg here. And what I would like to convey here is that roughly 10 years ago, with significant funding from WHO, but also the EU, a number of large-scale population-based surveys were conducted in up to 10 different European countries. And consistently across these countries, there was this discovery of what we refer to as hidden cases of self-harm. So at the bottom of the iceberg, we identified, particularly via school-based surveys, that the majority of young people, adolescents who reported one or more acts of self-harm had hardly ever been in contact with anybody in the services, not even primary care and not even, for example, a school counselor. So this was consistent across many of the participating countries, many areas of Europe. So this gave us the evidence that on top of hospital-treated self-harm, we're also facing a challenge with a large volume of hidden cases of self-harm. And exactly this is the level of the iceberg where community-based interventions, but also public mental health awareness programs are absolutely critical. So I was very pleased to hear the health minister and also previous speakers highlighting this important area. I will come back a little bit later on the evidence. The next slide, please. Just to move on. So most of the research over the past decades that has looked at risk factors associated with self-harm in adolescents has overall found consistency in terms of specific risk factors associated with high risk of self-harm. And I have listed them here in terms of strength, in terms of predictive value. And what has been an interesting finding is that particularly over the past 10 years, we've seen a bit of a narrowing of the gender gap. So boys and girls showing almost similar trends in self-harm, but also overall fairly similar risk factors associated with both self-harm in boys and girls. Many of you here will be familiar with many of the risk factors, and obviously it goes without saying that the more risk factors that are present, the higher risk of self-harm. But an interesting finding here, a very pertinent risk factor is self-harm by friends and family members, which we can also expand to being exposed to self-harm in the media, being exposed to self-harm on social media. And this is definitely one of the evidence-informed hypotheses for particularly the recent increases in child self-harm. And why that's further evidenced by that phenomenon or by that aspect is also a shift in moving towards more highly lethal methods that we see nowadays amongst children as young as 11 or 12. One area where we definitely still face a gap of protective factors associated with self-harm. So I would definitely recommend funders to focus equally on the importance of protective factors. So where we can see how we can prevent even a first act of self-harm, but definitely where we can prevent repeated acts of self-harm. Can I have the next slide, please? So in terms of challenges related to self-harm and suicide in young people, as I just alluded, a decade ago, we were still focusing on self-harm and suicide in adolescents. Sorry, I'm missing a slide. We should have one in between. Oh, yeah, so no, sorry, this is okay. It's just that the size is a bit different, but I will just adjust. But in some of the countries listed here, such as Ireland, UK, US, Australia, and Japan, over the past decade, we've seen increased rates, in particularly of self-harm in children, as young as 10, 11, or 12. And as I said, we've seen a growing trend of the use of highly self-harm, and also a fairly new phenomenon that I refer to as method escalation. And what I mean by that is via a lot of our research that we do with hospitals, we see young children coming in, for example, with an intentional drug overdose. And surprisingly, just a few weeks later, we could see repeat acts, but then with significantly increased lethality of self-harm methods. So the shift in children of moving from more low lethality to high lethality methods is a new phenomenon where we have to respond to urgently. Also, even though there is a growing development in the evidence-based supporting mental health promotion programs, we're still lacking behind. So it is an area to prioritize for funders and policymakers. Some aspects we can't see because apparently the slide is a bit changed here. But another very important area, and some people have touched upon it, we're lacking behind in early identification and in self-harm in children, but it's also very difficult then to offer a tailored options for aftercare. Usually there is less capacity within existing adolescent mental health services. So we urgently need to focus on tailored mental health services, particularly for that very young group of children at risk of self-harm and suicide. And then another very important challenge is to obtain much more detailed information on what are the specific mechanisms through which social media impact on young people's self-harm, suicidal ideation in general, but what are the profiles of children and adolescents that are at particular high risk when they're being exposed to harmful content of social media. Can I have the next slide, please? So in the next slide, I would like to focus on what we know so far in terms of the impacts of COVID-19 on self-harm and suicide trends. And so far, we've seen an interesting development in that across many countries, there is strong evidence of increased self-reported mental health problems by children and adolescents. So particularly self-reported anxiety, self-reported depression, and in some countries also self-reported suicidal ideation. However, during the first wave of COVID-19, let's say for the year 2020, particularly in high-income countries, we have not yet seen consistent evidence for significant increases in suicide or significant increases in self-harm. However, in some of the low and middle-income countries, we have seen very clear increasing trends of suicide and self-harm. It's hard to explain these differences in a few words, but one of the hypotheses could be that obviously in the high income countries in which this research was conducted, most of these countries were already engaging in their first or their second national suicide prevention program. So we can start testing the hypothesis, what would be the buffering or the protective factors when you have already knowledgeable expertise and infrastructures in place to respond in a timely manner to increased needs for services. Can I have the next slide, please? Because the slides are now delayed. Yeah, so this is what I refer to, and also this evidence is based from a living systematic review led by my colleague Professor Anne John in the UK, which everybody can easily access online. Can I go to the next slide, please? So in the next slide, I would like to refer to a commendable work by WHO, the so-called Live Life plan and guide, which has only been recently launched. It's worth for everybody on the call to look at this in great detail. So I call it the evidence-based implementation guide for suicide prevention. And it's, again, no coincidence that there is a strong focus on suicide prevention and prevention of self-harm in young people. Now, it's across broader ages as well. But if we look at key pillars of Live Life, such as limiting access to means of suicide, interact with the media, and responsible reporting, that's obviously very, very crucial for children and adolescents. The fostering of life skills for young people, so that whole area of protective factors, and then early identification of people at risk of self-harm or suicide. So I think for all of us globally, this has been a huge step forward, and I think should definitely be reinforced as a huge fundamental basis for suicide prevention in countries everywhere. Can I have the next slide, please? So moving on to more positives towards the end. So so here are a number of systematic reviews that very fortunately have already identified increasing evidence base or support for some of the prevention and intervention programs. The health minister referred, I was pleased to hear him talking about multi-level approaches, because recent systematic reviews do show that if in schools or other settings you have youth-focused multi-level mental health promotion programs, they genuinely, consistently contribute to improved self-esteem, improved resilience, but also reduced suicidal ideation. And many of you here may be also aware of the growing evidence base for cognitive behavior therapy, dialectical behavior therapy, specifically for adolescents. And also there's some evidence for home-based family therapy, particularly when we talk about smaller children. And
Ella, I'm sorry, I'm reminded by the organizers that there are other sessions pending in the hall. So if you can
I will
summarize, we go back, we go to the other speakers. Thank you.
Exactly, yeah. I'm going to the last point. So which is, from my perspective, the most important point, if I can show it. So I think Amy already mentioned something in relation to hope, and also that aspect. She didn't say specifically ambivalence, but what I wanted to highlight at the end is that particularly the global research on risk factors and motives associated with self-harm has shown that consistent evidence that when young people are in an acute suicidal crisis, suicidal intent and wish to die is not the only aspect. So what we have discovered is that at the same time, during a suicidal crisis, yes, people report a wish to die, but at the same time, they still report motives to enable change in their situation. And we refer to that as ambivalence. And the ambivalence, and I hope the last slide comes because I have some imagery there, but the ambivalence is also definitely supported by people who are now advocates in suicide prevention. So here on the left side, we have Kevin Hines, who many years ago nearly died during a highly lethal attempt of jumping from the Golden Gate Bridge. And in retrospect, he was able to tell that even during this high-risk suicide attempt, for a number of seconds, he felt that he didn't want to die. But the process had already started, so the act had already started. And I did find some art reflecting this, but I think a lot of people do not realize, first of all, that people who attempt suicide don't want to die. What they want is a different life. And when you look at this carefully, it's a fundamental difference for community-based facilitators, healthcare staff, if they understand the process of ambivalence, it makes it easier for them to engage with people who are at risk of suicide or who are currently in an acute suicidal crisis. So on this note, I would like to end, and I would like to thank you all very much and wish you an inspiring Congress.
Thank you very much, Ella. And I think the last point you made is very, very important. And I hope it is a lesson that our audience can take stock of and take it home and base their future interventions and support to either other healthcare workers in capacity building or in their own everyday practice. I have now the pleasure to pass to the next speaker, Professor Kurt.
I'm so sorry.
Yes.
Could I say? Уважаемые коллеги, я хочу вам напомнить, что сейчас...
Bit of an announcement. Colleagues, I'd like to highlight that other streams kick off at 1 p.m. Moscow time. In this call, we are a bit late, so we will continue with the WHO session, but you are welcome to review the program and look at the parallel streams that are starting currently. Thank you, Lydia. Over to you.
Thank you, Natalia, and apologies to the others that have joined us in the hope to find another session. I hope the session will be interesting enough for some people to still remain with us. I have now the pleasure to give the floor to Professor Kurt Hagquist, who is a guest professor of public health at the University of Gothenburg in Sweden, and who at the same time has been a very active player in the WHO Technical Advisory Group for the studying of mental health impacts of COVID-19 in the WHO European region. He has, due to his background in children and youth mental health, Professor Hagquist has played a very important role in that group to draw evidence, and is now going to talk us through the impacts on mental health promotion and prevention in Sweden. Over to you, Kurt.
Okay. Thanks very much to the organizers for inviting me to this conference and giving me the opportunity to give a talk. I will focus on how COVID-19 has affected young people's lives and mental health globally and in Sweden, and the challenges for policy and mental health promotion as well as research. I am relying upon the work by the WHO Technical Advisory Group on the mental health impacts of COVID-19 in the WHO European region. While young people are less affected by the COVID-19 compared to older age group in terms of severe illness and death, it is obvious that young people's living conditions and everyday life are profoundly affected by the pandemic. Next slide, please. This is clearly indicated and highlighted by a recent paper in The Lancet, estimating that 1 million children globally have lost a parent because of deaths in the wake of the COVID-19 pandemic. The challenges for public health are further highlighted in the UNICEF's flagship report, The State of the World's Children 2021, that was released earlier this week. In order to confine the spread of the coronavirus, schools have been closed, implying that children and adolescents over long periods have lost parts of their educations and experience a big change in their social relations, with loneliness, more sedentary behaviors, and less physical activities for many students. During the early phase of the pandemic in the spring of 2020, 150 countries fully closed their schools. In March to May 2020, up to 1.5 billion children and young people were out of school. Sweden stands out by not adopting the universal strategy of school closure as the way to confine the transmission of the coronavirus in the compulsory school. That's the lower and secondary schools. In the Swedish upper secondary schools and universities, classroom teaching was replaced by distance learning. This was made possible because of high availability of internet access in Sweden. Undoubtedly, COVID-19 has increased the risk of mental health problems among young people. A recent study in JAMA Pediatrics, based on meta-analysis of 29 studies, showed that the global prevalence of clinically elevated symptoms of depression and anxiety induced during the first year of the COVID-19 pandemic were double compared to the pre-pandemic rates. Next slide, please. A recent systematic review by Wiener and colleagues identified 27 studies concerning mental health indicating considerable impacts of school closures across emotional, behavioral, and restless inattention problems. There is an obvious risk that the inequalities in living conditions and mental health of young people will increase in the wake of the COVID-19 pandemic. Preliminary results from a Swedish study that I've been involved in confirm that this is likely to happen also in high-income countries. Self-reported worry related to COVID-19 about personal and family issues and finances was socially structured. Negative impacts of the pandemic were more common among students from lower socioeconomic groups compared to higher socioeconomic backgrounds. While digital technologies offer opportunities to mitigate the negative impacts of some confinement measures, in a global perspective, the inequalities in digital connectivity is gigantic. Even in high-income countries with high internet connectivity, students from lower socioeconomic backgrounds may be more negatively affected by the school closures because of inequalities in access to parental support. It follows that a major challenge for governments is to provide educational support to students, helping them to catch up with drawbacks caused by school closures and distance learning. Special attention needs to be paid to groups at higher risk for school failure, for example, socioeconomic disadvantaged students and those with pre-existing mental health conditions. Social emotional learning is a kind of educational evidence-based support that needs to be prioritized in addition to traditional basic learning. Next slide, please. These perspectives are summarized by the WHO Technical Advisory Group by saying that countries should promote, communicate, and increase access to socio-emotional learning, educational support for learning loss, and mental health and psychosocial support in school and universities, and provide more community support for adolescents and young adults. There are still a scarcity of high quality studies also in Sweden that allows for firm conclusions about the impacts of the pandemic on young people's mental health. Sweden and other countries should therefore heed the WHO Technical Advisory Group recommendation, next slide please, that countries should monitor changes in mental health at population level through valid, standardized, and comparable measures and instruments. Next slide, please. Finally, and to conclude, there are an obvious risk that inequalities in mental health and young people will increase in the wake of the pandemic within Sweden and other countries, as well as between high-income countries and low-income countries. Therefore, governments need to respond powerfully to the WHO call for action to address the impact of COVID-19 on mental health. Thanks for your attention.
Thank you. Thank you very much, Kurt, for making a very bold call and also for bringing attention to the social determinants of health. It was mentioned even before during the previous speakers, the Deputy Minister of Health, Ella Arensman, but you also drew attention on the aspects of social determinants on mental health of our young and children and young people. I'm going now to present the last speaker for today, but not the least important, Professor Tamás Kurimai. He is head of the Family-Friendly Mental Health Center at the new St. John Hospital and Outpatient Clinic in Budapest, Hungary. Some of you will have a chance to meet Professor Kurimai in Budapest next year, where he is the chair of the organizing committee of the European Psychiatric Association Congress that will take place in April next year. Over to you, Tamás, for delivering your presentation.
Dear colleagues, dear Lydia, dear Excellencies, thank you very much for the invitation. I think this is a very good opportunity to speak about this kind of continuing, which we were speak before. Please, next slide, please. This is the title. So the main aim is to bring maternal health into these days. Next slide, please. To indicate the importance of prevention and promotion, and what time can we start investment into the prevention. Next slide, please. So this is the prevention and promotion start as early as possible, an early age and use and for vulnerable groups. This deliver the greatest benefits and return. And also maternal health cannot be separated, as I mentioned, from infant and child and adolescent health, including mental health. So the human potential for development requires age-specific investments throughout not just the first 3 years, but for the 8,000 days of childhood and adolescence, because just for the first part it is inevitable, but very important, but also later phases. Next slide, please. So this is a kind of chart that indicated the rate of return to investment in human capital, the most gaining when we start as early as possible. So pre-conception, first, second trimester, preschool, school, and this is rates of return to human capital investments, setting investment to be equal across all ages. Next slide, please. So this is, for this reason, this is very important to speak about the prevention of stressful events and its consequences started as early as possible. Please, next slide, please. Because the area of prevention is important in that level. So this preconception healthcare, perinatal healthcare with good clinical practices, screening high-risk groups, and early interventions are the main focus of this. Next slide, please. So these areas are very important around perinatal period. And when we prevent in the prevention, we can think about the gene-environmental interaction. Also, there are other important stressful events, childhood maltreatment, parenting, which could have an intergenerational transmission effect. And this is just mention a study about the role of oxytocin receptor and role of oxytocin gene in that sense that are in focus in what is the role of the transmission of these receptor gene. Next slide, please.
Professor Kurimai, while
yes.
they change the slide, I am informed by the organizers that they really need the room, and I'm terribly sorry to have to interfere in your, but very kindly, if you can kind of wrap up, shorten it with apologies.
Okay, in this case, so the problem is that, of course, I use 8 minutes as it was.
Of
before.
course,
but but please, next slide, please, so we can go through the further slides. Okay, the impact of perinatal depression also important because the risk for infant is transmitted via parenting and also through paternal intimate partner violence is also an important point. Next slide, please. Okay, so when we talk about the changeable effects, for example, the pregnancy and smoking, because the smoking during pregnancy could affect the children, sudden infant deaths, ADHD, and other transgenerational epigenetic effect. Next slide, please. This is an example, the Hungarian smoking cessation hotline service. This is which prevent the also this kind of effect. It is offered to the pregnant woman as well. Next slide, please. Okay, next slide, please. So I am going to brief it. Due to the time concern. Next slide. So the first Hungarian example is the Hungarian National Breastfeeding Committee, which is was founded in 2019 by the Hungarian government to utilize the advantage of and support not just breastfeeding, but around those values which are important. It has many working groups containing many professionals, and you can see here this is health professional education, family-friendly care, baby-friendly pediatricians, and baby-friendly hospital initiation also included. So this is a kind of organizing, backing institute, supporting the values and the prevention, and also including the family-friendly approach. Next slide, please. It was mentioned this is during COVID pandemic, WHO recommend the breastfeeding even when the mother is suffering COVID-19. Next slide, please. The next example is a research project. It's a longitudinal birth cohort study run by the Hungarian Demographic Research Institute that will follow the lives of more than 8,000 children from before birth. This is a country-wide representative study to provide overview of child development in Hungary and factors influencing it. Next slide, please. And it was also a very important part that each wave's mothers, primary caregivers, and also fathers are interviewed, and the measurement could give back to policy level what kind of patterns can be realized. And plans are right up until the children are grown up. The second study, which I bring to you to attention, we can see the next slide, please. This study is, I hope it will arrive, okay. This is a 21st century baby room study. Next slide, please. Because it refers to the mapping of the parent survey. This is also a representative Hungarian national survey to examine the early childhood mental health problems and important individual, family, and broader environmental risk and protective factors associated with them. So this is the first representative survey to examine quite a great number of samples and also examining children under 3 years of age. Next slide, please. So this is not just a study, this is also a translational research which creates a bridge between theory and practice among the researchers and clinicians. Next slide, please. And also we jump, this is the theoretical model behind it. I don't have time to do it, but all these indicators are collected, and it is important to have factors to identify risk and protective factors. Next slide, please. This is about the role of psychiatrists in this process. Next slide, please. We're just not doing our everyday work, but we have to do prevention and protection work in that. Next slide, please. This is the last part, very in 1 minute. It is about our new program was founded 70 years ago. Please, the next slide. And in this program, we treat together the baby and the mother, and also with the father in a unit. So please go to the next slide. Okay, this is our program, and also we developed a guideline about it. This is interdisciplinary and intergenerational program. Next slide, please. So this is during the program during the COVID-19, we also was affected by that. Next slide, please. Because the rates of depression, anxiety, and stress also were raised, and also the separation of infected mothers from infants also has a great effect. Next slide, please. These are just the final ones, just showing that the overall data during the pandemic was shown that can we jump to the next slide, which is just to the end.
I am sorry, but I'm told that the organizers really have to cut us out of this room.
So the okay.
Yeah. So
please go to the latest slide, and that I will finish. Okay. Next one. So that this is a summary. This is next one. Please, next one, and the final, and next one, the summary too. This is the message. The next one, summary two. Okay, so this is the message: investment into preparing postnatal care national program supporting families, intersectoral collaboration, monitoring and research are important prerequisite and joining elements of youth mental health. That's it.
Thank you, Professor Kurimai, for bringing
I'm
the
sorry
attention. Thank you for bringing attention of the importance of taking care of our mental health from before the child is born. I hope the audience will take important lessons. I want, before closing, to extend very warm thanks to the Union for Mental Health, Natalia Treushnikova. You've been very, very important in organizing this, and to my colleagues in the WHO country office in the Russian Federation, Melita Vujnovic, and especially Olga Manukhina. Over to you. Thank you very much to the audience for the patience, and apologies to the organizers for the delay. Thank you.
Спасибо огромное, коллеги. Нам было очень интересно и важно.
Thank you so much, colleagues. It was incredibly important for us to have this session from the World Health Organization. It's been a great honor and a great opportunity to get some insights from other European regions. And we continue with our program going on to our plenary session, psychic health, prenatal and postnatal health. We are a bit late with this. We are late going into it. The co-chairs of the session, Jana Glasman, PhD, President of International Society of Applied Neuropsychology, Research Director of Luria Research Center for the Development of Neuropsychology, Professor of the Faculty of Psychology at the Lomonosov Moscow State University, and Dr. Emilia Afranj, Director at Instituto do Prematuro, Director of Institutional Relations at Mamãe Associada in Brazil. Giselle's presentation that was announced, we were planning to show a video. We are going to publish this video at our channel. It will definitely be available for a long time. You'll definitely have access to it. But because of this delay in our timings, I suggest we start with the second presenter today so that we have time for everybody and we have time for a discussion. Should we have any? Jana, the floor is yours. Thank you so much, Natalia. We are, in fact, very late. And despite the fact that we do have the small opportunity to save some time, thanks to this video being posted from Giselle, I'm going to ask all of the presenters to please stick to the timings, and I'm going to be very strict about it. Otherwise, we are never going to catch up, and it's going to create problems for our colleagues. I announce this plenary session number 1 open: mental health and prenatal and postnatal care for mothers and newborns. And the first presenter will be a leading researcher of the Research Institute of Mental Health at the Tomsk National Research Medical Center of the Ministry of Health of the Russian Federation, professor of the Department of Genetic and Clinical Psychology at the Faculty of Psychology at the National Research Center of the Tomsk State University, Professor Yelena Gutkevich. Yelena, please, you have 15 minutes max. Your sound is distorted. Your sound is, well, your microphone might be off. You have 15 minutes, but the sound coming from you is not very good. Natalia? Apologies, Yelena Gutkevich. Yelena, we cannot hear you. Technical support, could you enable Yelena's sound, please? Please switch off and switch on your microphone, Yelena. Unfortunately, that didn't help. We can't hear you. The sound isn't coming through. Yelena, can you try disconnecting from the session and reconnecting again? Yelena, we cannot hear you. Could you please reconnect to Zoom? Could you please disconnect and reconnect to the Zoom conference? Artyom, can you try enabling her sound? Can you hear me? Yes, we can hear you very well, Zhana. There's no problem with sound coming from you. Artyom, what seems to be the problem? I think the problem is with Yelena's microphone. Yelena, can you hear me now? Yes, finally, we can hear you. The sound is coming through. Thank you so much. So what do I need to do? Do I need to screen share my own presentation? If you can, please do that. It'll be more convenient if we are able to switch your slides at the rate that it's convenient. Okay, I'll try to share my screen. Jean, the way it works for you. So, what do I need to do? Could you enable Yelena's presentation? Okay, we will share the screen on our side. We'll do that, and then you'll let us know when to switch the slides. Yelena, let me start, I guess. I will start with a welcome remark. Dear colleagues, dear participants of our Congress, again, I would like to welcome you all. I would like to thank the organizers for this opportunity to participate in the third Congress Mental Health Meeting the Needs of the 21st Century. And I would like to report on the results of our research that has to do with genetic prevention of mental health in children and adolescents. I would like to start by mentioning the fact that, of course, there is a relevant context that was mentioned about by our deeply respected colleagues. The next slide, please. They mentioned the next slide, please. And if you could quicker, please switch between the slides. I'm willing to go through them faster. The figures on mental disorders across the Russian Federation and the Siberian Federal Districts, which I represent, are indicated here on the slide. Retardation is about 23.7%. There is the UN and the WHO Global Health and Wellness that made very interesting presentations today. Our colleagues also mentioned the fact that over the last 2 years, there's been this epidemic of orphans with a lot of losses, with grandmothers, grandfathers, and parents dying. The overall coefficient, the birth rate is going down. It has been going down over the last few years. And in the Russian Federation, we're also observing these trends. In line with the statistics, the situation degraded. And in the Tomsk region, we're also observing the birth rate decline. The death levels going up. And there is a reduction in the amount of marriages. There's a bit more in 2021, but nonetheless, there's also an increase in the amount of divorces. So let's please go on to the next slide. These are brief stats on the status of pregnant women given childbirth and newborns. So this is data for 2020, and what we see from these stats, illnesses in newborns and prenatal anomalies compared to 2019 and even compared to 2014 in the Tomsk region are about at the same level. There's a small decline, but of course it has to do with the fact that the amount of newborns is going down. Next slide, please.
We have been working on it, and our multi-year research into families with mental disorders has come up with this notion of ontogenetic family cycle. It represents different family situations pertaining to family function, where we foresee different stages in potential genetics-based crisis, where we can expect birth with defects or emergence of pathologies. Currently, our discussions are focused on genetic prevention across several lines, genome-based and phenotype-based. Genotype-based prevention provides for different interventions, whereas phenotype-based prevention is indication for consultations. Next slide, please. Given the conditions where we focus on families of children with mental disorders, we are guided by family genetics principles. These are multivariate pathologies, unlike monogene-based or chromosome-based disorders that are inherited. As a family, there are cultural, emotional, and behavioral features that inform habits and patterns. In a family unit, you usually have several generations: children, adolescents, young adults, adults, and seniors. Given that physical disorders have polymorphism and undefined phenotype nature, we say that these consultations have to cover the entire family and must have a broader range of goals and tools. In the 20th century, our teachers, including Professor Davydenkov, told us that genetic consultation can be a foundation for effective prevention. In psychiatric health, there are differences in application of this because this would be specialized genetic help. To aid this, we've set up a Center for Family Genetic Prevention and Adaptation. We use a multi-factor and multi-system crew of psychotherapists, family therapists, psychiatrists, and data specialists. Recently, the concept of genetic consultation has been revised in a major way. Currently, we believe that genetic consultation has to focus on engagement and communication with a family as a system, especially if it's a system with a history of mental disease. We propose this definition. Family genetic help or prevention is a process of communication that taps a lot of different issues other than genetics, issues that can emerge given a risk of mental health problems in a family, including children and adolescents. This help is delivered in stages. The first stage looks at the plan for the general engagement with the family. A program is drafted that is to be implemented in stage 2 using genetic diagnostics, genetic psychological tools, and genetics and psychological therapy. The efficacy of these interventions is assessed holistically, so we use additional criteria on top of objective reporting. We take into account subjective effects as reported by the families. Here are the key goals that this center addresses: mental health in the families, prevention and adaptation. So we use psychogenealogical studies so that we can come up with a family health profile in the form of a document. When necessary, we cooperate with the Tomsk Institute of Genetics to carry out differentiated diagnosis of inherited and congenial pathologies. We look at polymorphism and we build profiles of mental disorders in the families. Then we have a forecasting of offspring, of screening and prevention. Genetics-related psychological consultation is also part of our tasks that our multi-specialist staff addresses. There are some indications for referral. We mentioned comorbidities, where you have psychosomaticism and adolescents with disability. But then you have relatives in the families. Sometimes you can plan ahead for the possibility of giving birth to a child with psychological disorder. Sometimes the parents have a disorder. The probability is higher for such families, including for families who use substances. Last but not least, we focus on the mental health of mothers, fathers, and especially so for children who were birthed with the help of reproductive technologies. Then we look at the means to support mental health during the pandemic, especially for adolescents. Our research has demonstrated that families with children with mental disorders of different types have plans for additional children in 40% of cases. Most of the families need genetics consultation, and they have taken note of our recommendation and our programs that we've designed for them. Here's a list of most common genetic diseases that we've faced in our consultation. Usually, you will find it under the F section in ICD-10. But let me underscore that our work extends to general screenings. This would be families that didn't have any symptoms. We do preventative screening, we do mental health assessments, and we also apply this to families where extended families might be exposed to mental health issues. Sometimes we faced child schizophrenia, neurotic and mood disorders, including suicidal and depressive syndromes. We have some neurological disorders as well. And now, very briefly, to look at some specific cases. It was mentioned as well, cases where you have pregnancy and addictions. This could be fetal tobacco syndrome, there is drug babies, and then you have fetal alcoholism syndrome. We've seen that, including in children with non-differentiated retardation. These embryonal defects are co-present there as well. But I'd like to stress that these kids and addictive families where you have alcoholism, for example, these kids can grow up to be healthy adolescents with alcoholism. And then they will form their own families who can turn to us for help. Another innovation I mentioned this as well, assistive reproductive technologies. We have recent data on that. Two groups, naturally conceived children and children conceived with reproductive technology. We've looked at their health, both for kids and for parents. For kids, this would be 18 months old. And in these early stages, we've seen that the attitude of parents towards their kids is determined by the use and non-use of technology. However, by 18 months, these differences go away and the family continues with their own natural ontogenetic cycle as determined by the genetics. Still, we continue to follow up. Now I'm approaching the end of my presentation. Another innovation, we had an online survey this year. Of course, we need to monitor the awareness of the population when it comes to ASDs. For example, last year, Ijevskaya et al. Published the data that participated in the global research, Your Genes, Your Rights. Just 1 out of 3 people surveyed knew about potential genetic problems. In our case, respondents indicated their awareness of the inherited etiology of autism. Most importantly, our general sample respondents differentiate these diseases by the communicative skills and functional skills of these families with people with ASDs. They also recognize that there are technologies that can be helpful to these families, and they need to be included into psychological help provided to them. Another line of effort, this has to do with transmissible diseases in children. Might seem a bit unconventional, but our esteemed colleagues, led by Mr. Kazakovtsev, published an article in 2016 that showed general prevalence of mental health diseases in Russia with a retrospective analysis of cases of transmissible diseases in kids. And they have determined a definite causality between incidence of transmissible diseases with their future mental health, at least for Russia. Prevention of infectious diseases is crucial. It is now doubly corroborated, especially given the pandemic. Viral infections are on the rise during this period, and as has been mentioned, this leads to mental health disorders that can have far-reaching effects. So we've developed, in a group of researchers, we've developed a model of multi-factor diseases where you take a system of stomach with microbiota and brain as a dyad. There are such technologies as bacterial reconstruction that can be included into the help provided to families with kids with mental disorders. We've articulated this as a proposition that the service for prevention of mental health needs to focus on families where mental health disorders are present in any generation. This needs to be a multi-tiered system comprising different activities. This needs to rely on communication, population-wide. We want to reduce the inheritance burden of prevalence. On the level of family, we aim to reduce existing problems apart from genetic consultation. This concerns the risks of mental health disorders at different stages of the family's ontogenetic cycle. With that, I would like to thank my colleagues, and to wrap it up, I would like to cite Albert Likhanov, a kids writer from Russia, who said that the more you invest into your childhood, the more you get out of it. But it's up in the air whether your returns are going to be positive or negative, glorious or inglorious. In any case, we need to provide comprehensive support to kids genetically and psychologically. Here are some acknowledgements. Thank you to the colleagues. Thank you to the participants of this great Congress, Congress on Mental Health, meeting the needs of the 21st century. And thank you to the families who participated in our consultations, who are monitored by us currently, and the families who will reach out to us for the first time. We are ready to provide you this help, family-based genetical help. Thank you very much, Professor Gutkevich, for this engaging and informative presentation. Thank you for your great timing. I've looked at the chat on Zoom. I don't see any questions there. So let me give the floor to Professor Dadali. You can see her on your screens. He is the professor of the Department of Molecular and Cell Genetics at the Pirogov Russian National Research University. So we move from Tomsk to Moscow. I see that Professor Dadali has her slides up, so we are ready to listen to your presentation. Thank you for the invitation. As geneticist, I'm head of the research department at the Bachkov State Medical and Genetic Research Center as well, where we look at phenotype manifestations, clinical manifestations, development of pathology, etiologies. We look at prevention of hereditary diseases. Unfortunately, we don't look at the prevalence of mental health diseases, but we touch upon these areas as well. I'm going to give you a brief presentation because tomorrow my colleagues will tell you more about diagnostics and manifestation of certain diseases. First, I'd like to tell you about the change to the definition of mental retardation. In ICD-10, it is defined as a state of delayed or incomplete mental development that leads to impairment of skills during development that determine the general level of intelligence, cognitive skills, adaptive skills, and others. But in January 2022, ICD-11 will take effect, where you have revisions to terminology and some general principles. This affects this circumstance that a lot of new genetic diseases have been identified that are accompanied with mental retardation. Here it will be defined as the impairment of cognitive development, where you have a group of different states that emerge during development. This decreases cognitive skills by 2 or more standard deviations as assessed by standardized quantitative tests. So when we have patients with cognitive impairments in linguistic development, we've been mandated until recently with asking for the results of these tests from them. However, intellectual deficiencies in our patients with chromosome syndromes or monogene diseases has been marked visibly. So after revision, it says in the ICD that if tests are not available, the diagnosis should rely on a clinical assessment based on comparable behavioral evaluations. Onto the etiology. It can be different or impairment of intellectual development. But our knowledge has been advancing as well, primarily based on the advancement of gene technology. Prior to sequencing, the etiology had remained unknown for most of the diseases, but now we've identified 1,718 genes that lead to monogene diseases and syndromes, where symptoms can include mental retardation. There is a couple of dozen of chromosome syndromes that lead to these deficiencies as well. First and foremost, these are monogene syndromes. A syndrome is a stable assortment of symptoms that can be identified in a clinical examination.
When we can expect some monogenic symptoms, there are non-symptomatic monogenic variants of intellectual deficiency. And there could be various development defects, but nonetheless, we cannot allocate the syndromes to a known monogenic syndrome. So these are assessed as non-syndromic monogenic syndromes. The monogenic malformations of the brain, hereditary metabolic diseases, neurodegenerative diseases, and chromosomal syndromes defined by structural chromosome changes. Intellectual deficits with genetic diseases and syndrome can be both inherited or it can be the result of the dysfunction of a particular protein, the toxic effects of enzymatic catalyst products, or product of a gene expressed in the central neuron system and involved in the formation of its structure and function. What are the primary diagnostic methods to be used when the hereditary nature of mental retardation is suspected, like medical consulting, which is offered by our genetics doctors? A phenotype analysis is the first method that allows you to identify specific monogenic syndromes based on a specific set of symptoms. An MRI of the brain needs to be performed, enabling to reveal a certain defect in development of various biochemical screening methods, TMS, enzyme activity analysis, etc. And we also do a karyotype analysis. Our international colleagues suggest doing a chromosome intrauterine analysis, but we think that this is a rather cost-effective method which identified uniploidy, polyploidy, etc. Now, what is the key issue with diagnosing hereditary pathologies? And of course, genetic heterogeneity of hereditary diseases. It's understood as a phenomenon when a clinically identified disease can be caused by mutations in different genes, and sometimes hundreds or dozens of genes. And on the contrary, when a mutation in a single gene causes different clinical forms of the same disease or different bioclinical manifestations of the disease. This is called allelic heterogeneity. In addition, the same disease may have different types of inheritance. I think you understand the challenges that we have to face to diagnose a specific genetic variation. If we cannot diagnose the specific genetic variation, then the entire medical consulting then the efficiency of our diagnostics will be close to zero. We need to make sure that we prevent repeated cases of hereditary diseases and to help with family planning. I wanted to give you an example of the locus heterogeneity with the non-symptomatic mental retardation variants. Currently, we have registered 244 genetic variants of non-syndromic mental retardation. 64 types are autosomal dominant, 72 are autosomal recessive, and 108 are types of X-linked variants. And of course, the search for variants continues. How can we diagnose hereditary diseases? Of course, we need to use molecular genetic methods. There is a variety of molecular genetic methods out there. Recently, before we started using sequencing of the new generation, we analyzed the mutations in specific genes. So we still continue with this type of analysis, and this is done through direct automatic sequencing by Sanger. This method is used still to this day, rarely now. If the syndrome is not genetically heterogeneous, there's a syndrome and there is one specific gene and the mutation leads to it happening, or there is a specific genetic variant that accounts for 50 or more % of the genetic heterogeneity of the syndrome, or there is major mutations, and then we start our diagnostic search. This will reduce the cost. But now what we have is sequencing of the new generation, and this significantly simplifies our lives. We can identify groups of clinically similar syndromes, or we can do sequencing of clinical or complete exome. What is exome? An exome is all of the coding parts of the gene, the non-coding parts of the gene in the exome. So there's 85% of all of the mutations. A clinical exome is a sequencing of 6,800 genes, mutations in which are known to this day and lead to hereditary diseases. Genes which are coded by proteins and mutations in which can lead to hereditary diseases, monogenic hereditary diseases. There are more of those, from 20 to 22,000. Then we can do a full sequencing of the exome, when we can simultaneously have a look at mutations in 22,000 of known genes. Then it's better to perform the true sequencing of the mom, the dad, and the baby. I mentioned 85% of all of the mutations have been located in exomes and 15% introns. When we sequence clinical or complete exomes, we analyze only the coding patches. When we sequence the genome, we can analyze both the coding part and the non-coding parts of the exome. In terms of chromosomal syndromes, first and foremost, we use standard genetic analysis methods. When we analyze the karyotype, we look at the chromosomes using a microscope. The potential of the human eye is limited, of course, and it can capture the duplication, doubling of a patch, only in less than 10 million pairs. And about half of all of the structural chromosome rearrangement are less than 10 million pairs. And then we can use a so-called molecular cytogenic method for analyzing variations in the number of copies of DNA compared to the reference markers without the need for cultivating cells, which, well, is sometimes a struggle. Chromosomal micromatrix analysis enables, in some cases, to diagnose monogenic diseases as well. For instance, if they're conditioned by deletion of an entire gene. If we do clinical sequencing of an exon and we don't identify a mutation in the gene, then in order to diagnose, we can do a chromosomal micromatrix analysis. Both of the methods have their limitations. For instance, the chromosomal micromatrix analysis does not enable a reliably diagnose transplantations, translocations, balanced translocations. They do not have any clinical symptoms, but sometimes there's even a high risk of a child being born with a chromosome pathology And of course, they have a very high percentage, up to 25%. There's a risk of miscarriage and loss of fertility. This is a diagnostic of the autosomal dominant mental retardation type 1 when it's caused by deletion of an entire gene, MBD5. Now I would like to give you a number of examples of the clinical genetic diagnosis of certain syndromes based on analysis of phenotypic traits. And I'll walk you through the algorithms. In terms of what we can do in order to specify the diagnosis, we can identify the type, we can identify the risk of a baby being born with the pathology, and we can carry out prophylactics to prevent the birth of such a child. Could be pre-symptomatic diagnostics using extracorporeal fertilization. This will be decided together with the family. The Beckwith-Wiedemann syndrome, when babies are born with a larger weight during the postnatal period, they have macrosomia, macroglossia, the increased size of all of the internal organs, including the liver, the kidneys, the pancreas, the heart. They get umbilical hernias and an increase in the bone age. And they have notches on their earlobes, and of course there is an intellectual retardation. This syndrome can be diagnosed following a clinical analysis. Then we need to identify the gene or the chromosome rearrangement that's responsible for the syndrome in this specific child. And this way we can consult the family. This syndrome can be caused by mutation of 3 different genes on the 11th chromosome. We build a small panel with the 3 genes, and at the same time we analyze the mutation in the genes, and sometimes we might not be able to identify the mutation using this diagnostics method, and then we use the chromosome matrix analysis to identify deletions or duplications in the imprinting region. And this way we can use 2 different methods for diagnostics, and then we decide which sequence is best suited in this specific situation. Or, for instance, the Rubinstein-Tabin syndrome, which is also a very pronounced syndrome, low height, a nose deformation protruding back of the nose, a very small chin, an unusual smile with half-closed eyes, the extension of fingertips and toes, and intellectual retardation as well. We know that there are 2 types of this syndrome. And first and foremost, we diagnose the first and the second type using a panel of genes, 2 genes which are localized in chromosomes 16 and 22, and 90% can be diagnosed using this gene panel. If there is a lack of the mutation, we look at the 16th chromosome, and then we're able to capture the remaining 11%. So diagnostics is possible again using 2 methods, the sequencing method or the chromosome micromatrix analysis. And we decide that together with the family and together with our colleagues molecular genetic experts. This is the FISH analysis. That's all I had. This is my brief presentation. Thank you so much for the invitation to make the presentation, and I'm ready to take your questions should you have any, and if we have time. Thank you so much, Elena. That was incredibly interesting. I had a look at the chat. We didn't have any questions, so I will announce the next presentation. Professor Borisa Kazakovtsev, Professor and Deputy Director of Research at the Serbsky Federal State National Medical and Research Center of Psychiatry and Narcology of the Ministry of Health of the Russian Federation. He's going to make a presentation on organization of obstetric and gynecological care and prevention of mental disorders. Boris, are you with us? Boris? Boris, I can't see you. Just a minute, Zhana, let me reach out to Dr. Kazakovtov. Yes, Boris Kazakovtov. We're waiting for his presentation.
Тема доклада организация акушерской гинекологической помощи и профилактика психических расстройств.
Organization of Obstetric and Gynecological Care and Prevention of Mental Disorders, a topic of our next presentation.
Артем, переключите, пожалуйста.
Artem, we can't really hear you.
Борис Алексеевич, включите у себя микрофон и видео.
Boris, if you could please enable your webcam, or Artem, could you help us with this? Жанна Маркина, we're working on it. Unfortunately, we are really short on time. Жанна Markina, could you please fill this pause? Жанна, would it be possible for us to change the order of our presentations? Well, yes, we can. If Artem can indicate the fact that he can't solve the tech glitch in the next couple of minutes, and then we'll change the order. So. Artem, how much time do you need to try to fix the problem with Dr. Kazakovtov? Artem, we need 5 to 10 minutes to resolve this issue. Then what we're going to do is, while you work on the problem, and we're going to go on to the next speaker, we have Professor Irina Kupriyanova, professor and leading researcher of the Research Institute of Mental Health at the Tomsk National Research Medical Center of the Ministry of Health of the Russian Federation, a professor at the National Research Center at the Tomsk University. She's going to talk about the assessment of mental health of women with different pregnancy pathologies in the context of prevention of mental disorders in children. Irina, are you okay to make your presentation now? We can now see it up on our screen, so just give me a second, please. We can hear you, and please go on with your presentation. Irina? I'm struggling to get it to go full screen. I would like to say hello from all of the Siberian psychiatrists, and I would like to congratulate everybody on this important forum, which is particularly relevant, and it's great that we got together and we're bringing together professionals from different specialities. Dear colleagues, I'm going to talk about the assessment of mental health of women with different pregnancy pathologies in the context of prevention. Irina, could you make it full screen, please? In women with problematic pregnancies, there is a sharp decrease in the indicator of psychological adaptation. I cannot make it full screen. It doesn't matter. Oh, okay, here goes. It's good though. There is a distortion in the perception of their own corporality. There is increased anxiety, a reduction in psychological protection, and a change in subjective perception of the quality of their life. The tension of the pregnant women impedes dual bond formation between the mother and the child and has a negative impact on the development of the fetus. Diagnostics of psychopathological manifestations during pregnancies is difficult, as many symptoms, such as lability of the emotional background, increased fatigue, changes in appetite, and reduced cognitive functions, are often seen in physiologically normal pregnancies as well. Psychopathological conditions are very common among women with pathological pregnancies. Somatic disorders, aggravated obstetric and gynecological anamnesis, socio-psychological and individual psychological characteristics of the pregnant woman, biological factors have an adverse effect on the psyche of the pregnant woman, forming difficult psychopathological manifestations leading to the severity of obstetric complications. I'd like to present an inter-regional project, mental health of women with pathological pregnancies, including the following cities: Tomsk, Novosibirsk, Krasnoyarsk, and Moscow. The project ran in 2009 to 2021. It's very long. It says the key coordinator was the Tomsk Research Institute of Mental Health. The Academy of Sciences, educational institutions participated in the project, including commercial organizations as well, the Siberian State Medical Institution, the Academy of Postgraduate Education of Tomsk, Novosibirsk, and Krasnoyarsk, and birthing homes. There were 4 monographies, a number of PhDs. I'm not going to read them all out to save some time, but there was a lot of research performed based on this project. There were 18 articles published. I recommend you to read them. Participants of the project presented the results at 46 different events, at 4 international congresses, 25 Russian conferences, and 12 regional scientific events. 3 project participants have completed their postgraduate studies. The psychological mental health of women, we looked at it in 2 areas: mental health of women with pregnancy pathologies and mental health with the risk of miscarriage, neuropsychological disorders, and preeclampsia and hepatitis C and B. And in the project, we used a common methodological approach, a traditional psychological qualification of the condition, and dynamic observation, diagnosis of the condition using clinical scales, identifying the level of stress, subjective evaluation, and the subjective assessment of the quality of life. 86 healthy pregnant women were monitored as a control group. There's a slide with an ethnic breakdown of the pregnant women with chronic diseases, hepatitis B and D. This is a big social issue for our migration. Migration leads to the spread of virus diseases, and this has an impact on the health of pregnant women and newborns. Research of addictive behaviors of pregnant women indicates that women with chronic viral hepatitis, hepatitis C, smoke in 28% of cases, and they use intravenous drugs. Obstetric gynecological history in pregnant women with chronic viral hepatitis show a big percentage of medical abortions in these patients. Nonetheless, we see that these women also experience miscarriage, premature birth, and frozen pregnancies. Probable infection paths could include dental care, operations, manicure, medical abortions. We didn't get any confirmation of piercing or tattoos being probable infection causes, trips to exotic countries, but going forward, this will probably be identified as one of the probable infection paths. Psychopathological manifestations among pregnant women were characterized by a high level of depressions. It's a well-known fact that taking antivirus medication leads to depression. I would like to point out that any research on virus diseases today are becoming particularly relevant because essentially we need to correlate virus hepatitis and COVID. Mental manifestations of complicated pregnancies were characterized by a high level of depressive disorders. If we look at pregnancy complications, we've identified a high level of dissociative disorders, and we're looking at the structures described by Professor Semke. Mood disorders is a complex which is in line with the register of mental disorders, which lead to clinical manifestations, and there are 4 different options. Somatoforms, neurosentience, mood disorders, and phobias were led to placenta, preeclampsia, pregnancy pathology, and miscarriages. Affective disorders were manifested among patients with viral hepatitis B and C. Stress level analysis led to the fact that it would increase in patients in neurotic conditions. And there was a clear difference between mentally stable and non-stable patients. The first line is neurotic mental anxieties. For pregnant women, they had a mental triad, tension and stress. With preeclampsia, there was a high level of somatic stress. When we compare grades, we characterize the quality of lives in patients with various neurotic conditions, we've identified that the highest level of the quality of life was identified with patients with physical abstinea, and the lowest was for patients with somatic PDA. Anxious post-traumatic disorder and somatic disorders led to the highest level of anxiety. In pregnancies with neurotic disorders, there was a decrease in protection mechanisms. These are the protection mechanisms with preeclampsia, with various other pregnancy pathologies, the placenta pathologies, and during miscarriages. When there was a threat of miscarriage, there was an increase in archaic protection methods, such as regression. When there was a pathology of the pregnancies, there was a tension of compensation. With preeclampsia, there was a reduction in intellectual reflection. With neurotic pathologies, women increased the scale of non-adaptive styles of combating stress versus other groups. During miscarriage, there was a reduction in the emotional and cognitive behavioral strategies. With placenta pathology, there was a decrease in emotional mechanisms. Of preeclampsia, there was the lowest indicator of open strategies. Coping strategies. The change in the coping strategies is a significant factor in adaptation and disadaptation in women with pregnancy defect. Adaptive emotional and behavior strategies would differ versus healthy women. Taking into account the complexity of using medication in this group of patients, the data that we received was taken into account and ability to use drug treatments. Low subjective assessments of the quality of life was a specific indicator, leading to the development of biosocial conflicts, prenasal reactions, neurotic disorders, and affective pathologies. In these patients and these pregnant women, there were some pathological stigmas, such as troubled relations in the family, or communication issues, a lot of somatic issues, starting from the chronological issues, the issues with the digestive systems, medical abortions in the past, professional tensions, negative relations, negative attitude towards the pregnancy, and negative attitude towards their body, and ambivalent experience during the pregnancy, and issues in the family. Of course, this would lead to a catastrophe, a biosocial conflict. We looked into problems in families and pregnant women, and we've identified disharmonious and contradictory past and present relationship with their parents, with their mother, in the past and in the future, with phobias, lack of participation on the part of the mother, or excessive control. With anxiety disorders, we identified mutual attachment with accusations in all unfortunate stressful moments in life, obsessive compulsive disorders.
Зависимые отношения, отсутствие
There
самостоятельности.
was a conflict, detached relationship with the mother, with dissociative conversion disorders, cold, formal, relations devoid of a close emotional contact, somatoform disorders, codependency, and hypercare. Neurasthenia, the relationship with the mother was formed under the weight of maternal problems. The sick mothers that ignite the fear in their kids, and they change the psychotic condition of the woman. At the fourth conference that took place in Tomsk at the Symposium of Prenatal Psychology, Professor Dobrikov and Professor Zvereva talked about relations with the father as well. In subsequent research, we identified that for a miscarriage, the father plays an important role, and it's not just relations or lack of relation and alcoholism, but in families with a caring husband, similar psychological issues would occur. The girl would not mature and would not take on the role of the mother willingly. Another problematic issue that needs to be looked into is the use of psychopharmacology. The lowest frequency of the use of drugs during pregnancy was identified in Nordic countries from 44 to 47%, and the highest in France, 93%, in Germany with 85%. In the early stages of the pregnancy, 39 to 76% of the women take medications. The frequency of the use of drugs that are prohibited during pregnancy varies from 0.2% in Ethiopia to 4.6% in the US. The frequency of using drugs with a risk of category D was between 2% in Italy and 59.3% in France. A significant proportion of the women are exposed to medications during pregnancy, and they use drugs with potential risks. And the same data demonstrates the need for post-marketing evaluation of the use and the risk profile of the drugs used during pregnancies. It is necessary, in the event of a need for a psychopharmacological treatment during gestation, the treating physician and the pregnant woman should weigh the benefits and the potential risk of treatment. And this is particularly relevant to girls that had issues with the psychotic state before their pregnancy. And it should be limited to certain critical periods, and if necessary, they should be carefully selected to take into account the course of the disease and its negative impact on the fetus and the health of the pregnant woman. The risk of using antipsychotic agents, drugs, is so that they can penetrate the placenta and they can have an impact on the fetus. And this can lead to malignant tumors being formed in newborns and can lead to anomalies of the fetus. The benefits or harms of antidepressants is an open-end question still, due to lack of information, due to lack of comparative studies, and the complexity and the high responsibility of special studies dedicated to the topic when planning pregnancies. In our research, women with pregnancy issues, so we refused to use drugs, and we developed a 3-level program. The first program, which is a psychoprophylactic one intended for patients with problem pregnancies, included an educational cycle with a training in relaxation techniques and the basics of self-regulation. The second program was a psychotherapeutic one designed for pregnant women with problem pregnancies and neurotic disorders. And this program included the previous one. It was complemented by rational and cognitive behavioral psychotherapies. The third program, intensive individual psychotherapeutic, designed for patients with problem pregnancies and mood conditions. The first and second psychotherapy programs were mandatory, followed by a trans-based psychotherapy and neuro-linguistic programming. Natalia, I have to remind you about the timings, unfortunately. It took into account the level of stress. The clinical efficiency was assessed following a remission schedule of borderline, and the efficiency there was at 93%. Remission A, which is full remission. Remission B is a significant improvement. C, residual disorder symptoms. And there would be various obsessive compulsive disorders that remission D, no remission. As a result of these programs, women with problematic pregnancies had a significant decrease in the level of their anxiety. They subjectively started to perceive their life at a quality level, and social factors. You'll see the numbers on the slides. The results of our project. We have examined 1,055 pregnant women with pregnancy pathologies of 826. During pregnancies, women received high-quality psychological, psychotherapeutic, and psychiatric care. 1,067 healthy babies were born. 5 guidelines were developed by project participants. Conclusions. The medical and social significance of the problem of maternal and child health is incredibly high and requires special attention to the research of the mental health of pregnant women. The quality of the provided psychotherapeutic assistance and the development of innovative strategy. The data obtained can be used as a basis for conducting comparative studies of the mental health of pregnant women in different countries, as well as research factors related to the quality of obstetric and gynecological care, the provision and introduction of psychotherapeutic assistance to women in childbirth, and preventing the development of various pathologies. Thank you so much. Thank you so much, Irina. Thank you for such a wonderful interdisciplinary study and such amazing results. I would like to congratulate you on that. And at this, I'm passing the floor to Professor Boris Kazakov. We've already announced his presentation. What's going on technically? Have we sorted the issue? Can you hear me? Yes, we can. We can hear you perfectly. Thank you. Good afternoon, everybody. My presentation is based on the results of an analysis of data from the Russian Statistical Associations. Primary morbidity for all mental disorders per 10,000 people of the population between 2005 and 2015 decreased by 22.5%. Primary incidence of psychosis and dementia, again, per 10,000 people of the population, decreased over the same period by 6.9%. So next slide, please. Next slide, please. Over the same period, over 10 years, the primary manifestation of schizophrenic spectrum disorders decreased by 30.7%. Taken into account presentations made by our genetic experts indicates the fact that it could have been some genetic factors that played a role more so than others. The next slide, please. Primary manifestation of non-psychotic mental disorders, as I said, decreased by 30.7%. And non-psychotic mental disorders, that's the next slide, decreased. We need to switch the slides faster, decreased by 24.7%. And in light of the presentations that we've heard today, what I find particularly interesting is that over the same 10 years, primary manifestation of intellectual retardation decreased by 43.8%, which is also a significant drop. What are the causes of this reduction? We think that there is over the last 25 years, we've seen an increase in the quality of pregnancy and childbirth support in the country. The second factor is the quality of prevention and treatment of infectious diseases in children, which is something that we also talked about today, and the quality of injury prevention across all age groups. So next slide, please. Talking about the quality of pregnancy and childbirth support, the fastest or synchronous decrease is in the rates of primary morbidity and primary disability in mental disorders respond to the decline in rates, such as hypertensive disorders complicating childbirth and diseases in genitourinary systems in pregnant women. Next slide, please. The quality of pregnancy support and childbirth plays a key role. With a time interval of 5 years, there's a reduction in primary morbidity and primary disability in mental disorders, responding to the following processes: an increase in deliveries on time, reduction in anemia in pregnant women, and birth disorder going down as well as an indicator. Next slide, please. Talking about regional variations. Regional variations in the primary incidence of mental disorders suggest that there are untapped reserves in terms of preventing the impact of environmental factors. So that's just a general statement. Let's go on to the next slide. Talking about perinatal centers and support, perinatal centers play a key role. From 1995 to 2015, the number increased 12 times across the country. From 2005 to 2015, the number increased 1.7 times. The process is slowing down, as you can see, but nonetheless, the increase in the amounts of perinatal centers continues. The process of gradual accumulation of this type of institutions took place across most federal districts. Next slide, please. Analysis of organizational factors. The number of consultations offered to pregnant women, the number of wards, beds in hospitals for pregnant women and women in labor, the number of gynecological beds and day hospitals, the proportion of women who have had access to general practitioners and passed some lab tests for syphilis, HIV, and hepatitis B and C, the number of women's consultations across the whole country, the number increased by 6.1% from 2005 to 2015. There's a high level of this indicator across federal districts with high rates of reduction of primary morbidity in mental disorders. And the proportion of pregnant women who have been placed under observation during the period of up to 12 weeks of pregnancy is also an increase. Next slide, please. The number of beds for pregnant women and women in childbirth, in labor, in day hospitals in federal districts with high rates of decrease in primary morbidity, mental disorders increased, exceeded or were close to the national average. General practitioner examinations and lab tests for syphilis, HIV, and hepatitis B and C. There was a decrease in primary incidence of mental disorders in the country as a whole, began simultaneously with the decrease in diseases of urinary system in pregnant women. Similar trends were observed in most 7 out of 8 federal districts. Thank you. The conclusion. The results of the present study can be used to research the impact of mental health indicators on improving the quality of obstetric and gynecological care by using them in the regions of the country, and procedures for offering medical assistance in the field of obstetrics and gynecology approved again for the second time by the order of the Ministry of Health of the Russian Federation from the 20th of October 2020. Thank you so much for your attention. Thank you so much, Boris. It was a very clear presentation, and a lot has been done in the area. Thank you so much for sticking to the timings. I can now announce the last presentation from our Brazilian colleague, the president of the Latin American Federation of Psychotherapy and the vice president of the Brazilian Association of Psychotherapy, Emilia. She's going to be talking about premature births.
Brazil, Emilia Afroni, president of Latin American Federation of Psychotherapy from Brazil, preliminary delivery.
Thank you very much. May I share the presentation?
Yes, yes, please, we are listening for you. You can speak in English because we have simultaneous translation for everybody who want can listen.
Well, thank you for all. And I would like to, I am very happy to be here, to be back here. This
Press F5, please.
Next one, I can. Okay. This was my first visit in Russia Congress. It was 8 years ago. Was anybody here at this time? Well, in this moment, I present two papers, one about preterms and the other one was about children under the risk of vulnerability. I continue my working with both groups, but here in Russia, my focus is in preterms, and here you have the classification. I came back to Russia 3 years after, in 2016, for the first Congress on Mental Health. In that time, in that opportunity, I explore a little more the situation of prematurity in my country and around the world. You see the word and different tones of blue. Estimated numbers of preterms births in 2010. 10 countries account 60% of the world preterm births by rank. Check if your country is here. As you can see, my country is number 10. 2 years after, I was here again for the second Congress of Mental Health. And I made another presentation about my work with preterms, going deeper in the psychotherapeutic aspects. I expanded the boundaries of my investigation, reading local and foreign articles report about the topic. Year by year, I was working with other professionals, always trying to find better ways to help these children and adolescents. here I am again to continue talking about this, the prematures, and to convince you that we should worry about. Just a reminder, 10% of the global population was born prematurely. This year, I decided to collect all the information and experience that I accumulated over the last 9 years in one book, which I am distributing free of charge. In the book, I tell my story with preterms, my educational background, and I describe an idea that I had with the photographer RED method. I developed a project of having the children taking their pictures with their images when they were babies, and the result was amazing. Over the last 9 years, I had more than 100 patients, including the children, their parents, and other professionals. Now, I would like to share with you one of these cases. My intention is to illustrate and reinforce the importance of the psychotherapeutic approach with preterms. I start to work with Joe and his mother in October 8th of last year. Today is 1 year, exactly 1 year later. Joe was born with 26 weeks. Remember the classification? This is very extremely premature and low weight. In this moment, he was 2 years and a half. Joe was born with this, and now in this moment when I start to treat him, he was 2.5 years old. In this 2.5 years old, in outpatient, he received treatment and assistance from all the professionals that as you saw before, pediatrics, doctors, physiotherapists, all the members, but not me, because I am not a member officially. I am a volunteer. They perceived that he had problems of expressing himself, and they didn't know how to diagnose. They have suggestions, possibilities. Example, Asperger syndrome, other problems, but they were not sure. They called me then to help, to auxiliate. So my relationship started with him. At first, I had sessions with his mother early in the morning, and he was sleeping because he is 2 years old and a half. 1 minute, please.
Simply pass it.
Okay. Well, he had problems to relation with the others, to communicate, and well, In the beginning, it was very difficult to communicate with her mother. We are on pandemic and we start online. She on her cell phone and me in a computer. Well, it was very difficult to communicate with her because she is very shy, very introspective, and she has a lot of problems and issues that she brings from her childhood, from her life, that were not solved at the birth of Joe prematurely, made the situation even worse for her to express herself. But despite of all the problem, she was very respectful to me. She always present every session on time. In spite all the problems of communications, and little by little, week after week, we were building our relationship gradually. Until one day, more or less 2 months after Joe started to get up very early in the morning and appeared in the screen, I could not communicate with him because only she had the earphone. At first, I saw him and I find to communication by gesture to say hello, showing these toys, Muppets, like this. The other sessions, he continued appear, and I began to bring some toys, puppets, to try to attract his attention, try to communicate with, and he reacted. Until one day, I brought a specific toy in front of the camera, and he smiled so. I would like to show you how I did. Something like this, to put him talking with this. Can you see? Yes. Well, with this toy, he put a big smile, showing his teeth and the eyes big, very big. And we start to communicate more. Then I was sure we were communicate, but I discovered that the mother was using the earphone and he never listened to me, never. I comment this with her mother, his mother, and until this moment on they share 1 ear for each one. Then gradually he were communicated. He never spoke, but I could perceive that he understood me. He was participating in the session with her, and gradually, little by little, our communication was improved. During the process with the mother, I perceived that she had a moment that she was out our conversation. Her body was present, but she was absent-minded. I could clear from her eyes. Then I commented with her, and one day she perceived, she remembered that he, Joe, called her one day, "Mommy, Mommy," and she had a moment. Wow, maybe that I had this moment of absent-minded, of getting out, and he's calling my attention. This mother.
1 minute, Emilia. Emilia,
What?
1 minute.
Okay, is this my presentation? And I would like to convince all the people that is very necessary stay with service, psychological service with preterms. Thank you very much.
Muito obrigada. И большое спасибо всем.
Thank you very much. Thank you very much to everybody for your very interesting presentation. Thank you so much for being so punctual. And in these harsh conditions that we're in, we're almost half an hour behind and we're still caught up. And we managed to end our session on time. In 15 minutes, we're going to go on a break now, and we're going to come back for plenary session number 2 here in the first hall. We're going to be talking about mental health and well-being in preschool children, going from the prenatal period now to preschool children. 15-minute break.
Перерыв.
Развитие различного генеза, расстройства поведения, невротические расстройства, органические и психические расстройства, синдром раннего детского аутизма, шизофрения, легкая и умеренная умственная отсталость. Врач-психиатр совместно со специалистами отделения разрабатывают индивидуальную программу каждому ребенку и реализуют ее в условиях отделения. Детям и подросткам, помимо лечебно-диагностической помощи, предлагается курс занятий с логопедом, психологом, дефектологом, занятия лечебной физкультурой, изобразительным и музыкальным творчеством.
Предоставляется уникальная возможность творческих занятий в мини-группах по 2-4 человека, что очень важно не просто для развития фантазии, воображения, мелкой моторики, но и прежде всего для самораскрытия ребенка, повышения его самооценки.
It's important to boost the child's confidence, and the parents that come with the parents, the grandmothers and the grandfathers have the opportunity to reach out to any doctor with any question while the
Доказано, что чем раньше начинается целенаправленная работа с ребенком, тем более полным и эффективным могут оказаться коррекция и компенсация нарушений, а в некоторых случаях возможно и предупреждение вторичных отклонений развития. Особое внимание уделяется диагностической работе, позволяющей оценить степень адаптации и
enabled, the better the result is going to be.
Следующая работа ведется по специально сконструированной индивидуальной коррекционно-развивающей программе с учетом закрепления ее родителями в домашних условиях. Средний цикл занятий для детей и подростков обычно рассчитан на 2 месяца. За это время, конечно, невозможно коренным образом изменить
The
ситуацию.
average cycle is 12 to 1 month, so this is not enough to change the situation in the family, but you can set the right vector for the parents and set them moving in the right direction. Parents need to understand that there's one component that we cannot change. That's something that they're going to live with for the rest of their life. The kid needs to, well, they need to adjust to the specifics and understand that we can change some of their behaviors, but the personality is vulnerable, particularly when they come to us with kids that are 10 to 12 years old. They already have their personalities formed. We just need to describe it into a context, a framework of human relations, but we need to accept the children for what they are, looking and judging their actions, not the kids themselves. There is a speech therapist and a psychologist working with the group. Usually the group is made up of 6 to 8 people. Algorithmics helps them to develop their passive and active speech because they have the opportunity to repeat sounds and words pronounced by the adult. Logarithmic exercises help them develop their speech breathing and rate, develop their motorics and their face muscles, and helping them to develop their speech. Temporhythmic and melodical and intonation characteristics of speech are also boosted. They can combine movement and speech, and a single rhythm has a positive impact on developing this spatial orientation. In order to develop the creative skills of our little patients, we have pottery classes, and we know about the impact of clay on the emotional state, helping them to develop their focus.
Занятия с каждым ребенком строятся по индивидуальному плану.
Developments with each kid.
Задержкой психического развития, умственной отсталостью. Также ОМИ-ВИСТА эффективно...
Will help them. This is also efficient when working with mood disorders and behavioral disorders as well. With the multi-sense OmniVista system, starting from April 2012, the best positive trend is identified for kids which are suffering with early infant autism and a retardation in their physical development. So the system was used in at least 2,000 sessions. So the new system helps us expand the tools that we have available, improving the quality of the medical psychologists. There is a special set of exercises aimed at developing speech, memory, and focus. We need to train the brain to properly process information from sensory organs. This system is recommended for hyperactive kids. The trainings are based on balance board exercises and vestibular exercises. Neuromotoric correction is a great exercise which helps to work with the defectologists and boost their efficiency.
Another method which is used there is taping. Tape is made with high-quality cotton. It's highly elastic and it mimics the human skin. The tape is elastic, which means that when applied, it goes along with the skin. We use this treatment in order to improve microblood flow and lymphatic flow around the neck area. There is a special application pattern to achieve this. We also use taping for neuromotor correction, that is to stabilize the waist area. Then, when speech therapy is applied, taping is used in order to help the speech organs, as well as the face muscles for mimics. Tape also engages the various receptors found in the skin. It sends the signals to the brain, which stimulates it. In their efforts, the experts of this department help parents be accepting of their child development and then guide their developments in education and correction, so that through small steps, they can achieve the maximum social adjustment for each particular case. So we have our patients making an threading exercise in his own pace really well. So making a loop and going the other way around. So that's how we make the base layer for our weaving operation. Then we need pure white wool. Is everything fine? Working out okay? Time goes on. That's natural. Show me the way you did it. Great. And then you add wool in, right? Can you show? Show me. Little by little, right? Great. Doing pretty well there, right? Getting the wool ready. You need to add some more, right? Do you? So how much are you going to add? Piece by piece. Great job. Then you get nicely done wool. Bit early. Some more work to do. We have a lot of wool to process. Okay, I'm not going to bother you anymore. Keep on the good work. Imagine that the world around you is chaotic. Objects, people, events, you don't know what to expect. That's how many kids perceive their reality, and it's a struggle. But you need to adapt. We established 2 centers to help kids with speech impairments, behavioral impairments, and educational impairments. Our inclusive center has groups for social adjustment for school kids with invalidity, with special needs, where kids can gain autonomy and social skills. You kid, where do you go? What do you want? I want happiness, which means to make friends, to not be afraid, to get new experiences, to acquire new skills, to go to the regular school, to go grocery shopping, to go to the movies. In 2014, we established a speech therapy center for kids from 18 months to 18 years. We help with linguistic development, we do rehabilitation and developmental classes. We take the severest of cases with Down syndrome, Rett syndrome, Martin-Rell's syndrome, Asperger syndrome, psychological development impairment, and ASDs. We have unique techniques, fast forward in time, and many others. It's very important for us to take a personal approach to each individual kid. Over 3 years, we've helped adjust hundreds of kids. They now go to regular schools and look pretty much the same as their peers. It's a great achievement for us. Each kid needs to be sure that they are loved, no matter what. So give your kids this love and come to us because we can help.
Для меня главное в проекте «Тренировочная квартира» заключается в
The
том,
key thing about this project for me, the adjustment apartment, is that my son, for the first time, has been able to live independently for almost 4 months, living his own life, which is unprecedented. This project, the training apartment, appealed to me because I wanted to be independent, to live on my own, to meet new people. So I've acquired some life skills. So we are going to tell you about our project, the way we've contributed to the training apartment project. Colleagues, we can continue with the agenda if you are all ready. So, do we begin? Yes. Dear friends, dear colleagues, let us begin our deliberations on mental health and well-being in preschool children. The co-chairs for this section are Professor Martin Musalik, Professor of the Faculty of Physical Education and Sport at the Department of Anthropology and Humanities of the Charles University in the Czech Republic. And we also have a humble servant, Professor Nikolai Veraska, professor of the Lomonosov Moscow State University. The first speaker is going to be Professor Жанна Glozman. Professor Glozman, are you with us and are you ready? If not, I can deliver the first presentation. The timing is 15 minutes per person, and we'll have to wrap up by 5:15 Moscow time. Professor Verasko, let's start with you, and then we'll follow up with Professor Glozman. Okay, will do. And then let us start the slides. All right. I'm going to talk about the development of attention and emotions in preschoolers, as well as their cognitive development. You see, the cognitive structures can be classed into two types. Some have to do with formal thinking, and then you have dialectical thinking. In the former case, you see this cyclical pattern, as was shown in the slide. Then, if you speak about the structures, they facilitate dialectical thought actions. These dialectical thought actions include those that are listed in the slide. These are operations over situations in the minds of children and adults, naturally. We've developed a number of methodologies that enable us to trace dialectical development in kids. Here is, for example, a creative depiction of a tree. Then the kids are tasked with drawing a tree in an unusual way. Then we have overcoming of contradictions, because something can be both black and white, and we get a lot of responses naming zebras. And then we have the next slide. So recognition of these basic developmental processes is based on these cyclical structures. In particular, these could be seasons of the year or cycles within the day. They correspond to the dialectical thought actions, which means that dialectical thinking is part of such processes as creativity, making something creative, a creative product. Then it is involved in overcoming contradictions. And it also contributes to our understanding of developmental processes, for example, various cycles. Here are some methodologies that we use. For example, cycles, the way kids perceive them. We show them sets of pictures, and they need to arrange them in a particular order, in order that corresponds to a cycle. Example, you have sugar dissolving in a teacup. That's one of the classical tasks that kids get. Apart from that, we investigate the links between cognitive development and understanding of emotion. Our theory of emotion understanding is based on the theory by Pons and Harris. They identify three aspects that have to do with understanding of emotion by kids. Here are some methodologies or techniques that we used in evaluation of emotional comprehension. Kids are presented with certain situations and they need to evaluate the face which is appropriate for the situation above. It turns out that comprehension of emotions is linked to dialectical thinking. In particular, it has to do with understanding of cycles or the kid's ability to make a creative product in the form of an unusual tree, for example. So creativity. We've looked into the understanding of mixed emotions as well. In this setting, we tell different stories to the kids, and then we ask them whether the emotional response was adequate there. Then we've identified a significant correlation between recognition of mixed emotions and the test scores on dialectical thinking. Apart from that, we took some classical tests developed by Jean Piaget and tried to use them in order to establish links of them with understanding of emotion. Here is a probability task by Piaget. And then we've seen some link, specific link between dialectical thinking and the Piaget tests, in particular, in the probability task. When a kid is tasked with estimate the likelihood of certain events. Then it turns out that explanations, internal explanations of emotional states in others is, among other things, linked to the scores on Piaget tests. So, to conclude my brief report, I'd like to say that understanding of emotion and mixed emotion involves two types of processes. First, you have formal thinking processes, and second, you have dialectical thinking processes. This means that when we address development of emotional perception in preschoolers, we can state that it's necessary to account for both cognitive processes as mentioned. And it means that we need to not just diagnose them, but also try to shape their development. Thank you.
So now, hopefully, well, the proposal I would make is, if you don't mind, let's do the presentations first, and then if we have time at the end, we will open up for a discussion. So the floor then goes to presenter Jana Glassman, a neurological approach to the prevention of mental disorders in children. Professor Jana Glassman. Unfortunately, she's not here yet. She will need 10 more minutes to connect. So who else can make the presentation now? Let's have a look. And we have preventive measures to enhance neurocognitive development in early childhood. Professor Carla Anonati from São Paulo, Brazil, PhD in clinical psychology, director of the Centro Integrado de Neuropsicologia. Psicologia.
Hello. It is my honor and pleasure to give this lecture today in such a prestigious Congress. Thank you very much for the invitation. Today, I will talk about preventive measures to enhance neurocognitive development in early childhood. Relationship is the key to a significant childhood development. Vygotsky mentions that man is constituted through social relations. Babies already notice feelings of acceptance and rejection. These experiences stay registered in their minds. Experimental studies indicate changes on the neuroendocrine and behavioral systems of babies that suffered from privation on the beginning of life. Early experiences influence the growth of the brain. Experiences of positive affection related to pleasure and safety cause an increase of synaptical communications. Cunha says that the level of cortisol on the saliva of babies of depressed mothers cause decrease on the synaptical density and on the serotonin. Mota affirms that the heart frequency of babies of depressed mothers is considered high. Jones mentions that babies of depressed mothers have more activation of the right region of the brain. Field affirms that this is related to emotional privation. Look at the negative consequences of social neglection. These are brains of 2 3-year-old children, one normal and one who suffered from extreme neglect. The one who suffered has not only the size smaller, but also internal structures are different of the brain. They are underdeveloped. Bowlby considers that a child which lived a positive maternity will have an adequate brain structure, developing a safe attachment system and trust internalized. This way, we'll be able to relate with the world with more self-confidence and courage to deal with challenges and dangers, becoming more resilient. Resilience suggests mental flexibility to deal with adversities and overcome them, reaching autonomy and independence. Leal points that there is an innate impulse that reaches for the reaction of the significant other. The baby relates himself with a person which seems to him the legitimate and responsive other. Fonseca affirms that a baby is a social human being and that bond is the first step to intelligence. In this moment, let us propose some basic orientations to parents and caregivers of children. Pay attention to the initiative of this baby and respond to them, showing that you are present within this dynamic relation. Give holding. Hold the baby firmly and safely to pass security. Look the baby in the eyes when changing diapers, when breastfeeding, and in all occasions when together to create visual, tactile, and auditory contact. Emphasize the emotions that appear. Let the emotions emerge and nominate them. Be complete in the relation. Touch your baby and nominate where you are touching and the tender feelings that emerge. Talk to your baby. Establish a relation with him. When the baby does a gesture, nominate and do the same gesture back to show that you are with him, following him. When the baby emits a sound, baby talk back to the baby. Nominate your and his emotions. Communicate in a sensible way with your baby. Leal emphasizes that the communication occurs in a go and come back and is observed very early in the baby's life. This is the root of motor, affective, and cognitive development. Vygotsky affirms that instruments, actions, and social relations are presented to the child in the first instance at an interpsychological and social level, and only later it will occur at an internal, intrapsychological, and subjective level through the process of internalization. Vygotsky explains the zone of proximal development, when a person who knows more helps the one who knows less to pass from the level of potential development when he still needs help to the level of real development when the person is already able to do it alone. Let us look at some interactive activities which promote development and immersion on the cultural world. Here, I was singing a song with the baby about a chick that fits on the palm of the hand. And she sings along and goes to the wall to show me that there is a picture of a chick on the wall, the same chick that she was singing about. We play with interactive toys that are colorful and have sounds. clapping hands while singing happy birthday to you, singing songs and doing motor commands that the song suggests together with the babies, playing on a stimulating table and naming all the stimulus around, communicating using a symbolic telephone, which can be any toy or object around. Parents, which are well-oriented, should use strategies to promote development of Luria's 3 functional blocks. The first block that has the localization in the reticular formation of the brainstem, non-specific structures of the diencephalus, limbic system, basal medial areas of the frontal and temporal lobes, and other subcortical structures which are responsible for brain activation and for the vigil state. Several psychomotor exercises can be used to recruit attention and brain activation. Use motor activities such as bobat balls, rows, bridges, and tunnels. For brain activation, also use breathing exercises like these. Exercises using fast games also, all of them have a bell, as you can see here, okay? Which you have to perform the activity very fast and ring the bell. Simon Says is also an activity to activate the brain. In this activity, the child can only do the exercise when he hears Simon Says before the command. If not, he should not do the activity. For example, Simon says, touch your nose. Simon says, touch your elbow. Simon says, raise your hand. Put your hand down. This command should not be done because Simon didn't say so. Another exercise that can be used to activate the cortex of preschoolers is head, shoulder, knees and toes, knees and toes. And the words are taken off and only the movements continue to be done as the activity becomes more complex. Choreographies can be invented by the children to create an identity of themselves, of the family, or of a classroom, and can be done at the moment whenever the energy level decreases. These exercises stimulate the brain, promoting a good level of attention, recruiting attention to start and continue the daily activities. The second block, localized on the posterior part of the brain, this functional block is responsible for the reception, processing, and storage of information. Input of the informations by the sensory organs. Here on the temporal lobe, auditory elements will be perceived. Here on the occipital part of the brain, vision elements will be perceived, and on the parietal part of the brain, tactile elements will be perceived. Auditory, visual, and tactile activities to exercise the posterior part of the brain. These are some of them. Here, vision, here, tactile, here, auditory. Play of listening to all the sounds on the surroundings. Close your eyes, pay attention. After that, you name 10 sounds that you heard, and other toys and books that can be used to stimulate the temporal lobe with auditory activities. Game of the 7 mistakes and other visual activities can be used to stimulate the occipital part of the brain. Magic bag with objects inside to recognize, and other tactile activities to stimulate the parietal part of the brain. The third block is localized on the frontal lobe, is responsible for organization, planning, inhibition of impulses, problem solving, and correction of errors. Use of games and activities to stimulate thinking and planning, which also improve the cognitive aspects. Some activities were oriented to work executive functions, which involve abstraction, logic strategies, mental flexibility, and inhibition control. In pandemic times, there is also the suggestion of use of cognitive activities from online platforms. Activities for preschoolers can also be used both online and personally. Stop and go activities in which the child must be aware to control the body, inhibiting the impulse with different rhythms in which the child needs to dance or run and then freeze. Games which stimulate mental flexibility, inhibition, planning, and organization are these such games. This one is the game Ghost, in which you have to find or the same object with the same color, or a different object, completely different, not a chair, not a rat, not white, not green. So that would be the book. Not a chair, not a ghost, not gray, nor blue. And that would be the bottle. Chess, mastermind, in which you have here a code, and the person has to identify which code is here by the clues that the therapist gives. Sudoku. These are some Sudoku for children, small children. In the book, 15 Minutes with Your Child of Joaquim Quintino Aires, he affirms that time with the children should be quality time. The trick to a good relationship is quality, not quantity. 15 minutes is enough for this good quality time. Never start a relationship moment if you are worried about something, if you have little time, if you are late for an appointment, or if you are very angry with the child. If you have 15 minutes, approach your child and wait. When he makes a gesture or performs an act, do the same. If he's older and already talks, continue what he says. Don't change the subject and the theme. Stay on the same subject. Wait for your child to start a game or a story. Try to understand and respond to what he is playing or talking about. Continue with the same script he is creating. You can add parts of the story as long as it doesn't change the meaning. If he changes the script, follow him, changing it also. You must be an attentive listener. Listen more than speak. Ask lots of questions without fear of exaggerating. Allow him to talk about his life and the life of others. Name your emotions and feelings. Also name your child's emotions and feelings. Summarize what he says. Don't hide from your child everything that can cause him suffering. Talk to your child about bad things like you talk about good things. Never undervalue a situation of suffering. The family and the school, with their significant adults, will act as mediators, promoters of interventions aimed at advancing progress, going beyond. All together and dialectically, the adults assist the child in insertion into the symbolic cultural universe in favor of his integral development, uniting action, thought, and affection so that the adults are always together with the child, promoting this development, promoting it through affection. These are my references. This is my contact of email and WhatsApp. Thank you very much. Спасибо большое.
Теперь мы предлагаем выступить
Now,
Жанне Марковне.
the floor goes to Professor Jana Glosman. She's going to talk about
Нейропсихологическом подходе к профилактике психического здоровья ребенка.
a neuropsychological approach to the prevention of mental disorders in children. Thank you so much, Professor Nikolai. Let me just put up my presentation. Thank you. Thank you. I'm very happy that you managed to join us. We should have your presentation. Our tech support should be able to share it. Okay, here it is. Can you hear me? Can you see me? Neuropsychological approach to the prevention of mental disorders in preschoolers. First and foremost, I have to say that this approach was developed by Alexander Luria. Jana, could you please make your presentation full screen? Could you please press F5? The approach to the prevention of mental disorders was created by Alexander Luria, and it was made up of two components, the cultural and the historical background, looking for mechanism of higher psychotic functions beyond the brain and not in the mechanisms on higher neural activities, but in the social life of the child. What this means is that any abnormal child development includes, well, there's a biological and social factors that come together. Developmental defects, and Luria identified this back in 1920s. It was his first book on the issues of real psychology. Developmental defects such as perinatal complications or genetic pathology that we talked about during the previous session, or sensory deprivation, cause delays and distortions in mental development, and they tend to be exacerbated by pedagogical errors, aberrations, leading to learning and adaptation difficulties for the child. And conversely, the correct, proper psychological support for children with abnormalities, and they can significantly offset their problems. What learning malfunctions lead to? They lead to learning complications. They lead to challenges in the learning process, not just with schooling, but as Professor Luria showed, it also applies to preschool activities. What this means is mental and social functioning of such children does not correspond to their psychophysiological abilities or to their needs, as well as to the demands of the micro-social context that they are in, the school or the preschool establishment that they frequent. And this is all aggravated by the fact that this poor kid with difficulties in learning is then constantly being accused of not wanting to do something, or of being lazy, of not being sweet enough. He's been constantly told that the adults are ashamed of them, etc. And this constant pressure increases the psychological context and makes them lose focus more and more. And I keep talking about this, it's important. Any child, each child wants to be good and they want to be successful. And when they're not supported, but instead they are constantly blamed and scolded, that leads to a negative attitude to schooling altogether, fear of failing, a lower self-esteem and self-worth. So how do we help them? How do we help this child? Well, thanks to Mr. Luria, we've created a system of preschool educational establishments. And we have neuropsychologists there as well. What should a neuropsychologist do in an educational preschool? Well, first and foremost, they need to conduct follow-up monitoring diagnostics of the development of the cognitive activities of the child and in separate components such as gnostic, intellectual, speech, regulatory. To study the individual psychological features of the child, their self-assessment, their reactions to failure, and ways of getting out of situations, their increased anxiety or normal levels of anxiety, lack of communication skills that hinder the satisfaction of the individual needs. To identify and to qualify in a timely manner the child's unwillingness, lack of desire to attend schools. I've seen catastrophic. My PhD, my graduate student, a school psychologist, was carrying out this test analysis. Up to 70% of kids are not ready for school. To help the teacher and the parents in understanding the strong and the weak links in the child's mental development, to identify the need of sending the child to some remedial training if necessary, when and if it's required. Another problem emerges. What is a special needs child?
There are different ways that people call it. Problematic child, children with special needs, children with educational impairments, or children with mental retardation or delayed psychological development. This reflects different approaches that are out there. And the use of a particular approach would depend on the person that applies it. For an educator, this would mean that a child doesn't achieve the appropriate level of academic attainment in preschool, in early school, or later. Maybe this child cannot adjust to become part of the peer community. For a medical professional, this would be a child with pre, peri, or postnatal pathology of brain, from cerebral palsy to various different genetic pathologies. If we speak about a lawyer or a social worker, then this is going to be focused on the ways you can protect and enable kids and their families to enjoy their rights. For a neuropsychologist, this would be about identification of mechanisms, structure, and gravity of delays in development that prevent proper adjustment and what can be done to improve it. Only by joining those lines of effort and perspectives, we can achieve success. Until recently, most neuropsychologists have been working with patients starting from 5 years old, never earlier, even speech therapists. From the very moment we set up our center 20 years ago, the threshold for us was 3 years, and now we decreased it to 2 years of age. The reason is that 2 to 3 years of age has been omitted by neuropsychologists almost entirely, even though it's an important stage in development of motor skills and cognitive skills. That's the period when you can observe onset of general development impairment or linguistic impairment. That's the stage where you can intervene most effectively. Last year, we published a guide for neuropsychological diagnosis of preschoolers. This has a theory section, then quantitative techniques as well, and it comes complete with diagnostic protocols. So, methods for children are different in various aspects, and we use a new approach with play-based analogs of Luria's psychological tests. So we take objects that kids are familiar with, that are interesting for them, in order to facilitate testing. These tests, just like any technique by Luria, are polymodal. So here is one example. This is a test about spatial building skills to build a pyramid. In a 2-year-old child, you can see whether they can cognitively assess dimensions, relative dimensions, larger or smaller, and then it also enables you to track their kinesthetics and fine motor skills. Seconds boards, the example below, allows you to look at kinesthetic skills, fine motor skills, but then on top of that, you can test for speech, because you say, you now need to take the cow to the house. The child uses forceps to take the cow and then to place it where it's appropriate, and then it means that they have impressive speech as a skill, as well as the concept of a cow that they understand. The same applies to all other tests because they're polymodal, covering spatial reasoning, fine motor skills, color recognition, image recognition, shape recognition, speech recognition, building skills, what have you. And then with age, we can administer more and more Luria tests from 2 to 6 years old. And then down with age, the role of play-based techniques and discussions with parents increases. Here is a nice example of using the same set of objects, the cups that we had in the previous slide, in order to test for visual memory. You can use color cues as well. And this can be administered as early as 2 years of age. With that, I'd like to thank you for your attention and your readiness to help the little ones. I would be glad to take your questions. I have a proposal. Let's first listen to all the speakers, and then we'll have a dedicated Q&A time. Okay, that's down to you. Thank you very much. I'm really glad that you were able to join us today. So up next, according to the agenda,
Так, теперь у нас по плану, если я не ошибаюсь,
if I'm not mistaken, we have Dr. Jane Murray.
Jane.
Hello, hello there. Hi.
Nice to meet you, Jane.
Lovely to see you, and thank you very much for inviting me today, Nikolai.
It's great.
Do I need to share my screen?
Yes.
Very good. Okay. Well, hello, everybody. I am Jane Murray, and thank you so much for inviting me to come today. I'm based at the Centre for Education and Research at the University of Northampton in the UK. And today I'm representing a team of teachers and academics who work together in participation in the Erasmus Plus Science Outside the Classroom project. Each person that you can see named here contributed to the research element of the project in one way or another. This presentation is going to report findings from one strand of the Science Outside the Classroom research study, transversal skills outdoors. And in the presentation, I will introduce the project, set out the research aim and objectives, provide a brief overview of relevant theoretical perspectives, and briefly explain the research design before presenting relevant findings and conclusions. Now, Science Outside the Classroom was an international project that took place in 2018 to 2021. The project team created and implemented a development programme with the intention of enhancing children's scientific inquiry skills and their transversal skills in outdoor learning environments across 5 educational settings in 4 European countries. A research team from the Centre for Education and Research at the University of Northampton led a study alongside the development programme. And this presentation reports on one strand of the study that measured and compared the study children's transversal skills development in outdoor learning environments over the duration of the development project. Now, on the left of this table, you can see the aim of the project's development programme. And on the right-hand side, you can see the research study aim and 4 research objectives that acted as stepping stones to achieving the study aim. Because this presentation is focused on one strand of the research study, transversal skills and outdoor learning, we're focusing today on the elements that are in green. Data concerned with the science inquiry skills will be published elsewhere in due course. Now, the theoretical framework for the research strand of the project mirrors the development programme by synthesising emotional intelligence theory from Goleman and theory associating non-cognitive skills with academic achievement from colleagues including Agassisti and Longobardi, Durlac et al., Perez Gonzalez et al., and also biophilia hypothesis from Wilson. Research and literature suggests that learning outdoors affords children agency and integrated opportunities to succeed, including possibilities to acquire transversal skills that can help them flourish in a mutable world. However, we know that internationally, children experience variable access to outdoor learning environments. So what are transversal skills? Well, in the context of this programme, you can see them here, but they're defined by UNESCO as skills that can be used in a wide variety of situations and work settings. These 21st century skills are increasingly in demand for learners. They support successful adaptation to change and enable individuals to lead meaningful and productive lives. The parameters of transversal skills used for this study are drawn from UNESCO 2021 and Goleman's 5 domains of emotional intelligences, as well as other selected sources indicated at the foot of the slide. So the 5 transversal skills we were really looking at throughout the project were well-being, motivation, creativity, social skills, and critical thinking. Now, the study was conducted within the participatory inquiry paradigm promoted by Heron and Reason in 1997. And within this paradigm, what could be known objectively about the world is relative to how it is subjectively shaped and articulated by the knower and those with whom the knower interacts. And in this study, teachers and academics cooperated to co-construct knowledge with children. Children's acquisition of objective knowledge about science inquiry skills was reified in the project through their subjective, objective knowledge acquisition of transversal skills in diverse contexts outdoors. The selected methodology was multiple case study. The cases were 5 educational settings that formed an investigation of the ways the outdoor science programme may support the development of children's scientific inquiry skills and transversal skills in 4 European countries. The focus of this presentation, as I said earlier, is on the green wording. Ethical considerations were informed by the British Educational Research Association in 2018 and were agreed and monitored by the University of Northampton Research Ethics Committee. And this is a sampling frame from which the participants were drawn. A purposive sample was used. Selection was based on characteristics of the population, that is the teachers and the children in the project schools. And also the study aim, of course, was taken into consideration. To capture high quality, robust data, we used a multi-method model, including several comparative measures. Data collection methods used before the programme intervention are shown on the left-hand side of the table. The methods used after the programme intervention are on the right-hand side. Data concerning transversal skills were collected before and after the development programme by using children's and teachers' questionnaires, teachers' assessments of children's transversal skills when learning outdoors, teachers' observations of each setting's outdoor learning environment and how it developed over the time of the project. And that was based on Cooper's benefits and standards for an outdoor learning environment, and harms and criers, Eckers, as well as critical reviews of intellectual outputs. In each setting, teachers were asked to observe the transversal skills of 10 children aged 3 to 11 years in their settings outdoor environment, both before and after the programme. Selected children were diverse in respect of gender, age, academic ability and ethnicity. And based on their observations, teachers completed the ATSLO scale, that is the assessment of transversal skills when learning outdoors. This scale was developed for the study for each child. An example of one of the pages of the scale is here, which you can see. Now, after the development programme, using the ATSLO scale, teachers observed an average increase of 15.4% in children's presentations of transversal skills when learning outdoors in their settings. The teachers also conducted pre- and post-test observations of their settings' outdoor learning environments and completed the OOS scale developed for the study, that is the observations of outdoor setting environments scale, again based on a synthesis of Cooper's minimum standards to promote quality natural outdoor learning environments, seen on the left here, and Harms et al.'s revised Eckers R. And for each setting, percentages were calculated for any differences between OOS scores before and after the development programme. And overall, these revealed an average increase of 38.8% across all settings OOS scores by the end of the programme. Now, as we have very little time, I've selected particular findings from the children's and teachers' attitudes and belief questionnaires to share with you today. Descriptive statistics were used to analyse the questionnaires. We asked students aged 3 to 7 years to complete Likert scale responses to statements concerning transversal skills. So, for example, for well-being, we asked them to respond to the statement, I feel good. For motivation, we asked them to respond to I want to learn, and so on. And after the programme, more students were positive about their motivation and their creativity, as you can see here in the green text at the bottom. However, fewer children seemed positive about their well-being, social skills and critical thinking. Before and after the programme, children selected Likert scale options with given statements to share their beliefs about their overall skills acquisition when learning indoors, then when learning outdoors. But when we compared children's responses for indoors with their responses for outdoors, by the end of the programme, 12.4% more children agreed that learning outdoors enhanced their transversal skills acquisition compared with the children who opted for indoors. And what did the teachers say? Well, we asked them to rate on a Likert scale for their own expertise, confidence and enjoyment as excellent, good, okay, poor or bad in helping children aged 3 to 11 years to gain transversal skills indoors, then outdoors. And by the end of the programme, teachers' excellent and good ratings of their expertise, confidence and enjoyment for teaching children transversal skills outdoors were 24.4% greater than for indoors. We also asked teachers what, if any, difference the programme would make, then afterwards did make, to them supporting children's transversal skills acquisition indoors or outdoors. Did the teachers think the programme would make them better, different, so better, no different, or worse in terms of supporting children's transversal skills acquisition indoors or outdoors? Well, whereas 4% fewer teachers believe the programme had made them better at supporting transversal skills indoors, 99% of teachers believe the programme had made them better at supporting children's transversal skills acquisition outdoors afterwards, which was exactly the same finding before the programme. In other words, teachers' expectations regarding how the programme supported them to help children to develop transversal skills outdoors were met by the programme. And 3 intellectual outputs have also emerged from the development programme: a teaching manual, a science Pictionary game, and a photo book. These were intended to feature curriculum content and pedagogical strategies to support teachers to help children aged 3 to 11 years to develop science inquiry skills and transversal skills outdoors. These materials were co-created by the teachers and academics who worked on the project and trialled within the development programme by the project teachers in their settings for children aged 3 to 11. At the end of the project, the intellectual outputs were uploaded to the project website for public access. You can see the website address there. Those resources are there today. To establish whether these intellectual outputs offer pedagogical strategies that may enable teachers to support children aged 3 to 11 years to develop transversal skills outdoors, they were subjected to 2 critical reviews to identify if the intellectual outputs themselves feature pedagogical strategies, and if so, which pedagogical strategies in the outputs afforded children opportunities to practice transversal skills as part of the programme. From this comprehensive list of pedagogic strategies, only decolonisation there on about a third of the way down on the right-hand side was not represented in the intellectual outputs. Overall, these reviews provide evidence that the programme's intellectual outputs are replete with a rich theme of pedagogical strategies that enable teachers to support children aged 3 to 11 years to develop transversal skills outdoors during the programme. So, in conclusion, did the findings address the study objects, and if so, how? First, children aged 3 to 11 years develop transversal skills through their engagement with scientific inquiry outdoors. An overall increase of 15.4% on the Atzlow scale that I shared with you earlier showed they'd done so by the end of the programme. Second, specific features of the physical environment enabled children aged 3 to 11 years to develop transversal skills outdoors. The OOS scale data showed that all the settings outdoor physical environments had improved, except the only Nordic setting where the score did not change. And of course, there is already a very well-established tradition of outdoor learning in Nordic settings. So by the end of the programme, the settings had improved their outdoor environments in respect of 12 of the 14 items listed on the OOS scale, comparing children's responses for indoors with outdoors. After the programme, 12.4% more children thought learning outdoors enhanced their transversal skills acquisition compared with those who opted for indoors. And 99% of the teachers believe the programme had made them better at supporting children's transversal skills acquisition outdoors, fulfilling their expectations before the programme. And third, the development programme offered 33 pedagogical strategies that enabled teachers to support children aged 3 to 11 years to develop transversal skills outdoors. And this was confirmed through those reviews that I shared with you earlier. Finally, the findings in this participatory study indicate that in the Science Outside the Classroom project, acquisition of objective knowledge about science inquiry skills was reified through subjective objective knowledge acquisition of transversal skills in diverse contexts outdoors. Findings also provide evidence that children aged 3 to 11 years develop transversal skills through engaging in scientific inquiry outdoors. They support the proposition that children's transversal skills were enhanced by the Science Outside the Classroom development programme. The section of the study aim that's relevant to this paper to investigate if and how Science Outside the Classroom development programme supported the development of children's transversal skills in 5 European educational settings was therefore achieved. Data concerned with the science inquiry skills, as I said earlier, will be published elsewhere. Additionally, the availability of the project's intellectual outputs in the public domain means that any teacher with access to the World Wide Web can now draw on the pedagogic strategies set out in the project's materials in the safe knowledge that these are likely to enable them to support children aged 3 to 11 years to develop transversal skills outdoors in their own practice. So thank you for listening. All the photographs that I've shared today are from the project. I hope you've enjoyed looking at them. Do look at our project website. You can see the URL there. And if you have any questions about the research, I'd be really pleased to hear from you. My Twitter handle is at the bottom there for our centre, and also my email address is at the bottom there. Thank you so much for listening once again.
Jane, thank you.
References are here. Bye-bye.
Yeah, but we will talk about it after all presentations. Thank you. Так, и сейчас у нас
all right. After Jane, we have Dr. Mikhail Ivanov, if I'm not mistaken. Hello, I am here. Hello, everybody. Can you hear me? Okay, let me share my slides.
Пожалуйста, сообщите презентацию.
Do tell me if you can see it. Not yet. Okay, it's up now. Thanks again. I'm going to talk about mental disorders in early childhood, detection, prevalence, and prevention. My co-presenters are 2 medical doctors, doctors of sciences, lead psychiatrists in childhood, Professor Natalia Semeshkova and Professor Galina Kozlovskaya. I myself am a clinical psychologist, Mikhail Ivanov. Increased attention to early childhood is due to a high prevalence of mental and behavioral disorders in children, adolescents, as well as in adults. Early childhood is relevant because it is in the first years of life the risk factors are manageable, not as much on the side of genetics or biology, but you have mental and social factors. So these are factors that can counter risks, therefore be used to provide comprehensive primary mental help to at-risk children. In some cases, when a disorder is identified or diagnosed, it can be remedied. Russia has been studying infancy and early childhood mental health issues since the 1980s. It was carried out by the Moscow Center for Mental Health. They looked at disorders in the mother-infant unit. Then they also looked at triple units of a mother-father unit. There was research in parental attachment, other caregivers, deprivation, depression, and reverse attachment by parents to their infants. Special attention was paid to mental health in orphans. A orphanage syndrome was described. And research was done on kids, both orphaned at birth and later in life. Para-autism was described as a symptom, as well as other symptoms in the orphanage syndrome. Child abuse was also researched. Physical abuse, sexual abuse were studied as syndromes within the family and outside the family, both. Longitudinal prospective studies were a focus as well, meaning the question was asked how this affects the future mental health of the patient and the trajectory of their development. Larger psychiatric issues were addressed, including schizophrenia. Kids were studied born from parents who had schizophrenia. And a complex of symptoms was described of neuropsychological disintegration in early childhood. Schizoid inclination or pre-pathology. Russian state policy for protection of mental health has been paying more attention to invalidity due to mental or behavioral disorders. The government agencies, Mr. Makushkin, the chief child psychiatrist of Russia, as well as the Minister of Health of Russia, have been paying attention to prevention and early identification of these diseases. A pilot was thus launched to screen all kids, blanket screening of all kids. In the years 2015 and 16, it was 3 regions. Then in 2017, more regions were covered. And this screening is aimed at identifying risks of disorders in psychological development. For practitioners, it's not easy to focus their attention appropriately, especially when just looking for risks or trying to diagnose certain disorders. Fashions come and go, and you have more focus given to ADHD, dyslexia, intellectual development, or ASDs that has been especially fashionable recently. So you need appropriate measure for that. It's a question, and to the right, you have a number of diagnostic tools and approaches. For example, ICD-10, DSM of America, and different deeper or screening methodologies that are used by both experts and parents in order to provide a diagnosis. For example, one of the more popular diagnoses recently is ASD. When using any diagnostic tool, healthcare professionals need to work together with clinical psychologists because they are the experts in providing or administering diagnostic screening tools or deep examination tools. Our center has developed a tool that can cover a broad group of at-risk people that are at risk of mental health disorders in early age. It is a questionnaire with 35 questions that touch upon major areas of psychological development in early age. Mother-child unit, instinctive vegetative system, sensory systems, emotion, cognition, and social interactions. This tool is used at the initial stage for detection of mental health disorders. So this is preclinical and pre-nosological. It's used by pediatricians, neurologists, medical psychologists. The questionnaires are filled out by the parents. And then if the child is classified as at risk, then a preventative consultation by a psychiatrist is recommended. That's stage 2, marked in blue. A psychiatrist then looks at the status of psychological development of the kid with different criteria for identifying diseases. Psychometrics can be used. Pathological and neurological psychologists can be referred to as well so that a more precise diagnosis can be made. Based on the pilot, some data was collected. This was done under the auspices of the Russian Ministry of Health. So blanket screening was done on over 600,000 parents of children under 4 years of age. The prevalence of at-risk children is 13%. Some of the at-risk children were examined by a psychiatrist, and based on clinical diagnostic tools, 1.5% of kids, 1.5% of the general population got a diagnosis under ICD-10. So clinically manifested, verifiable disorders, mental health disorders or behavioral disorders. Here is the nosological breakdown. Mostly these are development impairments that then can become more severe or rebound to norm. Then we have about 30% for ASDs, then behavioral disorders, including emotional disorders, hyperkinetic disorders, come in at 17% as well. The blue slice is mental retardation, and then there is a bit of childhood onset schizophrenia, a very thin slice of that.
Autistic disorders are of particular interest, various kinds of diagnosis. 44% is of 88 autistic disorders. In line with the national classified, this diagnosis is set as a preliminary diagnosis, which later needs to be specified to identify to what extent this is infant autism or atypical autism. The dark blue is infant autism, and 16.5% is the atypical autism. As part of the overall all-population encompassing survey, we've identified the Rector syndrome, which is also perhaps a part of the autistic spectrum disorders, more of a neurological disorder, in fact. And there are other types of autistic hyperkinetic syndromes, etc. In Russia, the prevalence of autistic disorders among young children is presented as follows. Before 2 years old, manifestations of autistic disorders is 5 to 10,000 people. At the second stage, when we increase the age coverage, the amount of instances with autism increased 18 for every 10,000 people. In the Voronezh region, and this is data from 2015, when using the screening methodology, chat and the subsequent clinical assessments would identified 6 to 10,000, and Rostat's National Statistics Agency talks about 8 to 10,000 in children 0 to 18 years old. So as you can see, screenings indicated a bigger amount of autistic instances. It's interesting to compare our data with data for other countries in young children. Our data, 1.5%, correlates with Denmark and children the same age using the same international classifying techniques. In Spain, there is a bit more, and the coverage is a bit bigger. They covered children under 5 years of age, 4.5% in this article. They've described that most of the children with disorders are children with various autistic disorders. Below, you see 0.18%. For the United States, the number is much higher. Different approaches to diagnosis and to the epidemiological assessment. In Russia, we use a different method. There's a medical diagnosis that's presented in this research at the bottom from 2020. They used various sources, including telephone service, email service, gathering data from educational institutions, and various psychometrical scales, which were later summarized without any in-person assessment by a clinical psychiatrist. Starting from 2019, based on the data of pilot projects, psychiatrists are included into the list of preventive medical exams for children at the age of 2 years old. Psychiatrist examines only those children who have been included in the risk group of mental development disorders based on the screening results. And this is used across all of the regions of the country, starting from autumn 2019. The form is filled by the parents when they come and see the psychiatrist. Previous presentations from Professor Jana Glasman indicated that interest to early children from neuropsychologists is increasing. Having seen a pediatrician and the psychologist, the parents can now come to you to reach out for preventive support. A lot of hope is placed on early preventive measures and specialized treatment of mental disorders, starting at the early stages in early childhood. Based on the national experience, early age psychiatry from the perspective of preclinical medicine, children at risk in a pre-condition need to strengthen their mental health. These are kids with vulnerabilities, kids that are vulnerable. That's why psychiatrists and teachers and psychologists need to put a stronger emphasis on strengthening their mental health. On the next slide, you will see the structure of psychopreventive approaches that are used in Russia. My paper is mostly focusing on primary preventive measures that include risk screening for developmental disorders, of working with the micro and the macro social surrounding of the child. To conclude, the study of mental behavioral disorders at an early age contributes to the development of preventive activities in child psychiatry and the protection of the mental health of children. Screening among young children of the general population is a promising area for preventive preclinical medicine. preventive psychiatry first and foremost. This is something that we could never have thought about before, that primary preventive approaches to psychiatric and mental illnesses is possible. And it was only after lengthy phenomenological descriptions of the disorders and the psyche this became available. Organizational and staffing issues also need to be addressed. We need to make experts aware of the specifics of the mental health during the first initial lives of a child. And the last point is incredibly important: raising awareness, the psychoeducational efforts, working with the population, especially with the parents of the children, both through children's clinics and working with the parents of the children for whom there's been identified some defects in the development. If you have any questions, please go ahead and raise them now. Unfortunately, we don't have any time for questions at this point. Thank you. Moving on.
Выступает Мартин Мусалик.
Martin Musalik. Martin, can you hear us? Martin, please go ahead. Oh, you need to unmute your microphone, please. Please enable your microphone, Martin.
I hope you can now listen me.
Yes, please.
Okay, thank you. Thanks a lot that I can be a part of this very nice and beautiful conference. My name is Martin Musalik. I'm from Czech Republic, and I am at the Faculty of Physical Education and Sports at Charles University. My topic is devoted to, I think, quite new syndrome, which has risen maybe 15, 20 years ago, and which starts to be quite serious, especially within child's populations. I would like to devote my presentation to population of so-called normal weight obese children. And today I would like to speak about normal weight obese preschoolers. Our previous research pointed on significant relationships between this syndrome, so it means between normal weight obesity and some aspects of motor development and motor behavior in school children and also in preschool age children. What is normal weight obesity? Because it seems like a paradox. Evidently, obese child is a child with a high body mass index and excessive amount of body fat. Normal weight obese individual is an individual with a normal BMI, so normal body mass index, but with a high amount of body fat. It means that these people have quite low muscle development. And from previous studies, it was found that muscle development is closely related to physical fitness, motor development from at least childhood. A preschool age, this is another term. The preschool age in Czech Republic, let's say the children from 3 to 6 years, it was found that this is really crucial role in determining of long-term lifestyle habits, including physical activity habits, including eating habits, social habits, and that the physical fitness as a one part of motor development and motor domain, let's say, was recognized as a very important health parameter, especially a preventive health parameter. And that from preschool age children, it seemed that physical fitness is very strongly determined from the perspective of long life, quality health status. Even though we have all of this information, a very limited research has been done in the area of normal weight obese preschoolers, their physical fitness, and also their, at least, let's say, basic eating habits. Therefore, the aim of our study was to investigate and was to verify whether normal weight obese preschool age children differ significantly from their normal weight non-obese peers in the sense of physical fitness level and eating habits, and whether they are also different in this level of physical fitness and eating habits, or if they are at the same level as their overweight, evidently overweight and obese counterparts. So we came to 8 kindergartens in Czech Metropole in Prague and in Central Bohemia region. We did our study between 2017 to 2019. And we finally just sent something slightly more than 300 informed consents. What was very interesting, only 70% of them were accepted. So 30% of parents were not interested in our research. And there is some kind of information how we are fighting with the reality. I mean, how we can bring a real picture of a current situation when 30, and maybe the most important 30% of parents are just getting, let's say, refusing these things. This, the final sample, because we had to exclude some of the children because of some neurological diagnoses and so on. So finally, we had a 188 preschoolers, let's say quite balanced boys and girls. We measured at them some anthropometry, height, weight, and the body fat, amount of body fat. We measure it by bioimpedance with a quite standard protocol with regression equations for also preschool age children. For assessing of physical fitness, we used, let's say, 5 quite widely in the world accepted physical tests, and we used the standard protocol using in Czech Republic for investigating so-called basic eating habits in a form of, let's say, inventory for parents, not for children. There are 4 questions which we used. 3 of them have the response only yes or no, so they are binary scored. And the last one, what is your child's attitude to food? This is, let's say, the extension of the second question. Does your child eat almost everything? Because we were interested whether a child is like a naughty during food, during eating. So it means if they eat everything and they don't want any other portion or any extra portion, or if they are not finishing the portion, if they are asking for something different, because the just the meaning or just an information, if the child eats everything, is not sufficient. The division of our children to the categories of normal weight, non-obese, normal weight obese, and overweight and obese were led by following guidelines. I would like to emphasize that till the current time, we still haven't got any standard worldwide use methodology for identification of normal weight obese children. There are several of recommendations, but these equations or estimating criteria has not been really accepted from WHO or any other institution. So finally, we had quite unbalanced sample, 20 of the participants in the category of overweight and obese, 25 of normal weight obese, and 143 normal weight non-obese. A lot of people can say, hey, this is really unbalanced sample, but we have to admit that this ratio or proportion of participants is really in conformity with not only our previous findings. What is the ratio between normosthenic, so-called normosthenic, normal weight non-obese, and overweight and obese, and normal weight obese participants in a general population? So this unbalanced sample is nothing extra. The stats, we used the analysis of variance with factors of group and sex. We did the non-parametric or Danfoss test because the majority of our data had not normality verifying. And we also use the Fisher exact test for the categorical data from the eating habits questionnaire with some clinical effect size coefficients like from we. I don't think so. This is such an important. This is just a brief description what the kind of analysis procedure we used. What about our results? So the first results are from the anthropometry area. So we can see that in the body weight, the groups of overweight and obese significantly differ from the normal weight non-obese and normal weight obese children. The same in their BMI. So it means, in other words, the weight of normal weight non-obese and normal weight obese are the same as or non-significantly different, which is the same for body mass index, but these two populations significantly differ from overweight and obese children. What does it mean? It means that if pediatricians are using just BMI as a standard protocol, these normal weight obese children are like a hidden population because they are indistinguishable from normal weight non-obese persons. Even though in other row, we can see that their body fatness differ markedly. There was a difference between all three groups. Normal weight non-obese were the most lean. Normal weight obese had quite high amount of body fat, but significantly less than overweight and obese persons. The other very important fact is that normal weight non-obese had a very good fat to muscle ratio. It means that they had quite high level of muscle mass compared to fat mass, and that the normal weight obese and overweight and obese children did not significantly differ between each other. So they were, let's say, similarly poor in their muscle development. How this could be connected to the physical fitness outcomes. So we see that in dynamic strength of lower limb, in a sit-ups, which means endurance strength of trunk muscles, and in agility, shuttle running, 4x5 meters, and in cardiorespiratory fitness, multi-stage fitness test, the population of normal weight obese children displayed poorer, significantly poorer results compared to the normal weight non-obese pairs. Maybe you are a little bit surprising what these numbers are, like 0 point something and minus 0 point something. It means that we had to convert the raw values to the z-scores. So what you see here is that just z-scores, and because we needed to consider also the sex of participants, and because we know that motor development in a children is very dependent on their sex. So the final outcome from this table is that normal weight obese children are significantly poorer in their physical fitness in majority or in 4 of these tests. And in the standing long jump, in the dynamic strength of a limb, only in these tests, the normal weight obese children, let's say, achieved significantly better, even under average, but significantly better results compared to overweight and obese. Otherwise, in sit-ups, in shuttle running, and in cardiorespiratory fitness, the normal weight obese children were the same bad as overweight and obese. In the eating habits, it was very interesting. We have got a boys and girls. In the regularity of breakfast, we found that normal weight obese boys displayed significantly lower frequency of regular breakfast, so having a regular breakfast each day. We also found that normal weight obese boys significantly more prefer consumption of sweet foods and sweet drinks. There were 2 main findings. If we ask if children eat everything, there were no difference considering the sex. So we can remember regularity of breakfast is different between boys and girls and is significantly less frequent in normal weight obese boys, and consumption of sweet foods and sweet drinks significantly greater or higher in normal weight obese boys. We see that in girls, nothing really special. But what was interesting, when we analyze the data from the polytonously scored items, if the child is naughty during eating. Boys, we didn't find anything special, but in girls, we found and we revealed that normal weight obese girls are much more frequently like naughty. They are not finishing their portion. They ask for something different. And it means that they are more selective in the foods compared to the boys, and compare also to the normal weight non-obese and overweight and obese girls, who exactly the overweight and obese ask most frequently for the extra portion. So what are the closing remarks from our research? We have now, let's say, evidence that normal weight obese children have significantly poorer muscular fitness and cardiorespiratory fitness and agility, which is very fast change of directions, compared to normal weight non-obese pairs. And then in majority of fitness tests, they perform as bad as their overweight and obese counterparts. Could be explained by the excessive amount of body fat and very low muscle development. It could be also the consequence of very low physical activity, which we can assume, but however, unfortunately, we hadn't the data. The other thing is that we also found a very different or marked difference in eating habits, that normal weight obese boys significantly more prefer the consumption of sweet food and drinks, while normal weight obese girls had significantly more negative attitude towards eating. What does it mean? If I am, let's say, preferring a lot of sweets, drinks, and foods, it's just making a chronic, even small, but chronic inflammation in my body. We know that sugar, the monosaccharides, are the cause of inflammation status. And this inflammation status makes people, doesn't matter if child or adults or adolescent, more tired. It means that if, and it was also confirmed in animal model, if some animals like rats, lab rats, are receiving a lot of sugars or saccharides, they are lazy. They are not looking for any physical activity. So maybe a normal weight obese boys, and evidently obese boys, because of preferring the sweets consumption, are lazy, are not physically active, regardless of their, let's say, family status and the role of parents. On the other hand, we also found that the girls are very naughty during eating. So maybe they are not finishing the portion. Could mean, might mean, that they are maybe in the restriction of calorie intake, but could imply in decreasing of voluntary physical activity. They are just our suggestions and hypotheses. And finally, let's say closing remark is, even we have been working in this area for more than 5 years, we have not found any standard methodology for identification of these normal weight obese children, even though it seemed that in last 5 or 6 years, the amount of these children exponentially rise in the worldwide population. Thank you for your attention.
Thank you, Martin. Thank you very much. У нас осталось еще 2 доклада.
We have 2 more presentations. And it's very important that we stick to the timing. Up next is Dr. Alexandra Soboleva. Please, the floor is yours. But do stick to the timing, if you may. Well, I'm a fast talker, so the slides are up, right? Hello, Dr. Veraska. Hello, colleagues. Let me put it full screen.
Просто нажимай на следующий слайд мышкой.
Это я знаю, я понимаю. А вот.
Okay.
Не надо делать большой экран, только сложнее будет.
Нет, вот это крайне, да.
Сначала.
Мгм.
Тема моего сегодняшнего доклада – игра в
My
профилактику.
presentation today is going to focus on the role of play or game in development of preschool child. The ways games and play can help to correct high cognitive function in preschoolers. I represent the Center of Child Neuropsychology based in Moscow. It's been in operation for over 20 years. We marked our 23rd birthday, and we focus on correction or remedies for misadjusted kids in preschool and school settings. As Professor Glossman mentioned, we used to never work with kids under 3. It was rare that anybody applied even. So it was always a significant event back then. But now we get more and more cases, more applications by families with kids starting from 2 years of age. So what are the complaints that we typically hear? For example, no full motor development. 10 or 20 years ago, I had to ask if the kids were crawling and there was no concern. I had to initiate it. Now their awareness is higher. Then no active speech, poor lexicon, inhibited or hyperactive behavior. Previously, there was a misconception about that. Maladjustment to the society, or a quote that the kid does only what it wishes. Very recent complaint. There are upsides and downsides to this early reporting or early engagement with the medical system. The upside is that awareness is higher, so we can administer early interventions. But then, on the downside, we see that more and more kids that get applied are preschoolers, meaning that the kids' population is less resilient. The causes, as we see them, I think you'll agree, as the current environment that the kids are placed in. There are such factors as lockdown restrictions due to the pandemic, lack of parent time, where kids are handed over to educators. Sometimes educators are poorly skilled. Sometimes they cannot speak proper Russian. Then other reasons include devices and gadgets and application of poorly tested non-evidence-based methodologies. So when they come to us, we need to identify the key differentiators in physical function so that we can correct the kid to align with the proper stage of their activity. For example, for preschoolers, this is narrative-based role play, and that's what we need to give them so that they can stick to the rules and play the game out. Otherwise, this would not make the transition for them to transition into the school, because kids cannot transition to educational setting without going through this rule-based game stage. This can cause lack of background knowledge, immature thinking, low aspirations, higher preference for game than education. And when engaged in such activities, such skills are required as creativity, proactiveness, and engagement. Games provide positive emotions so that cognitive overload is prevented. Game makes skill acquisition easier. So according to Vygotsky, you get a unity of intelligence and effectiveness. We get emotional engagement, higher motivation, marshalling of attention, so that the stress is lower and the fear of failure is lower as well. Because when we teach kids like that, they perceive it as play. We integrate play in games into interventions, but let's speak about how we do that. Here is a bear, and it's not just putting beads on the string. There is this narrative that is to give us a present to his mother for her birthday, and they can only put a bead on having completed an appropriate task. Or the same can be done with flowers. In this case, the motivation is the following. A puzzle is given to the kid, a mystery, because there is this question, who do you think is behind this fence? One of the planks in the fence can be removed having completed a task. Then more and more of the information is revealed. There is a flying toy that swoops up into the air upon completion of all tasks. To the left, we have the stone eater. It's a competitive element because this is a negative actor and it's an opponent who steals scores away from the kid. Each successful task gives you one brick, and each failed task takes away from the bar reserved from this beast. So it's a competition. Then we plot such charts as were shown to the right based on their preference.
Игровой, так. Основная задача специалистов – это
The
добиться
key goal of our experts is to ensure proper formation of high cognitive skills through narrative-based games and to enable this transition from preschool period to schooling period in life. This should be based on fully functional game to transform into fully functional education. Professor Glosman told you about this publication that we made, so let me go straight to the next slide. Our gaming approaches account for the principle of norm, principle of systemic development, the proximal development principle, the existing psychological development at a given stage. We have books to accompany our classes. These are our publications. And they offer tests and exercises that are fashioned as games. We try to review our effectiveness. We make objective research of functional, personal, and emotional development of the kids that are our patients. In 86% of cases, we see positive improvements in the formation of high cognitive functions. In 91% of kids, we get positive improvements in emotional and personal domains. Especially so for control and programming, control of your own behavior, adherence to the rules, and programming of a solution to the goals that the kid sets to themselves. So spontaneity is also developed by this. Other psychological functions improve, attention, memory, and speech. So all the toolkit that the kid needs properly transition into the school age. Therefore, our practical experience and research gives us the conclusion that this comprehensive game-based correction program, together with neuropsychological treatments, in line with the proper context of the kid, with impairments, that is in line with advanced practices, can be an effective preventative tool and correction tool for kids with developmental impairments. Thank you. We have one other presentation by Valery Yarygin. Are you with us? Yes, Professor Bereska, I'm here. Let me put up my slides.
Так, все видно, слышно?
Can you hear me? Can you see it? Okay. Perfect.
Я сейчас не вижу просто здесь.
Launch the slideshow.
Опять не запускает. Ну вот все, запустил, просто опоздал. Ну и сегодня
All right. Today, together with my co-presenter, faculty head of early childhood psychology, Alexander Psychologist, we've been working together for 26 years. We're working on different elements of early intervention in preschoolers. For the past 2 years, we've been working in a group of 5 together with the Contact Regional Organization, helped by Absolute Pomosh, a foundation. Early intervention was developing in the Western countries in the 70s and in the 90s. This development came to Russia in the 1990s only, and then starting in 2001, Moscow had established about 120 early intervention services within its education system. A new stage was marked by adoption of the concept for early intervention as adopted by the government in 2016, and then in 2021, there was a government decree on the action plan for the decade of childhood through to 2021. So the key activity here is to consult parents and other family members. Here is a quote from our interaction with a mother. So, sustained emotional pressure on a parent who brings up a child with emotional impairments, no opportunity to rest usually leads to depletion of physical resources and lower adaptivity of their nervous system. So a key element here is the so-called social buffer, the resources and opportunities that are embedded in the social network of the person. The key objective of early intervention is to help rationally recognize the situation and look for solutions to better manage it and resolve it. This approach has been in the making for the past 20 years. The clinical psychology for early childhood department contribute Lekateka and the laboratory for early interventions were the contributors. It came in a number of stages. In 1996, we validated the trans-centered model. Then we implemented prolonged help called Russian Lekateka, and then it was rolled out all across Russia. Then we developed the competence-based approach. That's the focus of my presentation today. So in the transdisciplinary, interdisciplinary model for intervention. Last but not least, since 2015, we've been developing a model for remote support, and then we came in prepared when the pandemic struck. Last year, we supported 40 families like that, and this year we'll be supporting 40 other families as well, that is remotely. We made a number of publications describing these methodologies. You can see some references there. So the essence of this approach, since I'm the last to speak, I'll abridge my presentation a bit. So the key thing here is to prepare a qualified, trained expert. Fully fledged programs for workers of early intervention services are required, especially for online work. We began working on this in 2015 because we got the resources. So different technologies allowed us to provide such help online. Previously, it had been too complicated. And the justification was that most families with early childhood impairments usually had a single parent structure. So this was a lone mother, and it was really hard to get them to visit yourself. So the format was that we make an original kickoff session in person, and the rest of the sessions are online. This makes this service accessible to a lot more parents. In Moscow, for example, to travel to the center and then back home can take upwards of 2 hours, given the traffic situation. So, 4 hours in transit is a major barrier on getting help. We don't work with the child exclusively anymore. Originally, we focused on the kids with some sessions for the parents, but now we are providing training for parents. We have special educators who are specially qualified, at least 140 academic hours on top of their existing diploma as a psychologist or clinical psychologist. These are the people who are responsible for training parents so that we get a competent parent to work together then with our experts on improving the situation for the child. As you can see, we use the competence-based approach, which enables formation and recovery as well as enhancement of skills in all the participants of interactions, the expert parent, child, and their family. And the competency is a readiness of a person to use the experience that they gain through some meaningful activity and then their lifelong ability to improve. So that means that a kid can be effective in specific activities. For example, living their life and playing. The goals of early intervention is to build competences, to motivate the kids to address the challenges of daily life according to the level of development, to navigate their surroundings, their world, to engage with grown-ups in the world, to use motor skills, to move around, to self-service, to play, to partake in leisure, and to acquire new skills and knowledge. We see that competence-based approach and early intervention is not about correction. These are different things. So as we've taken on the competence-based approach, early help or early intervention is not early correction, not early education, not early medical help. This is joint work with parents, working jointly on developing the kid and helping the parent in accepting the situation, processing the situation so that they can move on to more constructive activities for the entire family. Based on our experience, the families that we've supported starting from the birth, the rate of fathers leaving the families decreased by 2.5 times. So they have some prospects for the future. They see that their life is getting normalized. They see that this kid will be developing as well, some prospects for the future. They might go to a corrective school, to a dedicated kindergarten, but nonetheless, their life is going to be pretty similar to the rest of people. Our competence-based approach relies on the functional systems approach and on the processual analysis theory. Then, this was adapted for early intervention. This analysis of interpersonal relation has 4 aspects: joint action, joint attention, joint control, and joint experience of affect. And there are 4 positions: dominance, submission, cooperation, and independence. Here is an example. It's a video, but we don't have the time, so. Here is a boy with autism. And these kids are all very special. This one was particularly interested in a Russian cartoon called Masha and Medved, Masha and Bear. So the family built a house fashioned after this cartoon. This was the key to work, to engage with the child. And through this game, all the interventions were facilitated later on, including supervisions. Usually, we have 1 hour for regular families.
это будет возможно. Родители выкладывают для нас либо в закрытом YouTube, либо в
Before
других
that,
ресурсах
we need to
записанные
review
по
some video recordings
нашему предложению
privately provided to
видеозаписи.
us
После
of their
микроанализа
kid. We
организуется
do
встреча, да,
microanalysis.
которая
After
идет
that, we
как
have a
предварительной
meeting,
дальнейшей
a
работе.
session where we
Дальше мы
discuss
видим,
next
что
steps.
уровень сформированности компетенции
As you can
может
see
быть
here, the
различен у
level of
родителей по
competency,
семейным
well, I'm
программам
not going to read
социальных.
off the
Они
slide,
тоже все
just
различные.
for
И
your
компетенции
information.
могут
These
быть
can be different,
ситуативно
and
интересны, может
competencies
быть
can be
предкомпетенция,
situation
да,
specific.
может быть
They
минимальная
can be
компетенция, может
a
быть начальная
pre-competency,
компетенция,
minimal
расширенная
competency,
компетенция и
early
адаптивная
competency,
компетенция,
extended
которая дает
competency,
нам
and
возможность
adaptive
уже
competency. That's our
полностью
classification, and this
социализировать
is what
ребенка. Наша
allows us
основная
to
задача
fully
это
socialize the child.
подготовка ребенка к
Our main
дошкольному
objective
этапу
here
организации
is to
и, в
prepare the
общем-то,
kids to go
полной
into preschool
социализации.
education
И,
and
как мы
then to
уже
fully
знаем, что
socialize.
компетенции могут быть
As we've
индивидуально
seen,
ориентированы, социально
competencies
ориентированы,
can be
универсальны, исполнительны.
personally
То есть каждый
oriented,
по обычаю
socially
хочет
oriented, executive, and
улучшить
universal.
компетенцию ребенка.
We need to build
Группа
those
специалистов под
holistically.
руководством Александра Михайловича была
A group of
разработана
experts
компьютерная программа,
developed
в
a
которой
software
идет при первичной встрече, да, с
that is
родителями
used in our
составление
kick-off
и
original session, the first session.
отмечаются компетенции, которые есть у ребенка по
It's a list of
аналогии к
competencies.
видеоматериалам, а также
We
электронным
mark them
носителям, да,
based on the
составляется
video that we
программа,
had been
эта
provided
программа
and based on asking the parents.
согласовывается с родителем ближайшие даты
Then
на оформление
immediate
ребенка. То есть,
goals
собственно
are
говоря, это все
aligned with the
работает.
parents and the
Причем
work
для
begins.
каждой компетенции
For example, for each
сформированы
competency,
различные, да, бальные оценки.
there are
Исходя
different
из
score
этого мы
scales,
можем понимать, по какой цепочке
and based on the
будем мы
score,
двигаться
we
для
can
формирования этой компетенции.
assess the
Конечно,
current
нужно
status of this
учитывать тот
competency and
факт,
the things that we
что
need to
специалист
do in
должен
order to
точно
attain it.
понимать состав
The key
компетенции,
is
все
that
ее
the
виды,
expert needs to be
быть
fully
потому что
aware
дети могут
of
быть
what
разными
this
по
competence is
видам,
comprised of.
и тогда у
Kids
нас
can be different, as we
получается,
will
что
see,
три формы. Это консультирование с
which then
родителями
means that
по
we can provide
формированию компетенции
consultations
ребенка и
to the
коучинг по
parents and
развитию потенциала
coaching.
родителей в плане
So
решения задач, воспитания и
helping the
обучения своего
parents to tap
ребенка.
their own potential in
Вот.
bringing
Дальше
up their
оценка
child.
динамики сформированности компетенции,
Then we
анализ
assess
через какое-то время, в
the
нашем варианте
competencies
через
across
квартал, мы вместе
time.
с родителями
In our case, they
обсуждаем,
do this
да,
quarter to
тот или
quarter,
иной
where we sit
подробный
down with the
аспект,
parents and
мы анализируем видеозаписи, различным
discuss
соавторам говорим,
the
как мы
progress with the
считаем на
parents.
него. Ну и
We
работа
ask the
как бы
parents for
продолжается.
self-reporting, and we review
Наша
the video
родительская
recordings as well.
детей,
So
как
here
у
is
нас, например, была
a assessment of our group of last year.
1%, да, это были
As
с
we've
детьми с
seen,
аутизмом, ну и так далее, разный состав.
we
Но
had
специалист, который работает в этой
people or
группе,
kids with
необходимо
autism.
должен быть подготовлен
So
к
the expert
выявлению и
needs to be
превенции любых
also
видов рака.
trained
Ну
for
и
any
дальше
of the
о
other
результатах, то есть мы
diseases.
постарались применить разные количественно
Onto
квантитативные
results, we
анализы
try to
по
apply various
оценке
qualitative and
результативности
quantitative
нашей
methods
деятельности.
to
Да,
assess the
мы
outcomes.
подготовили, просто я
And
привожу
then here
результаты.
are some of
И
the
второе,
scores.
что мы разработали, да, это уже
Another
сравнительный анализ тоже видео с
thing that we developed,
итогом. И мы видим, что за год, да,
comparative analysis based on video.
строй, и мы работали на
So there
совместном
used to be
строе,
parallel
к
play,
концу
now we
2020
have
года
joint
рынок
play.
кто
So by December
которые
2020, the
писали.
goals for the
Прием
kid were
пищи, да,
achieved.
мальчик полностью отказывается
Eating,
есть, он
this
протестует,
boy was
приходит
protesting
через
any food delivered
полгода
to him.
работы, у него
In half a year
становится
of working with us,
самостоятельная еда.
they
Еще
now
раз
can
повторю,
work
что основная
or eat
работа наша
on their
заключается
own.
в формировании
So our
компетенций
key objective
индивидуально в
is to
зависимых
form
ситуациях ребенка.
daily
Мы
life
не используем
skills.
надуманных
These are the
каких-то вещей,
competencies that
да,
we try to
мы
provide.
стараемся
These are not some
ориентироваться
abstract
на тот
things.
запрос родителей,
We
на ту
just
потребность,
address the
которая
needs
есть
of
в
the
вопросе
parents and
моего
the
коучинга.
challenges that
Дальше
they
вот у нас
face
подготовка
daily in
ребенка,
their
который
lives.
с аутизмом после
So
того, как
here is
он поступил к нам в
a
Даун,
boy with autism.
пошел в школу в нормативный класс.
After
И, в
us,
принципе,
he
обязательно
went
мы
to
спрашиваем, а что
to
произошло с
regular
семьей, что
school, and we
произошло.
do
Мы
follow up naturally
разработали
to
один
look at
опросник, сейчас
the
я вам
mother
о
and
нем
the
говорю,
family. We've already administered
для
one
нас очень
questionnaire, and
важно,
we are
чтобы это
designing
было
another one because
с
it's very important for us
непосредственно
to see
ухаживающим человеком,
what what happens to the caregiver as well. With that, that's it. I tried to be as fast as possible, giving you a bullet view of my presentation. Thank you. Unfortunately, we are out of time. but this was to be expected. At any rate, thank you everybody who has joined us, including our Russian and international colleagues. Thank you for your presentations. Thanks a lot. I think that email addresses are available for all the presenters, so if you have any questions, you should be able to get in touch with them. If there are any problems with that, you can reach out to me. Thank you, everybody. Thank you for this very interesting meeting.
Thank you, doctor. Thank you. It was fantastic.
Carla, muchas gracias. Muchas gracias. Thank you. Y Quintino, gran salud.
Sí.
Lovely to meet you all.
Jane, thank you very much. It's so nice to meet you. And I hope we will meet after this terrible pandemic. It's impossible to imagine.
Yeah, now we've had our jabs, Nikolai.
Yeah, we have to have.
Через 5 минут начнем следующее пленарное заседание.
Спасибо.
The next session starts in 5 minutes.
Yeah, good to meet you all. And thank you, Nikolai, for putting all this on. It's been brilliant. Thank you.
Thank you.
Всем спасибо, до свидания. Thank you. Goodbye.
Я вижу. Ты мне махни рукой, если что. Все, я готова говорить, да? Мгм. А я должна нажимать вот на начинаю говорить. Ни на что. Хорошо. А вот мой глубоко уважаемый сопредседатель. Я вход должна. Нет? Начинаем. Мгм. Начинаем.
Hello. Здравствуйте.
Добрый вечер. Глубоко уважаемый
Hello,
сопредседатель.
everybody, esteemed co-chairs, dear colleagues. If I may, let us begin our plenary session on mental health and well-being in school-age children.
Секундочку, мы еще не в эфире. Мы еще не в эфире. Если все готовы, можем начинать эфир запускать, да? Хорошо, по команде тогда. Внимание, приготовились.
Начинаю?
Мы в эфире.
Добрый вечер. Глубоко
Hello,
уважаемый сопредседатель.
esteemed co-chairs, esteemed colleagues. With your permission, I would like to now start our plenary session on mental health and well-being in school-age children. First, let me introduce my esteemed co-chair. I think most of you already know him, but we have some younger colleagues with us who might not be aware. We have Professor Rakesh Kumar Chadha, Secretary General of the World Association of Social Psychiatry, Chair of OC WASP Hybrid Congress, Professor and Head of the Department of Psychiatry, Chief of the National Drug Dependence Treatment Center of All India Institute of Medical Sciences. So before I give the floor to my esteemed co-chair, I would like to make a small announcement. Our time is regulated, so please stick to the timing that we were assigned. So we'll have a Q&A after the reports if we have the time. This is done so that everybody can properly deliver their presentations. Professor Chadha, do you have any opening remarks, or we can proceed with your presentation? Okay, so we are going to hear about mental health education and promotion in schools, strategies and expectations. Please, Professor, the floor is yours. We cannot hear you. Professor Chadha, we cannot hear you.
Yeah. Good evening. Am I audible? Yeah, thank you. Good evening. It gives me great pleasure being here in the session on mental health and well-being in school-age children. I would like to thank the organizers of Mental Health Conference of Moscow 2021, which was to be had last year, and it has got postponed and due to the COVID pandemic. And should I begin my presentation? So I'll be speaking on mental health education and promotion in schools, strategies and expectations. I work at All India Institute of Medical Sciences, New Delhi, India. This is my campus. And I also work at National Drug Dependence Treatment Center, which is located around 40 kilometers from my place, from my main institute. As we all know that globally, nearly 1/4 of the world population is below 15. And around half of the mental illnesses have onset by 14 and 3/4 have onset by mid-20s. In this background, it becomes very important to have school mental health programs. It's a known fact that anxiety disorders, learning delays, eating disorders, bullying, child abuse are common in school-age children. Most children spend significant part of their time in schools. So in this background, schools become one of the most important places for identification of those at risk of mental health problems and for early intervention. As per one of the reviews, mental health services in schools, approximately 20% of the students aged 6 to 17 suffer from significant impairing psychopathology. And it's only less than 1/5 of them receive any treatment for these disorders. And for substance use, the figure is much lower, that is 1 in 10. So in this big background, the developing mental health services in schools become very important. Unfortunately, 1/4 of public schools have no counselors, and over half don't have social worker, even in one of the most advanced countries with best facilities of that's the United States of America. So what could be the strategies at strengthening the mental health services in schools? It remains a big challenge. Why school mental health? Mental health issues impact most students in a school. Disruptive behaviors at school and emotional distress are among the largest impediments to all students' academic achievement in a school setting. School dropout rates continue to be approximately 10%, and this significantly higher in children with mental health problems. And it's seen that underlying psychiatric disorder is often responsible for nearly half the cases who are not able to complete school. Traditionally, mental health services are shifting from the conventional institutional settings to the community. In this background, schools and educational institutions provide an excellent facility for mental health promotion, prevention, and intervention for young population. Improving the mental health of children and adolescents has long-term benefits for the individual as well as for the society. More so, since in most schools, children have long vacations. So it's easy to organize sensitization and training programs for teachers on related to mental health promotion and early identification of mental health problems. So in this way, the schools become school mental health becomes very important component for mental health promotion and prevention. The scope for mental health promotion in schools would include improving self-esteem of the children, promoting resilience by support from teachers and the peer networks, and reducing exposure to risk factors like bullying and academic stressors. Preventive strategies would include identifying children with known risk factors, and treatment strategies would include the early identification of the mental health problems and their treatment. WHO has described 4 levels of mental health interventions in schools, which includes promotion of psychosocial competence, which can be integrated with the school curriculum. Focus on mental health education, which should be part of general health curriculum. Focus on children who need additional psychosocial interventions, and special focus for children who need professional help due to mental health issues. Thus, strategies for school mental health could include introduction of principles of mental health promotion in school curricula, sensitizing teachers at identifying stress in children, introducing counselors, engagement and support for the school staff, improving accessibility to mental health care. The program should take care of needs of students, school, and the community. There is a need for connectedness between the school and local mental health services, because definitely you can't have the primary mental health services in the schools. There needs to be a networking with the community mental health services in the specific area. Then reducing barriers to students' learning by identified strategies. There's a need for sensitivity to developmental and diversity factors amongst the students, and to develop strong teams, interdisciplinary relationships, and coordinating mechanisms in school mental health. COVID-19 has led to a lot of problems in the school children's mental health. The closure of schools led to, and the online classes led to the increased stresses among the children, especially about the future. There was uncertainty, fear of getting the virus, associated with the sleep problems. There was all around the world, there has been increased incidence of mental health problems, including stress-related disorders, depression, anxiety, substance abuse in the background of COVID-19 pandemic. Quarantine, school closures added to these mental health issues. And there were lack of adequate support systems in schools and the community. Historically, schools had provided a social support network and mental health services for the vulnerable teens, which went away in the COVID pandemic. Social distancing, school closure during COVID-19 pandemic had potentials of worsening existing mental health problems. So that was another issue. The existing mental health problems got worsened. Most students were not able to follow a regular routine because the lockdowns and closure of schools also led to the social isolation. Children would feel lonely. Though it brought more opportunities for family bonding because of lockdowns, the full family was at home. But it's also led to an increased incidence of domestic violence and the family conflicts. WHO had come out with the guidelines for children for coping with stress during the COVID-19 pandemic. This is one of the pamphlets which was given by the WHO on its website. What could be the strategies to strengthen the school children's mental health during the pandemic? By developing peer support networks, by creating a buddy system which allows students to form peer connections and check on friends through network hubs, using mobile technology and other IT devices for academic and career growth. Online classes had used all these modalities and need to involve all stakeholders, families, educationists, mental health professionals, social scientists, community leaders, policymakers, and political leadership. What could be the important components of school mental health program? A school mental health program needs to take into account the relationship between schools and the community. It needs to pay attention to the relevant socio-political conditions, should involve families and all stakeholders, should utilize the skills and expertise available with the schools and the community, because networking need to be developed with the community, and encourage multi-level interventions, which would include teachers, parents, peer groups, counselors, and mental health professionals if required. The mental health providers need to be competent within school. You can't have the psychiatrists or in the school, but there can be counselors, psychologists, and the school teachers, and they can be sensitized to provide the mental health, the basic mental health. They can be made competent to develop, build positive relationships, promote and support mental health, sensitize school staff to principles of mental health, identify risk and protective factors, key applications for mental health promotion, prevention, and early intervention. Consultation would need to be arranged for those who are in need, and there's a need to make them aware of evidence-based learning supports. Stephen and co-workers have given a multi-tiered system of support for school children. The tier 1 could be universal supports, that's for all students, which would include strong foundation for promoting wellness and positive life skills. This prevents and significantly reduces mental health concerns or problems in the 80% of students. Around 15% of students would require a targeted support. Students who have been identified as at risk for mental health issues. There's a need for early identification of such children and provision of support, which would help in reducing and eliminating the problem. Around 5% children would require an intensive and individualized support and would require services of mental health professionals. In a systematic review of universal resilience focused interventions targeting children and adolescents, it was found that resilience focused interventions are effective in reducing 4 of the 7 outcomes, especially the depressive symptoms, internalizing problems, externalizing problems, and general psychological distress. In children, these are effective for improving anxiety symptoms and general psychological distress. For adolescents, they're effective for internalizing problems. And in short-term follow-ups, it has been found interventions were effective for 2 of the 7 outcomes, and in long-term follow-up, they were effective for internalizing problems. In one of the meta-analysis, which has been published recently in the Lancet by Caldwell et al., they found weak evidence for school-based preventive interventions for anxiety, depression, and conduct disorders, and of CBT-based interventions for symptoms of anxiety and depression, mindfulness, relaxation, exercise interventions, efficacy. This meta-analysis has been criticized because by Faisal and the court, that this review was limited by a disconnect between the Institute of Medicine's definition of prevention and manner in which prevention programs are typically evaluated. The review had included symptomatic and asymptomatic students, like up to 40% could have had depression or anxiety at baseline. So thus, they could not find, they did not find any significant evidence for efficacy of the cognitive intervention in preventing depressive and anxiety symptoms. And from the youth development perspective, the findings of the meta-analysis don't report other outcomes that might be improved, might have improved in by these interventions. So this was one of the major critique of this meta-analysis. In a review of the current situation and comparison of school mental health programs in ASEAN countries, it was found that mental health services in schools are centered on professionals such as guidance counselors. All the coverage varies across among different ASEAN countries. Only Singapore conducts mental health training for teachers in a comprehensive way, which is not there in other countries in that comprehensive level. Coming to situation in India we have scattered experiments at developing school mental health program going on for nearly 4 decades. Because as you know that India is a huge country, our current population is touching nearly 1.4 billion. So most of the such programs which have been taken place at different places are mostly individual specific or institution specific endeavors. There's a lack of comprehensive nationwide program involving all stakeholders and strong intersectoral coordination. Various stakeholders such as the school boards have expressed concerns about the mental health of children. This has been a phenomena across all states because mental health issues in the children and adolescent in the school-going children have been in the spotlight, especially because especially it happens more near the board exams of 10th and 12th standard, which are the school leaving exam. At most places, schools either don't have any structured program for the psychological well-being of children or do have some activities that may not have comprehensive promotive, preventive, and interventional approach. Scattered programs do exist across many places. Just to summarize the situation about school mental health across the world, attempts have been done all across the world, including high, low, and middle income countries. Efficacy of programs has been assessed by meta-analysis and systematic reviews, but the results have not been very conclusive favoring them. In South Asia, like in India, a beginning in school mental health was made in late 1970s with multiple initiatives in different parts of the country, but nationwide implementation is lacking. In ASEAN countries, coverage is not very satisfactory except in Singapore. Nearly 1/4 of public schools have no counselors and over half don't have a social worker. In Australia, mental health nurses working as case managers could be effective in support of children with behavioral or mental health disorders in schools. They work not only with the individual child, but also with the family members and teachers. There's a need for stronger and broader evidence base in the field of mental health promotion, which should focus on both universal work targeted approaches to fully address the mental health in our young populations. To conclude, I would say that schools are a unique setting to introduce skills of mental health promotion as well as prevention in children and adolescents. Developing school mental health services is a priority considering onset of most mental disorders in the early years of life. School mental health services are not adequate even in high-income countries and are highly deficient in low and middle-income countries. Priority needs to be given to the school mental health services in health policy and program. We, the mental health professionals, need to take an initiative in sensitizing the educationists and policymakers to the need to introduce such services and strengthen them wherever they are existing. I thank you all for your kind attention and thank you.
Большое спасибо, профессор Чада.
Thank you so much, Professor. Thank you so much for your very interesting presentation. I would like to give the floor now to Professor Karabeynikov, Doctor of Psychological Sciences, Deputy Director for Research at the Institute of Economic, Editor-in-Chief of Defectology, the journal, a member of the Expert Council of the Higher Attestation Commission of the Ministry of Science and Higher Education of the Russian Federation. Professor Igor Karabeynikov, Deputy Director for Research of the Institute of Correctional Pedagogy, is going to talk about the analysis of factors and development conditions of a child with disabilities in the context of modern educational practices. Please, Dr. Karabeynikov. Can he not hear us?
Глубоко уважаемый председатель симпозиума, глубоко уважаемый
Esteemed co-chairs, dear colleagues,
исследования, которые проводятся
let
сотрудниками
me make a report on the research that we carry out at our institute. I believe that it is fully aligned with the subject of this plenary session.
на протяжении долгого времени проблемы
To begin
соотношения
with, let me highlight that the problem of the ratio between the effect of factors organically and socially has been not so much a matter of scientific research,
Спасибо. Является не столько предметом научных
so
исследований,
hasn't been so much studied academically, than rather discussed academically and non-academically. The primacy of biological factors gives way to the belief that social factors dominate, and this goes back and forth. These beliefs are not informed by academic interest so much as the need to deliver proper help to kids with invalidity or with other impairments. The Institute of Correctional Psychology has been tasked with research of kids in current environments with invalidity, kids with special needs, where we look at a number of factors that determine the quality of their educational attainment and development. Okay, this one. So the justification for this research was that we saw emergence of variable pathologies, which means that we need a typology of development formats matched with the educational settings. We need to refine our understanding of educational techniques
образовательной среде. Нуждается в разработке инструментарий для
to meet the
определения
needs of invalidity. We need to better plot educational trajectories as well as procedures for assessment of educational attainment for kids with invalidity in highly mutable educational settings. This research is based on long-term monitoring of different parameters as kids get educated. These data should enable assessment of the potential impact of social factors, as well as revising their contribution to the phenomenology of their ailment. These assumptions informed our objectives, and we believe that these are fully achievable, even though the ambition is high. The format of research is unique because we have longitudinal study through to 2030. We formulated a research goal based on that and came up with a hypothesis for that.
Позвольте остановиться на наиболее важной позиции. Значит, в соответствии с положениями федерального государства.
So according to the national standard for education and care for kids with invalidity, the matching is not done with nosologies, but with different developmental formats within each group. These variations inform the educational settings that vary based on specific educational needs. Within each disease, the differences between manifestations in kids are highly varied, and everybody who works with it is well aware. And then children can be classified as students based on the primary impairment that they have, sensory, cognitive, or motor. The rest of the research is focused on prevention or compensation of socially induced secondary pathologies. Here we have the highest variety, so the lack of homogeneity is further aggravated. Direct or indirect impact of the primary defect is fully offset here, and secondary pathologies are highly varied. We see this especially in cognitive impairments based on various brain pathologies. The determining factors or identifying these parameters is key to properly plotting the trajectory for education. However, proper detailed description of each format has been lacking up to this time, as well as the corresponding techniques. This cannot rely on theory alone, the theory on various manifestations of these pathologies. These descriptions must be based on empirical research so that the outcomes in diagnosis are reliable and valid. The second challenge is that there is no single standard procedure for educational monitoring as a dedicated line of effort, which aims not only to provide long-term assessment of interventions, but also on generating forecasts for educational attainment. Factors with predictive value include the severity of manifestation, the degree of compensation for primary pathology. Reliability of forecast is not an academic pursuit, but it can course correct the educational trajectory, which is a major achievement in the federal standard that was adopted. It is especially relevant in cognitive impairments because mistakes in initial educational trajectory lead to social misadjustment and school misadjustment. At this stage, these mistakes can be identified and corrected at an early stage. So within each pathology, there are different variants, which is a problem not just in practice, but in the dimension of methodology, because it raises the question of applicability or translatability of clinical knowledge to actual corrective practice. The evolution of diagnosis in psychological impairment, as we see in ICD-11, these notions are better aligned with the development formats, but there are no tools to identify them. The formats can be identified in order to set appropriate educational conditions so that the educational needs of kids with cognitive impairments are best matched. We do comprehensive studies. We try to outline these formats where we are informed by the clinical picture and by the psychological profiling, including affective behavior, behavioral properties, and life skills. The short-term intervention by a psychiatrist results in a diagnosis. Then, educators work for a long time, unlike psychologists. And they are focused on secondary impairments that are determined by social factors to a greater extent than the primary one. This matching of pathology and trajectories is a task of educational psychologists. It's not so much applied to kids with special needs, because here this is going to be about the content of education in a broader socio-psychological environment. The third challenge is that there are no reliable criteria or tools to identify real educational settings that can be then assessed as factors that improve or impede successful mental health development and social adjustment. We've already identified a number of parameters, for example, trained staff that provide comprehensive care and education. Another parameter is their qualifications, availability of teaching aids, the family environment, content and quality of coordination between the experts and the family. The longitudinal study is a unique opportunity for us to analyze these educational trends long-term for different types of children with impairments in different educational settings. The need for this data comes from the lack of evidence-based, reliable, verifiable beliefs on the advantages and disadvantages of inclusive educational models and special educational models for children with invalidity. The research develops new diagnostic tools, improves the existing tools that can be applied not just for evaluation, but for collection of data on the educational settings. In the interest of time, I will not go through the toolkit, but you can be assured that it is fully aligned with the goals that I've outlined. We're also developing a list of parameters that we use to assess the environment, as well as the rules for collection and processing of primary data. We are also designing a comprehensive procedure for monitoring of psychosocial development of kids and a scale to assess their progress in their educational trajectory so that it can be course corrected where necessary. Now briefly on the methodology and program of research. The program of our research originally went to the regions where we trained participants first in theory, Then we gave them the methodology on the comprehensive examination of kids and diagnostic techniques and skills. We delivered online training to over 700 experts from 169 educational institutions. As they operate, they can access research organizers and advisors for consultation. The coverage of kids is over 1,000. These are kids with ASD, with cognitive development impairments, with severe speech impediments, with musculoskeletal system impediments, impediments of cognition, vision, and hearing, early age children at risk of impairment of cognitive development, and blind infants and babies. Now onto the expected results. You can see them in the slide. One thing I'd like to underscore is that an important result from the final stages of the research is going to be revision and update of the fundamental clinical knowledge and the regularities of formation of psychological dysontogenesis, mostly affecting the cognitive functioning. Then we'll get current views, current information on this process in the population so that we are able to forecast psychological development of kids, as well as forecasting of risks that then can be properly identified in due time and mitigated. In essence, this means that we'll get better opportunities to address one of the key challenges in special education, that is prevention of secondary impairments in different types of invalidity. In closing, let me say that the need to update our knowledge on kids with invalidity centers around the same factors as we've known, but over time, organic factors remain pretty much the same. However, the social factors are highly mutable, new factors can emerge, and they are uncontrollably invading the life space of the child, as well as the educational setting. This means that classical and conventional profiles of children with invalidity are currently transforming, which requires further analysis. The totality of the results that we expect to get from this long-term longitudinal study should enable us to revise existing outlooks on current population of kids with invalidity, which will inform their profiles and generalized types and primary defects, but similar in the trends of the development of secondary psychological development depending on the environment. Of course, I wish to present you this research in more detail. Unfortunately, I have no time. One last thing I'd like to add is that we'd appreciate your feedback really much, both internationally and from Russia. Colleagues in Russia are well aware that longitudinal studies are very rare in our country. So there isn't much experience of working like this. So we have to learn as we go along, acquiring new understanding of what we do. We try to adjust our course, but we'd like to hear from people who've done it already or generally get some feedback. With that, thank you for your attention. Wish you a productive Congress. Thank you very much, Professor Korobenikov. With a heavy heart, I have to remind you once again that we need to stick to the timing, even though all the reports are very interesting. With that, I'd like to give the floor to our next speaker, Professor Catherine Cresswell, Professor of Developmental Clinical Psychology at the University of Oxford and an honorary consultant clinical psychologist, a research professor of the National Institute for Health, a honorary consultant. So, a speaker from the UK to tell us about improving access to psychological interventions for childhood anxiety disorders. Professor Cresswell, please, the floor is yours.
Thank you very much for having me. Hopefully you can hear me okay. Yeah, great. Thank you very much. It's really lovely to join you. And I'm going to be talking about improving access to psychological interventions for child anxiety disorder, and very much picking up on some of the themes that Rakesh Chadha mentioned earlier on in the session. Just to declare an interest. Okay, so I think that nobody here will need convincing that we need to be paying close attention to mental health problems in children and young people. And the particular focus of a lot of my work is on child anxiety disorders. And the reason that we focus on child anxiety disorders specifically is first that they're so common. So approximately 2 children in a UK classroom of 30 children will meet diagnostic criteria for an anxiety disorder, which means they experience a level of anxiety that significantly interferes in their day-to-day life. And we also know that this is possibly an underestimation of how things are now. Certainly our data in England suggested that from 2004 to 2017, we saw almost a 50% increase in the prevalence of emotional disorders, such as anxiety disorders, over that period of time. So the figures from the meta-analysis that suggests 6.5% may well be an underestimation. We also know that where children have anxiety problems, they're more likely to have ongoing anxiety problems into adolescence and adulthood. And they're also at greater risk of other mental health problems. We also know that early anxiety problems can impair educational attainments, impact on employment prospects, and lead to impairments in social relationships. And actually, when we look at the costs to the individual and society of different mental health disorders, anxiety disorders have come out as the most costly, given their very high prevalence and the impact that they have on people's potential. And as we've already heard, many mental health disorders have an early age of onset, and that's certainly the case for anxiety disorders. So these figures are from a recent meta-analyses that pulled together data on age of onset from a range of studies. And you can see that anxiety disorders are among the earliest age of onset. And actually for some of the anxiety disorders, such as phobias and separation anxiety, the median age of onset is particularly low, around 8 years of age, which means half of all those people who will have problems with phobias or separation in their lifetime will have experienced that by the age of 8 years of age. And social anxiety disorder, you can also see, had a median age of onset of 13. So again, half of all those people who have social anxiety in their lifetime will first experience problems before they hit their teens. So we're particularly focusing on that younger age group to try and capture those who have that very early onset for anxiety disorders, to try to interrupt the trajectory that they can take going forwards. And as the authors of this paper highlighted, for these disorders, good mental health promotion, along with preventive and early interventional approaches, really need to target these neurodevelopmental periods, mainly during preschool and the primary school period. So the work I'm going to be talking about today is very much focused on that primary school period. Now, the good news, I suppose, is that we do have treatments that work reasonably well for anxiety disorders. So I was recently involved in an update of the Cochrane review for cognitive behaviour therapy for anxiety disorders in children and adolescents. And we found what's now quite a robust finding, that cognitive behaviour therapy is an effective treatment, at least compared to a waitlist control. There are not so many studies that compare cognitive behaviour therapy to other sorts of control conditions, and there the effects are more modest, but certainly at the moment we have more evidence for cognitive behaviour therapy than any other kind of treatment. However, despite having an effective treatment, very few children access this sort of an evidence-based intervention. These are headlines from the UK, but from talking to colleagues internationally, I know that this is not a UK specific problem, but is a worldwide problem that very few children access evidence-based healthcare, if any healthcare at all, for mental health problems. And to try to understand the scale of this problem further, we went into the community to identify children who may have had undiagnosed or undetected anxiety problems. This work was led by my colleague Tessa Reardon, and she screened just under 2,000 families, and where children scored highly for anxiety symptoms based on parent, child or teacher report, she conducted thorough diagnostic interviews. And there she identified a number of children who met diagnostic criteria for anxiety problems by going into schools and finding these children. She then found out from the families about their experiences of accessing help. And she found that about 65% of the families where children had an anxiety disorder had tried to get some sort of support in the last 6 months, but only just over a third had actually accessed any support. So this very much ties in with what Rakesh Chadha was saying earlier on. But we also looked at what was the support that they got and found that of those who did access support, only 15% accessed a mental health professional. So in many cases, people had some sort of pastoral support in schools from, from support staff, teaching assistants, and so on. And only 2% of the children with an anxiety disorder had actually accessed cognitive behaviour therapy, which is our one sort of well-established evidence-based treatment. And I think these figures are so striking, you just have to supplement anxiety disorders for any other health condition or any health condition. Just imagine if 2% of children with asthma accessed an evidence-based treatment. So these figures are really, really striking. And if that's what it's like here in England, I think that we don't really have any reason to feel much more optimistic about many other parts of the world where we have a national health service. So what can we do to try to improve access to evidence-based treatments for children with these common mental health problems? Well, there's a bit too much information, obviously, on this slide, but what I want to draw your attention to are just the diamonds on the right-hand side of the slide, which show you the size of the effects for groups of treatment. And what we did here is took trials of cognitive behaviour therapy for child anxiety disorders and categorised them on the basis of how much therapist time was spent delivering the intervention. And the top group here, the therapist spent less than 10 hours on the intervention, the middle group between 10 and 20 hours, and the bottom group more than 20 hours of intervention. And if you look at the diamond, that shows you the average effect across. And what you can see is that diamond is in almost exactly the same place, regardless of the amount of time that was spent delivering the treatment. Now, of course, that might be to do with other characteristics of the participants, but actually, when you look across these trials, there are not obvious differences, for example, on the basis of anxiety severity. And what this might suggest is actually we can deliver brief interventions and our outcomes are really not substantially impaired. So if we want to be improving access, we need to be focusing our efforts on delivering brief, effective interventions. So one way that we felt that we could improve the efficiency of interventions more was by using guided self-help type approaches. So we developed an intervention where we support parents in applying cognitive behaviour therapy principles with their children, which means you can provide parents with written information and then provide sort of fairly low level guidance to help them individualise that to their child and solve problems that arise. And our first randomised control of this approach involved just over 200 parents. In this first trial, we focused on children whose parents didn't themselves have problems with anxiety because we felt we should focus on a group with a relatively good prognosis. However, in subsequent trials, we haven't limited ourselves in that way, and it doesn't seem to have impacted negatively on outcomes. But in this first trial, we compared a 5-hour version of this treatment to a wait list and also a 2.5-hour version to a wait list. And this was led by my colleague, Thurston Thirlwall. So as we can see from the results here, when we look at the recovery, we can see that that the full 5-hour version was clearly superior to the waitlist immediately after treatment outcome, whereas it was a bit less clear for the just 2.5-hour version on some of the indices. So we've continued really with the 5-hour version, and what these outcomes translate to in terms of comparing them to more intensive treatments are actually quite positive outcomes. So we could see immediately after treatment, after just 5 hours of intervention, half of the children no longer met diagnostic criteria for their primary disorder, and that rose to over 70% at the 6-month follow-up. And we saw over 70% were much or very much improved based on an objective rating at post-treatment, and that was maintained at 6 months. So actually very similar outcomes to what we see in trials of much more extensive and intensive CBT approaches. And encouragingly, this is data from the immediate post-treatment outcome, and we could see that actually we got the similar outcomes from the 5-hour treatment, regardless of whether the clinicians delivering it had been trained in CBT or were novices in the approach. So in terms of, again, increasing access to psychological therapies, this provides us with promising advice that we can train up novice therapists to deliver this kind of approach, and they can achieve good outcomes. We also wanted to establish whether this brought cost benefits in terms of alternative brief psychological treatments that might be delivered in child and adolescent mental health settings. So we conducted another randomized controlled trial in clinical services to compare the parent-delivered CBT approach to solution-focused brief therapy. And here we randomized 136 families, and where dropouts differed, it didn't appear to reflect the treatment condition. And essentially what we found was that the level of improvement was very similar across these two conditions. Things started a bit more severe despite the randomization in the guided parent-delivered CBT group, but the rate of recovery was very similar. And that was true whether you looked at parent report or child report, even though the children were not involved in the guided parent-delivered treatment. But what was notable was that despite these both being brief treatments, the cost of delivery of treatment was significantly less for the guided parent-delivered CBT approach, because we could work in much more flexible ways, including remote delivery, which reduced costs substantially. And it also, being a very structured treatment, reduced some other aspects of the time available. And the graph just here to the bottom right-hand side shows you the probability that guided parent-delivered CBT was more cost-effective than solution-focused brief therapy at various willingness to pay thresholds. And essentially what this shows is that it was over 90% likely to be cost-effective compared to solution-focused brief treatment, however much you're willing to pay for quality of life gains. We also wanted to then try to make this approach more accessible. So we worked with a range of different stakeholders to develop an online version of this intervention, which you can see some examples of here. It's more interactive, it has less text, it has audio accompaniments to try to make it more accessible to a wider range of families. And we've so far finished a clinical case series, which has had very positive results so far. So you can see here the sorts of effect sizes that we were seeing across a range of outcome measures, looking at anxiety symptoms, global outcomes, goal-based outcomes, and the impact of anxiety were all quite large, particularly for the idiosyncratic type measures such as goal-based outcomes, where this is rated on a scale from 0 to 10. And you can see when you look at the average of progress towards 3 goals, people move typically from average from 2 up to 7 on that scale. So these are really positive and encouraging results, but we're now evaluating these further in a randomized controlled trial across clinical settings in England, but also possibly of particular relevance following Rakesh Chadda's talk earlier on. We're also conducting a large program based study in UK primary schools, where we're developing a system for screening for anxiety problems in schools, trying to improve our identification of anxiety problems, and then co-designing with a range of stakeholders the procedures to take us from screening to this online intervention. And we've been working on this for the last 2 years, and we're now got to the final point and are about to start a randomized controlled trial to compare this screening and intervention package to usual school practice. So I look forward to be able to come back and tell you about that in the future. And finally, we also want to use this sort of approach for prevention purposes. So we're also currently conducting a large randomized controlled trial, this time with young children aged 4 to 7 in UK schools, where we identify children on the basis of being at risk of anxiety problems, on the basis of already having high anxiety symptoms, having high levels of behavioural inhibition, or parents being highly anxious. And if any of those things are the case, we offer an online intervention aimed at prevention. And we're working with parents all over England with this at the moment. And so far, we obviously haven't looked at the data, but the feedback we're getting from parents is extremely positive. So hopefully that's given you a flavour of some of the work that we've been doing to try to improve access to psychological treatments for children with anxiety disorders, and also given you a bit of a flavour of what's to come. So thanks ever so much. It's been great to join you.
Thank you so much, Professor. This is critically important. The level of anxiety is and anxiety disorders is much higher than we formally know from available data. So your work is very significant. Moving on to our next speaker. Harvey Milkman, PhD, Professor Emeritus of the Department of Psychology at the Metropolitan State University of Denver, Colorado, Senior Advisor at Planet Youth in Iceland and the USA. He is the one that Iceland owes a lot to in terms of reducing dependencies and bad habits such as smoking. His paper is called Environmental Support and Developing Brain. Professor Milkman, the floor is yours.
Hello, can you hear me now? Yes. Всем привет. It's an honor and a pleasure to be here. Can you hear me? Okay. Today we're going to talk about environmental support and a developing brain. This is a
Professor Milkman, get a presentation on full screen, please.
The child's brain is a work in progress. It's something that develops over time. It starts out from the beginning of life. We know that brain optimization dramatically increases the probability of health and well-being throughout the lifespan.
Professor Milkman, not this mode, change your mode presentation.
Can you hear me? Can you hear me? Is it working? The slide's working?
Yes, we see you, but the presentation need other mode.
Yeah, it's in the view where we can see your next slide and your notes as well.
Oh, so let's see. So how should I change that?
Добре.
Display settings. Huh?
I mean, it's okay if you see my notes, I guess, right?
Yeah.
Okay, so
Ну, вообще мы видим презентацию.
We can see your presentation. Well, there's a problem with the stream if you don't do it full screen. It doesn't come through properly.
okay, let's try the F5.
Try the display settings, Harvey.
What should I try?
Display settings on top of the screen.
Okay.
There.
Yeah. And what should I put? What should I push?
See the choices under display settings.
Вот эти вот иконки, которые вот под большим экраном, вот эти иконки, одна из них какая-то переключатель.
There's icons at the bottom of the screen. Now please press F5.
No. Still not good.
Такой вид. Другой тогда. Давайте тот пусть будет.
There you go. Click on the display settings to see the choices.
I see see all slides.
Left. Icon left.
Hide presenter.
This one, hide presenter view.
Half monitor icon, half monitor.
There you go. Click on it.
Left.
Click on what?
Hide presenter's view. You had the choice already available for you.
Oh, hide presenter's view.
Yeah.
How about now? Is it okay now?
Ладно, пусть будет так. Сейчас из нее кроп возьмем тогда. Хорошо, пусть продолжает.
This is fine, thank you.
Okay, so it's okay now?
Yeah.
Okay, so we're talking about the developing brain. And of course, the interesting thing here is that I work in Iceland and we've done this for the last 20 years. It's amazing that 96% of all the 5 to 6-year-olds in Reykjavik participate in after-school activities. And they get a leisure card. So every family has an allocation of 500 euros per child per family to enroll their children. So 96% of all the 5 to 6-year-olds are involved in after-school activities, the ages of 4 and 5 years old. And that goes on throughout middle childhood and late childhood. So there's tremendous participation in these after-school activities. My question is, what might be happening to their developing brains? And something very extraordinary is happening in terms of how their lives have changed. So we have now this program of leisure time activities that goes from early childhood all the way into adolescence, results in, you can see on the left side of the chart, in 1998, 42% of the teenagers were getting drunk in the past 30 days, I mean, really drunk. And now it's down to 7%. We have similar patterns for smoking and cannabis. Let's start out our talk about neuroscience with Santiago Ramon y Cajal, who's the father of modern neuroscience. And he was the first one to really look at the brain and discover that the neurons are not connected, that they talk to each other by way of neurotransmitters. And then we'll also include the concept of Hebb's law, and everybody should really implant this in their mind. Neurons that fire together, wire together. And so if we create optimal situations where children are exposed to positive environments, their neurons will fire together and they will become hardwired so that these patterns will result in resilience throughout the lifespan. Brain development, the child's brain is a work in progress. and it provides a foundation for all future learning, behavior, and health. The brains are built over time. It starts out in the first days of life. The child forms 1 million new synapses every second in the first years of childhood. We know that the interaction of genes and experience shape the developing brain. And the brain's capacity for change decreases with age. And so the earlier the intervention with children, the earlier the positive environment, the more likely we are to promote healthy living. Of course, the opposite of a healthy brain is toxic stress, and toxic stress such as child abuse, neglect, mental illness in the family damages the developing brain. And so you can see here the brain is built over time. The first part of the brain that develops is the visual part. These are in the first days of life, and then hearing, language, and then throughout the childhood and into adulthood, the higher functioning develops. And so, again, Hebb's law, I want everybody to think about that. Neurons that fire together wire together. So if we provide healthy experiences, then we create healthy brain development. In the first few years of life, more than 1 million new neural connections are formed every second. The emotional and the behavioral and the thought processes and the social elements of a child's life are intertwined throughout their life, and it all is connected with healthy brain development. You can see here in this chart, again, neurons that fire together wire together. So in the first years of life, we see the development of hearing and vision, later on language, and then higher brain functions occur as we get into the early childhood and middle childhood. Of course, this chart is very significant. The brain's ability to change in response to experiences diminishes with age. So we have more plasticity, more possibility of correcting problems in living in the early days of a child's life, rather than later when it becomes much more difficult to impart changes. One thing that's been said is that I'd rather build a child than to repair an adult. So it's much easier to intervene in childhood in terms of making changes in how the brain is working. Now I'm having a little problem shifting the slide. Can you see what are you seeing on the screen now? Can you hear me?
Yes, we are seeing what are ACEs.
Okay, now you can see the toxic stress slide. So we talk about adverse childhood experiences, and those are the enemy of healthy brain development. You can see on the left, the neurons that are working properly have many connections, and on the right, they have much more defective connections. And so you have a much more compromised neuron. Adverse childhood experiences are, how do they relate to toxic stress? Well, the more a child has those, such as physical or emotional abuse, neglect, caregiver mental illness, household violence, the more the child has, the more likely they are to develop things like heart disease, diabetes, poor academic achievement. The effect is like similar to revving up a car engine for days or weeks at a time. And of course, the more adverse childhood experiences we have, the more likely it is to have very severe problems later in life. The kinds of things that can happen as a result of toxic stress, ACEs, adverse childhood experiences, problems in learning and emotion, addiction, overreactivity to possible threat, increased stress response, mental illness, physical illness, migraines and chronic pain conditions, and a compromised immune system. Of course, the antidote to that, the things that can correct that are positive relationships, encouragement, supportive environment, being responsive to the child, and teaching cognitive skills to children throughout childhood. The policy implications are a balanced approach to emotional, social, cognitive, and language development, supportive relationships. Babies' brains require stable, caring, interactive relationships with adults, and early intervention is critical. Of course, if we have specialized early interventions, we target the cause of the stress and protect the child from its consequences. Let's look at epigenetics. This is the most important new field in genetic science. And we know that environmental influences affect the expression of genes. And so during development, our genes accumulate chemical marks that determine how much or how little a gene gets expressed. And this is what epigenetics is the influence of environment on genetic expression. So different experiences arrange those chemical marks. It's not nature or nurture, it's both. And we don't ask the question, is it genetics or environment? It's both. And so you can see here the policy implications is that negative experiences or positive experiences leave an epigenetic signature on the genes. Signatures affect how easily the genes are switched on or off. And there are ways to reverse certain negative signatures, but of course, that's easier to do early in life than later. We need to support responsive relationships and reduce stress to bring about strong brains from the beginning. Quickly about neurotransmission. The brain is built on 150 billion neurons or so at birth, and they don't talk to each other except by way of neurotransmission. And in order for a neuron to fire, we need a three-way combination of neurotransmitter, enzyme, and receptor site. And we get our enzymes from our genes decide the amount and type of enzymes that we'll have. If you want to have a healthy enzymatic production, you're going to build healthy children through early environmental experiences. And we get our enzymes from our parents, from the DNA and the RNA that determines our enzymes, but how much and how fast they are produced depends on the epigenetics, the environmental configuration of how they are produced. Myelination is the next topic here. And we can see here that the cells, the protective covering of the cells are the myelin sheaths, and these help the neurons move from place to place. Let's see. The importance of myelination, that affects how fast the neurons communicate with each other. And the best way to produce healthy myelin in children is through providing experiences that allow them to explore, active involvement in play, achieving mastery or success at a task. And of course, negative influences such as neglect and social isolation can negatively alter the course of brain development. And the brain continually builds healthy myelin. Damaged myelin leads to cognitive, motor, and behavioral deficits. This brings us to probably the most important slide in this presentation. The environment can be viewed as therapy that can bolster white matter health. And so think of the environment as therapists. It's difficult to do talking therapy with 3 and 4 year olds, although obviously from the past presentation, it can be done. But, and you certainly don't want to medicate kids. So the best thing to do in terms of building healthy brains is to provide a supportive and nurturing environment, and the environment becomes the therapist. And that serves the individual and the community. In terms of middle childhood, this is where pruning occurs. The brain has a mechanism of ridding itself of neurons that are not working and not useful. And so at 15 years of age, we have a healthy distribution of neurons. And of course, we know now that probably the most important discovery in hundreds of years of research on schizophrenia, that too much pruning is connected with schizophrenia, and too little may be connected with autopsy. So again, a healthy environment creates healthy myelination and results in healthy pruning. In terms of in middle childhood, aerobic exercise is critical, and encouraging physical literacy throughout middle child improves intelligence, physical, and mental health. The amazing teenage brain, there's a mismatch in maturation of brain networks for adolescents between the limbic system and the cortex. And so the emotional part of the brain matures much more quickly than the reasoning part of the brain, and leaving teenagers open to risky behavior. And you can see here by the age of 16, the preference for risk is so much higher than it is at other parts in the child's life. And so this is where you can see this comic slide. I can totally get away with this. And you can see teenagers are much more prone to risky behavior during this particular part of life. The healthy environment is the best therapist. And we know that neuroplasticity, the brain's ability to change in response to constructive dialogue between parents and teens, is critical. And so about issues such as freedoms and responsibilities, educators have the opportunity to affect the way that children learn and play, particularly through computers. And the skill of future development will be to critically evaluate a vast amount of data. Educators need to challenge the adolescent brain by training its plasticity on the demands of the digital age. Which brings us to the antidote to toxic stress and adverse childhood experiences, and those are natural highs. And so current research suggests that particularly during middle childhood and adolescence, marijuana and other drugs affect brain development. And it can cause abnormalities in brain functioning, including poor neurocognitive performance, white matter quality, and changes in brain volume. And so when people begin using marijuana early and as teenagers, it can affect how the brain builds connections. The antidote, again, is natural highs. And we know that there are natural chemicals within the brain that allow us to feel good and feel us responsible and healthy in our environment. So we have a movement here in the United States in several cities and certainly many municipalities to introduce the concept of natural highs, particularly in adolescence. And a lot of teenagers love learning about the brain. Natural highs are self-induced changes in brain chemistry that involves natural induction of chemicals like dopamine or norepinephrine or serotonin that result in positive feeling states and health and well-being for the individual and society. The Ethiopian proverb, when spider webs unite, they can tie up a lion. So if we combine psychology, biology, and sociology, we can introduce the concept of natural highs through the media, the schools, the parents, and all the other stakeholders. The take-home messages from this talk: neurons that fire together, wire together. Let's give kids healthy environments so that neurons are firing properly. In the first few seconds of life, 1 million new neural connections are formed every second. It's better to build a child than to repair an adult. The science of epigenetics informs us that genes are not destiny, that we can create environmental circumstances where genetic expression can be positive. There are 3 kinds of experiences that promote healthy brain development: exploration, active involvement in play, and achievement of mastery. These are the things that parents should be taught to do throughout early and middle childhood. The environment can be viewed as a therapy that can bolster gray and white matter health. Natural highs are better than drugs, and teens have a special opportunity to optimize their brain according to their choosing for a data-rich future, dramatically different from the life. They can create circumstances where neurons are firing together and wiring together in view of the computer age. The last is a slide, shows an Icelandic proverb. We've had so much good work in Iceland with a healthy environment. It's too late to cover the well when the child has fallen into it. And we say in Iceland, thank you very much, takk fyrir. It's been a pleasure and an honor to be here.
Большое спасибо.
Thank you very much, Professor Milkman. So our next presentation is going to be delivered by Dr. Ben Furman, co-director of the Helsinki Breathe Therapy Institute in Finland. And the name of the report is Skillful Class, a playful and solution-focused and evidence-based social skills learning project for elementary school classes to improve the atmosphere of the class, reduce stress of the teacher, and exchange learning, enhance learning. Please, Professor Furman, the floor is yours.
Oh, thank you so much. It's been interesting to listen to all the presenters. My name is Ben Furman. I come from Helsinki, Finland, and it's great to be in this international group. I will put my phone on so I know how many minutes I have. My subject is how to work with a whole class to improve the mental health of the class. And I would like to point out that I am especially interested in the mental health of the teacher. Because if the mental health of the teacher is good, it will have an effect on the children too, all over the world. Also here in Finland, which is a country famous for good education, a lot of teachers are complaining that they are tired of their work. They want to change professions. They want to stop being a teacher. They are super stressed by their work, and they are complaining that the children are difficult, that the atmosphere of the class is not good, that the children are fighting with each other, that they have all kinds of problems, and they are tired of working as teachers. They would like to work with something else. And many are leaving the field. We're already experiencing in some countries situations in which it's difficult to find teachers to teach the children. We all know that inclusion is a tsunami that is going around the whole world, where all the troubled children, all the difficult children come to the normal classes, and the teachers now are super stressed because they don't know how to handle these difficult children. I am a psychiatrist, and I have always been interested in developing ideas of how to work efficiently with children. So here in Finland, we developed already 25 years ago, I will show you some slides, a method that we call, in English, kids skills. And kids skills, you can learn about kids skills through the kids skills website. There's a video with the Russian subtitles, an English video on YouTube with Russian subtitles. There is a Russian book that has been also translated to many other languages, so about 20 languages. There is a free of charge computer program or app that you can download to your iPhone or to your Android phone, and it's free, and it is also in very many languages. You can have it in Russian, you can have it, of course, in Finnish language, but you can also have it in English and in many other languages. And this is a very simple way of learning the idea of kids skills. And I can, of course, tell you also the idea. It's a simple idea. When we work with children using kids skills, we don't talk about problems. We do, as if we have heard some other people already speak today, we talk about skills that children need to learn. I like to say that behind every defect, behind every pathology, behind every problem, behind every diagnosis, there is a skill that the child can learn to overcome the problem that the child is suffering from. The app will help you to think about what skill the child needs to develop in order to overcome the problem. So many teachers over the years have been asking me, how can I do this kids skills program, this learning skills program, which is very similar to CBT? How can I do it with the whole class, not only with individual children who have some problems, but the whole class? And some years ago, we developed an application of kids' skills to work with the whole class. And this intervention that we call skillful class has been researched in Russia, in Finland, in China, and it's been tried in many countries around the world. There is a manual of how to do it, and it is a project that the teacher, not a psychologist, not a social worker, but the teacher herself does with the whole class. You can find a video on my YouTube channel about this approach, and the video is with subtitles in many different languages: Spanish, English, Russian, Finnish. And there is research about this program when we study such things as the atmosphere of the class, if the children are helping each other, shall we say, meta skills. The children are learning practical skills, but we are more interested in meta skills. Meta skills? What is meta skills? Meta skills are social skills, like being on time when the school starts, helping each other, able to ask for help. If you need some help, you can go to another child. How to work as a team. So when we have done the project, we are interested to find out if the meta skills have improved, because if the meta skills of the class improves, that means that the atmosphere of the class improves, which means that the teacher is happier. See, most people, when they think about mental health, they think about the mental health of the children. But I think we should think about the mental health of the teacher, because a happy teacher is able to deal with the different problems that there are in the classroom and stays. The unhappy teacher will leave, and the children are without the teacher, and they have a new teacher and a new teacher and a new teacher, which is not good for the mental health of the children. So let's seriously start to think about the mental health of the teacher if we want to care about the mental health of the children. Anyways, I can quickly give you a little idea of what the program is all about. The Kids Skills program is all about stopping to talk about problems and talking about skills instead. It's a 15-step program where you make an agreement with the child about a skill to learn. You have a discussion with the child about why this is a good skill to learn. Children give a name to their skill. Children have supporters, fantasy supporters. They have real supporters like their parents and their teacher and their friends. They boost their optimism to learn skills, and you celebrate when they have learned their skill. There are more steps to kids skills, but I will jump to telling you about how to use this program with the whole class, which was my topic. And to use it with the whole class, you start by letting the children choose. The children choose. This is different. Now is not the teacher choosing, now is the children choosing. Why the children are choosing? Because if they choose a skill to learn, a collective skill to learn, they are more motivated to learn it. So look at this picture and you can see packing your school bag so you don't miss any books or any notebooks or pens, solving your own conflicts. I can use my, so this one, this boy here is helping the two others, to solve a conflict. This is a very important skill for children to learn, and the children decide which one of these skills they want to learn. This is, of course, making your home, taking care of your homework. This one is listening to the teacher when the teacher is speaking and not making noise while the teacher is giving advice. This one means calming down for lessons, calming down for lessons, because it can take a long time before the lesson can start because children make so much noise. And this one, everybody knows what this one is, raising your hand to speak. Very important skill. These are collective skills. But in addition to collective skills, when the children have succeeded to learn a skill, let's say the children say, we want to learn to become better at listening to the teacher. Then the program is about 2 weeks, maybe 3 weeks. And when the children have mastered this skill, then they move on in the program, and they can only do the program with the permission from the rector, the headmaster, the head teacher of the school. Once they have cleared the first part of the kids skills of the skillful class program, they can start to learn their own skills, their individual skills, their private skills. And there are many private skills that they can learn. Again, the children choose the skill they want to learn. The teacher does not tell the child what skill to learn, and they can choose one skill from 22 different skills. Each skill comes with a picture. So the children look at the pictures, they make a self-evaluation from 1 to 5, 1 to 10, and they decide which skill they want to learn. Here are some examples of what I mean when I say skill. This skill, for example, has been very popular. It is to give a compliment to another child, or to the teacher, even better, or to your parents. That's also good. But to learn to give compliments is a very important skill in developing good atmosphere in the class where the children are helping, supporting, and encouraging each other. I'll show you a few more. Concentration skill is very important for children. When they start to do something, their work, maybe they take their phone all the time and they are already, doing their WhatsApp. Learning to put your phone away and to finish your homework is a very important skill for children. Some skills are very common, like learning to eat nicely. Some children disturb when they should be eating. They don't eat, or they throw food, or they make noise when they are eating and disturbing everybody else. Encouraging others, a little bit different from giving compliments, but also very important skill. Many children have difficulties in making mistakes. When they make a little mistake, they go crazy. I cannot do anything. They react hysterically to mistakes. Learning to make mistakes and to be able to say, it doesn't matter. Nobody can succeed every time. Nobody can be perfect is an important skill for children to learn. I maybe mentioned to you, helping others is a very important skill. And when we have looked at what skills children choose to learn, what is their favorite, some of their favorite skills. So this one, you know what it means. You are there and the others are in a little group and they are doing something and you want to join the group. It's a very important skill to learn how to join other children when the other children are playing something or they're working in some way. You can see the picture, you can know what skill this is. Learning to listen without starting to talk, without interrupting others. Some children from small families, they are so used to be talking all the time that they have never learned that they also have to listen to other people and not always be the one who is speaking. Okay, I think you got the picture. I think you got the idea. When here is one more skill that is very important for children. You cannot always be the winner. You also have to learn to be number 2 and number 3 and maybe number 10 sometimes. And here is one of the favorite skills that many children have found important, and it is when you are bullied, when you are being bullied, when other children say you are stupid, you are an idiot, you are crazy, then you have to learn to answer back. Not always saying anything, but in your mind, to be strong. It is a resiliency skill, an important resiliency skill that actually all children need. And we are trying to do our best to make bullying disappear from the world, but it is impossible. There will always be bullying. Therefore, children also need to develop some strength, some resiliency in face of bullying. I think I have told you enough of this method. You can also guess that there is a skill on the list of children learning to speak in front of the class. Did we not hear an interesting talk about children's anxiety? Yes, every anxiety, we can turn it around and we can create a skill out of it. And this is the most common anxiety of children. They are so afraid to speak in front of the class. But many children, when they are allowed to choose what skill you want to learn, this is the skill they choose. Needless to say, in this approach, the children are helping each other. This is a peer support method where children are divided into small groups, and inside the groups they support and they give a lot of help to each other to learn those skills that they have decided to learn. It all ends in a celebration and a party, and there are many different teachers have developed different methods of rewarding the children for learning their skills. Here is a picture of one of the methods. Maybe you can guess what it means when the children tell the teacher in front of the class what progress they have made. The teacher puts one macaroni into the jar, and when the jar is full, there will be a surprise for the whole family. I will be happy to share with you my PowerPoint presentation, so I will send it to the organizer, and you can, with one click, you can see videos and you can find the literature about this method. Thank you very much for your attention.
Алло, ваш микрофон. Алло, ваш микрофон.
Anna.
Alla, your microphone is off. We can't hear you. Thank you so much. Thank you so much for such an interesting presentation. Unfortunately, we have no time for the Q&A. We have lots of them, but unfortunately, we don't have much time. Perhaps there'll be some time after we go through all of the presentations. And our next presenter for today is Professor Natalia Sirota, MD, Professor and Dean of the Faculty of Clinical Psychology, head of the Department of Clinical Psychology at the Yevdokimov Moscow State Medical and Dental University of the Ministry of Health of the Russian Federation. And she's going to talk about the prevention of behavioral disorders in the educational setting. Natalia, please, the floor is yours. Good evening, dear colleagues. It's my great pleasure to welcome all of you. And I will happily share my view on the universal and selective prevention of behavioral disorders in an educational setting. I have to say that my experience in this area has led me to believe that people that work in the field think about similarly about what this prevention should be like. The key question is about the strategies. So the strategies for implementing prevention mechanism across various contexts, countries, cities, etc. Our findings is something that I wanted to share with you today. At this point, a lot has changed, and we all know that new problems are emerging, problems with suicidal behaviors, drug abuse, although, well, these have been around for a while, like gambling, gaming, all types of technological dependencies, particularly characteristic for the current day. There is a combination of chemical and non-chemical addictions, and these are often comorbid with mental disorders, which aggravates the situation.
So our current challenges have been defined by the above. As applied to prevention, these new methods are already being included into prevention strategies. This includes theoretical approaches for universal and selective prevention for behavioral disorders, including our original model. This includes integration of trans-theoretical model on changing behavior, motivational interviews, and advanced approaches in motivational interviews as well, which of course includes CBT and its various elements. And last but not least, we have development of program for universal and selective prevention, differentiated by age, from childhood to young adults, all with the view to ensure positive development of the next generation. A preventative strategy means that you develop and implement a system of programs for positive prevention, aimed at strengthening the coping resources and coping strategies in kids to cope with individual, social, and family stressors that are far beyond our control, obviously. So improvement of coping strategies in kids, parents, educators, and caregivers becomes one of the key ways we can further these programs. The second component is motivation strategy to support constant, effective, and positive change. Because this is about growth, this is about development, and it's not only for the child, not only the child or the student is changed, this affects their parents, their educators, and the social environment as a whole. Then we have a strategy of CBT-based interventions, where we work with at-risk groups in line of our selective prevention efforts. Positive cognitive and behavioral development as an approach focuses on the potential of positive formation of effective coping strategies, as well as moral values in the kids and in the members of their environment. It also means that the range of interests is developed to enable their comprehensive development as a person. We've been working in this approach for a number of years now, so we've collected evidence to validate the efficacy of the preventative treatments that we have developed and implemented. Efficacy evidence for our prevention comes not just from ourselves, but from researchers of prevention, third-party researchers. And here are the factors that must be accounted for if your program is to be successful. Strengthening of interpersonal links of attachment, higher resilience to challenges, higher competency, social, emotional, cognitive, behavioral, and moral. Then cultivation of self-identification and self-determination, development of self-effectiveness, improved spirituality, improved outlook into the future, improved of a clear and positive identity, recognition of positive behaviors, giving opportunities for pro-social behavior, and last but not least, fostering pro-social norms. So in light of this, we design our prevention programs that I'll be highlighting later. Another pillar for us is the theoretical model by Ralph Schwarzer. This model says that cognitive behavioral mechanisms need to be developed if we want to change risk behavior to healthy behavior, if we want to make a change from high-level behavior, from low-level behavior, to high-level behavior. And I'd like to say a couple of words about this model. It is very important to understand that in order to change your behavior, you need to make a huge leap. It's indeed a leap from risk to health. It's not easy for a child, not easy for an adolescent, so they need to be supported. Now, we need to make people recognize of risks for health so that risky behaviors can be eliminated. We need to help with the recognition and understanding of the goals that the child or an adolescent needs to attain. Why change at all? Then we need to identify barriers that the child will face. This comes in the form of a coping plan, actualization of coping resources. And then we have development of self-directed effectiveness. Basically, the confidence that together with the kid, we will succeed. So this means that we have enough emotional, cognitive, behavioral, and social resources to effect that change. This is a must for your selective prevention program, otherwise the program will not work. Now, here are a few of the programs that we have been developing. Some are universal, so prevention for all, age groups 7 to 9, 10 to 13, and 14 to 16. And then we have programs that are both universal and selective. These are for at-risk kids as well. So we have live water, a vessel, and a way home. Each of the program contains more than 20 sessions that explain different basic values, life, happiness, freedom, health, disease, things like that. I don't think I have to name them all. These programs have been long in the making: concept work, validation, piloting, larger trials, and then actual implementation based on actual schools. So, spiritually oriented program for universal prevention aim to build healthy person, a healthy person that is capable of structuring their spiritual life in line with their spiritual values. This also means that they need to be skilled in communication, in relationship building, based on mutual understanding, cooperation, and their self-identity as a unique person with their own views and beliefs. These are skills of acceptance, acceptance of others as another unique individual, principles of help and mutual help, skills of taking responsibility for your own acts and for your own life. That's you are building with your own hands, in a sense. Our programs have personal trainings, discussions, role plays, psychodrama, psychogymnastics, narrative-based therapy, CBT elements, motivational interviewing. So this all comes together to create an environment for a personal transformation for the participants in the context of the changes that they undergo. It's a lot of sessions that take place once per week, about 90 minutes each. So it takes about a year to go through the program. So here is one program. Its name is a play on words in Russian, to be at ease with yourself. It's a newer program. So the name is informed with this idea of self-acceptance. Its content is centered around certain existential categories, moral categories like family, love, life, friendship, values, goals, the good, the evil, tolerance, acceptance, stigmatization, loneliness, health, disease, happiness, and things like that. And then each of the session unfolds as a huge game which takes place throughout the year. And this is for school kids. For younger kids, younger school kids, we have a huge role play that takes place over here as well. It's called Living Water or Life-Giving Water. It's a narrative of a fairy tale, an adventure there you have to actually save the humanity. In order to do that, you need to collect the fragments of a key that have been scattered all across the world. It's a tall task, it's a noble task, and you have to collect 26 pieces, nicely matching the 26 sessions that we have. So this program is ongoing. The next program also takes at least a year. It's aimed at university and college students. It's called Your Way Home, and it aims to prevent socially hazardous phenomena among young people. Another aim of this program is to instill into the next generation the concepts of family building, parenting, the attitudes towards their future kids, all based on moral values, like personal maturity and openness to responsibility that comes with family, starting a family and parenting. Now, briefly on programs that have been in place for a long time, so tried and true programs for younger children called SHIP. It's been proven quite successful. Then we have that other program where the narrative is built around travel. We go from the city of feelings to the city of happiness, for example, and then it takes 16 sessions. You can see them in the slide. And it's a sailing trip. The kids build their boat themselves, and every day we arrive to New Harbor, the city of feelings. Then we are taken away by the wind of surprise to the island of fear, into the vortex of anxiety, the triangle of misunderstanding, the whirlpool of offense, and the rest of it. The rain of guilt, the isle of sadness, the iceberg of neglect, the sea of anger, the Isle of Happiness, and then you have the closing session. For preschoolers or elementary schoolers, it's a training vehicle to cope with all these stressors. It's a group activity. It's supervised by facilitators. These are specially trained psychologists. There is a map, and that's the journey. So they take a boat and they fill the map to trace the program.
Программа для детей 11-13 лет «Поддержка».
This is a program that's called Support, young age group 11-13. But it's not only about support. It provides some information, cognitive development, personal resource development, and it also builds strategies for high cognitive functioning. So it's another program to build coping skills. Then there is a point support program, age group 14 to 16, 24 trainings, and that's to build healthy lifestyles. Takes place 1 or 2 times per week. It's aimed at building a healthy lifestyle, fostering fortified personal resources, behavioral strategies that prevent misadjusted behaviors. So this has been our programs that I wanted to tell you about. The former 3 have been trialed. Their efficacy has been proven. So PhD theses on them have been written and defended. 3 of the programs are carried out together with the Russian Orthodox Church, and they're being trialed across Russia in different regions. In closing, I'd like to say this. This is far from enough. Designing a program, trialing it, validating it, and implementing it in this school or some other school. The effect from these programs is validated, right? Evidence-based program will take effect only if they are rolled out widely on a large area, at least within one city or a region, and is preferably nationwide. Then we'll be able to actually discuss effects. If it's a once-off in some institution, this doesn't mean that it's going to be the same smooth sailing in some other place. So the next step for us strategically should be, I think, expansion of our coverage with these programs, so that more and more areas and institutions in Russia take him up. Thank you for your attention. Thank you, Professor Sirola. So I think I'll have to present the next report. It is going to be delivered by Senior Researcher of the Department on Adolescent Psychiatry at the Federal State Research Center for Mental Health in Russia, Dr. Anna Golovina, which means myself, an MD, Senior Researcher for Adolescent Psychiatry. And this report is titled Prospects for the Prevention of Mental Disorders in Childhood. Can you see my slides?
Prospects of preventing mental disorders in children.
Вас слышно? Включите, пожалуйста, показ слайдов, чтобы в трансляцию.
Could you please have your presentation in full screen mode? I think it's in full screen mode, isn't it?
Нет, показ слайдов.
It has to be full screen for the stream to work properly. So I think that's full screen. What else can I do?
Нет, вот сверху в меню показ слайдов.
Вот. Почему-то она приостановлена.
For some reason, it's not working. Can you see my screen?
Да, мы видим.
Yes, we can see your presentation, but for it to work in the stream, you need to make it full screen. But wait a second.
Нет. Не работает. Сейчас.
It's not working.
Дополнительно, может быть, нет. Не хочет она.
For some reason, it's not working. Can you try F5?
Так, есть?
Is it better? Are there any changes?
Нет?
No?
Нет, не произошло.
No changes.
Я нажала на клавишу F5.
Well, I pressed F5. Perhaps I should restart the screen share. What can I do? Nothing seems to be happening.
Так, что делать?
What should I do?
Нет.
No.
Ну что,
Давайте
читать?
оставим так тогда. Да.
Okay, let's leave it like this.
Значит, прошу прощения за
Okay, apologies for this technical hiccup. All of the psychiatrists that deal with issues of teenage and child psychology are faced with the question of preventing mental disorders as early as is possible. Despite multiple research in the field, nonetheless, there is no single answer to the question of how to go about the prevention of mental disorders. There is no systematic approach available. On this slide, I wanted to present a number of factors that are predisposing to the development of mental pathologies, including molecular genetic factors when they play out, or inflammations, among others, lead to disorders, unfortunately, in the structures of the growing brain. These include socio-demographical factors, environmental factors, stress factors, intoxication factors, early organic pathology of the central neural system with long-term hypoxia. For these two factors, the environment and the molecular genetic, they account for the bulk of mental disorders. Nonetheless, personal pathologies, cognitive failures that exist from birth or play out pressured by external factors such as COVID, for instance. So there is a shift in the personality traits, which unfortunately additionally leads to mental disorders in children and teenagers. Cognitive failure that could have existed initially, i.e. innate, or it could have manifested itself due to the impact of various factors. So this is something that's still an open-end question, but nonetheless, and in this respect, the question on the prevention of mental pathologies is raised. We're talking about primary prevention measures at the level of the population. It's aimed at the general population at large, talking about vaccination in line with med schedules, correct pregnancy support, childbirth support, the prevention of obstetric complications, taking folic acid and omega-3 fat acids. There's also primary selective prevention, which is targeted at selected groups so that are at a higher risk of mental disorders. And there is targeted preventive interventions for the high-risk categories. For instance, like a high risk of schizophrenic disorders with signs of a developing psychotic pathology. Not so really prevention anymore, but nonetheless. The question comes up on the age periods, the targets of population prevention of mental pathology, because across various age groups, these will be different impacts. We need to start with the preconception stage by monitoring the mother's health. We need to promote values of a healthy lifestyle among future mothers and the vaccines that I talked about before. Intrauterine development, early postnatal periods, prenatal fetal health aimed at preserving the prenatal health of the fetus at various stages of the pregnancy, impacting intrauterine of the fetal and 7 days after the birth. This is when the baby is at a high risk, not of just an organic pathology, but also schizophrenic and affective psychosis, and this has been proven. And disorders in gender identification, which is particularly relevant today for kids and teenagers, unfortunately. And as weird as it might seem, for neural anorexia. When we talk about the early childhood age, we're talking about prevention of infection. And in the context of COVID, this is something that needs to be expanded to cover all of the stages, all of the age groups, all of the stages in the child's development. A secondary childhood with the start of school, key focus is placed on preventing cognitive deficits and bullying. And the period of adolescence is focused on preventing the development of chemical and non-chemical addictions. And even the use of any psychoactive substances that, again, for our potential patients, they create a very high percentage of an increase in manifestations of psychosis. And alongside the addictions themselves, like depression and suicidal inclinations and just psychosis, These lengthy psychoses with a very polymorphic and unfavorable clinical manifestation, and they are very difficult to cure. And now let's talk about something that's very actively researched by psychologists and neuropsychologists and psychiatrists, cognitive dysfunction. Cognitive dysfunction is considered to be the basis of a lot of mental disorders. This is the basis for their development. It occurs during critical periods of a child's development, reflecting disturbances in neuroplasticity. It's characterized by the coexistence of hyperactivity of the corresponding brain structures and includes a variety of deficits, as well as specificity of emotional response and information analysis and synthesis by the patient. This is a schematic a representation of the cognitive dysfunction and the most common deficits. Because we don't have time, I'm not going to go over them. But I wanted to just indicate that these are displayed in patients that we treat, and they're formerly healthy relatives and close ones, which leads us to believe that it's necessary to extend our efforts, our preventive efforts, not just to cover the future mothers and the children themselves, but also the relatives, the close ones that are within the risk group. Individualized early interventions are, of course, necessary, and I would like to enumerate them by saying that they're not listed, they're not ranked time-wise, but rather by the methods that would be used to treat them. Psychopharmacotherapy, this is a secondary treatment methods. Antidepressants or antipsychotics is not something that can be used as a preventive method. We can only do this vis-a-vis a high-risk group with manifested psychosis, or, for instance, a depression that's already clearly manifested. Non-specialized pharmacotherapy, this is anti-inflammatory drugs that have an impact on the substrate, the one that leads to mental disorders. Nutrition, nootropics and vitamins. Then psychoeducation focused on the patient and their environment. By the environment, we mean it's in a wide sense, not just the family, but the teaching staff and the interns and our colleagues that deal with the patient. Differentiated, individualized methods. This is trying to use various types of sensory information, such as olfactory impact or visual impact, audio impact, stimulating speech development. The speech development stimulation has to be very active so that at the subsequent stages, we can avoid issues with communication trainings and cognitive remediation. Our colleagues that worked with complex patients, they know about this method very well. We are also well familiar with it, but for kids and teens, unfortunately, this has not been implemented into practice, or at least not widely enough. What is cognitive remediation? It's interventions aimed at restoring or improving cognitive functions through trainings or the use of acquired skills in a social setting. Neurally based efficiency of the method is the correction of neural network dysfunctions. So it has a very specific biological basis, in fact, and the target of cognitive remediation is the restoration of neuroplasticity, or the improvement of its quality, if I can put it that way. The types of cognitive remediation can vary. It could be isolated types aimed at training the individual components of a cognitive profile, complex cognitive remediation, targeting cognitive functioning in general, socializing types aimed at teaching social skills, are systemic, which combine cognitive and socializing trainings. What are the benefits of cognitive remediation? Well, there's a possibility of conducting it both in a traditional format and with the use of computer technologies, not just online, but in 3D, with all sorts of technology, diverse and attractive ways of presenting information, attractive for children and adolescents. And there is no time limit. The possibility of getting quantitative step-by-step and general objective evaluations and stable impact and a positive result. During the pandemic, cognitive remediation helps us to offer support remotely, but there's another method. This is not a stigmatized method, unlike psychopharmacology, but even psychotherapeutic methods are stigmatized. They lead to certain concern on behalf of our young patients and their parents and closed ones. Cognitive remediation, on the other hand, when you explain the benefits of the method and the concept, it's not rejected. It does not lead to any concerns. Of course, there are some undesirable effects of cognitive remediation. It's possible introversion when computer technology is not controlled properly, restriction of communication and functioning in everyday life, preference of communication with a virtual specialist versus real life activities. So if in real life people increased load on visual analyzers due to long work over the computer. All of these potential undesirable effects are easily preventable because, while they need to be factored in, and this needs to be talked over with the parents and with the young patient to explain that there are certain constraints and limitations to the use of this method. At this, I will end my presentation. Thank you so much for your attention. So, unfortunately, I can't see the presenters. I guess I've disabled my screen. I changed my view somehow. So, well, at this, I would like to wrap up with today's session. Am I still on air? Can you hear me? Yes, we can hear you. I would like to summarize today's events as follows. All of the problems that we've been discussing today are, of course, highly relevant and significant for our patients or those that can potentially become our patients and that interact with psychologists, psychiatrists, and the pedagogical staff. Life is constantly going forward, evolving, and we keep coming up against unexpected challenges. One of such challenges, well, the main challenge for now that we have to deal with is having to live in the context of COVID-19. I think that at least 4 of today's presenters are already working on helping and supporting children and teenagers to adjust to the pandemic context. because, of course, mental health of the groups that we work with, the age groups that we specialize in, is going to deteriorate significantly. It's already deteriorating significantly, and we can see that in our research. And if we're not going to interfere in terms of adjusting our programs, in terms of helping teenagers get around social isolation, in terms of offering more extended mental support, in terms of preventing addictions and abuse, drug abuse, in a situation when there are no more opportunities open to them in terms of how to pass their free time, then we would see very pessimistic consequences in this not so bright new world that we now have to exist in. Our efforts alongside the known methods, the known approaches confirmed by preliminary data need to be supplemented by additional efforts. There is no other way, because the children are our future. And we need to make sure that they are offered the best quality of life possible, the best conditions for education, development, and life in general. I would like to ask my co-chair whether he wants to say something to wrap up with our session.
Поскольку я не вижу реакции, не слышу, то,
I'm not hearing any response. Oh, Professor Chadel left the call. Okay. So he had to leave, which means that we have a couple more minutes. So let's open the floor for any questions that you might have, so that we'll be able to take them if there is an opportunity. Please address your question specifically to the reporter or the speaker that you want to hear from. If there are none, then I'll have to wrap it up. Thank you all. Thank you for your participation. Even if the load has increased dramatically recently, you still found the time to take part in this event today. Thank you for your presentations. They've been really fascinating. Unfortunately, we had really strict timing, so as a co-chair, I had to rush you along sometimes and call your timing, but hopefully it's not the last time for us to convene together. And for today, with your permission, I will close this session. Thank you once again.
Спасибо, всего доброго.
Thank you, everybody.
You.
Из эфира.